heart defects plus valvular heart diseases, aortic regurgitation, Kawasaki disease, gull, acute rheumatic fever, ul. Myocarditis, ul. Hypertrophic cardiomyopathy, TIM, infective endocarditis, gull, a. Cardiopulmonary resuscitation, cardiopulmonary resuscitation in newborns and children, supraventricular tachycardia, TAE, long QT syndrome. At GN9 Home Library lists settings. X. Cardiovascular examination. The cardiovascular examination is an essential cardiological tool that comprises the assessment of vital signs and jugular venous pulse, chest inspection and palpation, and, most importantly, auscultation of the heart. For specific auscultatory findings in valvular heart disease, see auscultation in valvular defects. For specific auscultatory findings of heart defects, see congenital heart defects. Details regarding the specific signs and symptoms of cardiovascular disease can be found via the links provided below. History and general examination. History. Dyspnea, chest pain, see cardiovascular causes of chest pain, palpitations, an unpleasant awareness of one's own heartbeat, can feel like a fluttering or pounding in the chest, one syncope, hemoptysis, edema, fatigue, claudication. General examination. 1. Appearance. Level of consciousness and syndromic features, example in trisomy 21, trisomy 18, associated with congenital heart defects, features of rheumatic fever, migrating polyarthritis, erythema marginatum, subcutaneous nodules, trademark features of left-sided heart failure, scent features of right-sided heart failure. Skin and mucous membranes. Scent color changes, copyright central cyanosis, see features of cyanotic congenital heart defects and congestive heart failure, copyright pallor, anemia, copyright plethora, polycythemia, scent xanthomas, dyslipidemia, scent dehydration, scent temperature. Hands. Scent perfusion, O temperature, copyright capillary refill time, O peripheral cyanosis. Palms, ossular nodes, Janeway lesions, see clinical features of infective endocarditis, scent nails, clubbing, splinter hemorrhages. A. Face. Scent general, copyright malar flush, 1 copyright swollen face, eyes equals QL. Collapse, fine text outline. Eyes degree, xanthelasmas, arcus lipoides, cornea, dyslipidemia, trademark O hypertensive retinopathy, ophthalmologic examination, scent mouth, copyright poor dental health, O high arched palate, Marfan syndrome. Neck. Scent carotid pulse, jugular venous pressure, see clinical assessment of jugular venous pressure. Other. Scent lung bases, pulmonary edema, scent lower limbs, O peripheral edema, copyright signs of venous insufficiency, M plus signs of stroke. O your notes. 4 shared notes. Lee blood pressure. Approach. 1. 1. The patient should sit for several minutes before blood pressure is measured. 2. Use the correct cuff size. 3. Ask the patient to rest the arm on a horizontal surface at the level of the heart. 4. Record the pressure in both arms and note any differences. 5. Determine the systolic and diastolic blood pressure value, example auscultatory method using Korokov sounds over the brachial artery. 6. Repeat measurement. A. 24-hour ambulatory blood pressure measurement can be helpful in establishing the average and peak blood pressure values during daily activities. Interpretation. Scent Korokov sounds, copyright definition, sounds heard when auscultating over the brachial artery during sphygmomanometry, copyright origin, turbulent blood flow through a brachial artery that is partially compressed by the inflated arm cuff of a sphygmomanometer, copyright interpretation, when deflating the cuff, the pressure at which Korokov sounds appear marks systolic BP, and the pressure at which Korokov sounds disappear marks diastolic BP. Cent normal blood pressure. Copyright systolic blood pressure. O systolic blood pressure to 130 mm Hg and / or a diastolic blood pressure equals 80 mm Hg. 3 Copyright C. Diagnosis of hypertension. Sources of errors in blood pressure measurement. 4 equals QL. Collapse. Find text outline. XX cardiovascular examination. Sources of errors in blood pressure measurement. Cent incorrect positioning. Cent white coat hypertension. Cent Menkeberg arteriosclerosis. 5 Cent incorrect cuff size. Auscultatory gap. Copyright Korokov sounds between systolic and diastolic blood pressures sometimes diminish or disappear, presumably due to increased arterial stiffness in hypertensive patients. O when the cuff is insufficiently pumped, i.e., below systolic blood pressure, the first appearance of Korokov sounds is misinterpreted as systolic blood pressure, a falsely low reading. Copyright the falsely low reading can be prevented by simultaneously palpating the radial pulse on the arm in which blood pressure is measured. VA. FA, CES. Lee jugular venous pressure. Jugular venous pressure, JVP, can be used to estimate central venous pressure, CVP, and provides information about fluid status and cardiac function. Approach. 1. The patient should be in the supine position, torso elevated to 45 degrees, with the head extended backward and turned to the left. Identify the venous pulsation of the internal jugular vein and evaluate the following. Copyright the height of the internal jugular venous filling pressure, by measuring it from the sternal angle O. Estimation of the CVP obtained by adding 5 cm to the JVP height O. The character of the JVP, by assessing JVP waves. Hepatojugular reflux should be tested if JVP cannot be assessed properly. Interpretation 11. Height. Cent elevated JVP, 4 cm filling level of the internal jugular vein above the sternal notch. Signs of an elevated JVP. O jugular venous distension. O small sign, distension of the jugular veins during inspiration due to the negative intrathoracic pressure that attempts to pull blood into the right heart, which is restricted by non-compliant pericardium or myocardium, example constrictive pericarditis, restrictive cardiomyopathy, right atrial tumors, ventricular tumors, right HF, massive. PE, 161. O hepatojugular reflux. Causes of elevated JVP. Right heart failure, fluid overload, tricuspid valve dysfunction, pericardial effusion, constrictive pericarditis, cardiac tamponade, SVC syndrome, pulmonary hypertension. Degree. Character. A normal JVP waveform consists of 3 waves, A, C, V, and 2 descents, X, Y. JVP waves and abnormalities. Wave description. Abnormalities. A wave. Copyright the first peak caused by atrial contraction *, absent in atrial fibrillation. * the second peak caused by tricuspid valve closure, contraction of the right ventricle, and bulging of the tricuspid valve into the * wave. 1. Severe tricuspid valve. C wave, MES right atrium regurgitation. * absent in, descent degree. A drop in JVP caused by atrial relaxation. Copyright tricuspid valve regurgitation degree. Right heart failure. Equals QL. Collapse. Find text outline. Wave *, the third peak caused by venous refilling of the right atrium against the closed tricuspid valve. Y *, a drop in JVP caused by decreased right atrial pressure as blood flows into the right ventricle after opening of the tricuspid valve. Descent of equals INE on T O FOSU. Lee pulses. A pulse wave is produced by ventricular contraction during systole. Approach 1 pound. * 3-finger method, palpation with tips of the 2, 3, and 4 fingers. Prominent in, copyright tricuspid valve regurgitation. Copyright right heart failure. Prominent in, 17 Copyright tricuspid valve regurgitation. Copyright constrictive pericarditis absent in degree. Cardiac tamponade. Copyright tricuspid valve stenosis. Scent. Palpate the common carotid artery, radial artery, abdominal aorta, femoral artery, popliteal artery, tibialis posterior artery, and dorsalis pedis artery. The carotid artery pulse should never be palpated at the same time bilaterally. 8 Copyright risk of compression of vessels. Cerebral hypoperfusion. Syncope or risk of hyperstimulation of the carotid sinus reflex. Bradycardia/low blood pressure. Cerebral hypoperfusion. Syncope. And the thumb of the examiner should never be used to take the pulse because its own strong pulse might be mistaken for the patient's pulse. Palpation. 11. The pulse should be assessed for rate, rhythm, character, volume, the speed of upstroke, and delay. Pulse characteristics. Rate. Rhythm. Palpation of the arterial pulse. Description. Bradycardia, 100 bpm. See also normal vital signs at rest for all age groups. Regular, the interval between individual pulse waves remains consistent. Regularly irregular pulse, the interval between individual pulse waves varies in a consistent pattern, i.e., there is a pattern to the irregularity. Irregularly irregular pulse, a pulse in which the interval between individual pulse waves varies with no consistent pattern. Pulse deficit, the difference between the pulse rate, measured by cardiac auscultation, and the peripheral pulse rate, obtained by palpating the radial artery for 1 minute. Pulsus minus, a regularly irregular rhythm in which 2 heartbeats occur in rapid succession followed by a gap. The usual pattern is high volume pulse, low volume pulse, delay, repeat. Hyperkinetic pulse, pulsus altus bounding pulse, water hammer pulse. Copyright bounding pulse with a rapid upstroke followed by a prompt collapse of the vessel. A degree referred to as Corrigan pulse when present in the carotid artery. Artery Traub sign, pisto. Shot-like sounds that are heard over the femoral artery upon compression. 2 equals A. Collapse. Find text. Text. Possible causes. Physiological variations. Bradyarrhythmias. Tachyarrhythmias. Physiological, normal. Atrial tachyarrhythmias, example atrial flutter, with a fixed AV block. Respiratory sinus arrhythmia. Atrial fibrillation. Atrial tachyarrhythmias, example atrial flutter, with a varying AV block. Ventricular ectopics, premature ventricular contractions. Pulse deficit. 10/min, atrial fibrillation. Pulse deficit. Severe left heart failure. Digoxin toxicity. Aortic regurgitation. Arterial hypertension. Hyperdynamic circulation, anemia, sepsis. Patent ductus arteriosus. Ventricular septal defect, VSD. A. Outline. Hyperkinetic pulse, pulsus altus bounding pulse, water hammer pulse. Copyright bounding pulse with a rapid upstroke followed by a prompt collapse of the vessel. A copyright referred to as Corrigan pulse when present in the carotid artery. Traub sign, pistol shot-like sounds that are heard over the femoral artery upon compression. Hypokinetic pulse, pulsus parvus. Soft pulse with a low amplitude. Pulsus paradoxus, pathological decrease in the pulse wave amplitude and systolic blood pressure. 10 mm Hg during inspiration. I copyright decrease of intrathoracic pressure during inspiration. Expansion of vena cava and right atrium. 7 venous return. 7 RV filling. Copyright pericardial compliance, example due pericardial rigidity in constrictive pericarditis. T bowing of the volume, amplitude, ventricular septum into the left ventricle. 1 LV ejection volume. Systolic blood pressure. Reverse pulsus paradoxus, pulse volume increases with inspiration. Pulsus alternans, alternation of strong and weak pulses caused by alterations in the stroke volume. Cardiac output, J dicrotic pulse, 2 peaks in the pulse wave occurring in systole and diastole. Fa. Degree UV equals A. I go for a GQOO registered 3Q23 equals LEOO equals by. Fast rising pulse, pulse seal a rapid upstroke of the pulse, speed of pulse upstroke equals, wave contour. Slow rising pulse, pulsus tardus delayed peak pressure of the carotid artery fa. Radiofemoral delay, a delay in palpation of the femoral arterial pulse when compared with the radial arterial delay pulse. Auscultation, 1. Aortic regurgitation, arterial hypertension, hyperdynamic circulation, anemia, sepsis, patent ductus arteriosus, ventricular septal defect, VSD. Low blood pressure. Constrictive pericarditis, cardiac tamponade, severe obstructive airway disease, asthma, COPD, obstructive sleep apnea, croup tension, pneumothorax, superior vena cava syndrome, HOCMAV, dissociation, intermittent positive pressure ventilation, IPPV, congestive heart failure, HOCM, aortic regurgitation, aortic stenosis, aortic regurgitation, aortic stenosis, coarctation of the aorta, vascular obstruction, atherosclerosis, aneurysms. Auscultate over the carotid arteries, abdominal aorta, renal arteries, and femoral arteries to detect bruits, which are vascular murmurs caused by turbulent, non-laminar blood flow in a vessel. Ascent causes of bruits: OAV fistulae, copyright arteriovenous malformations, EO aneurysms, O vascular stenosis, copyright hyperdynamic circulation. E.g., pregnancy, fever, anemia, hyperthyroidism may occur physiologically in adolescents. Chest inspection. Approach, 1. The patient is asked to undress from the waist up and the physician evaluates for the following. Asterisk scars, example heart surgery, pacemakers, chest deformities, example pectus carinatum, pectus excavatum, visible apex beat, sent distended veins, example in SVC obstruction, sent de Musset sign, head bobbing in time with the pulse, seen in aortic regurgitation. Your notes. 4st. Cardiac palpation. A. Collapse, find text. Al. Outline. X. Cardiovascular examination. Cardiac palpation. Apex beat, 1. The apex beat, apex impulse, is the outermost and lowermost palpable cardiac impulse on the chest wall. Palpation of the apex beat, 1. Approach, copyright performed in the supine position with the torso elevated to 45 degrees. The examiner places a flat hand on the cardiac apex to locate the apex beat, and further localizes and assesses the beat by palpating with 2 to 3 fingers. If the apex beat is not initially palpable, the patient should be positioned on the left lateral side and the cardiac apex palpated during expiration. Normal findings: copyright position, 5 left intercostal space in the midclavicular line. Copyright character, a brief, early systolic impulse that is felt over an area of 2 to 3 centimeters. Abnormalities of the apex beat. Abnormality etiology. Lateral and downward displacement. Left ventricular enlargement, displacement to the right hemithorax, dextrocardioroscillation, right ventricular hypertrophy. Asterisk right tension, pneumothorax, sent lateral displacement. Asterisk large right-sided pleural effusion. Asterisk chest wall deformities. Plus hyperdynamic impulse, a brief, forceful impulse palpable over a plus high cardiac output, example thyrotoxicosis, anemia, sepsis, beriberi, diffuse area, 3 cm, plus volume overload, aortic regurgitation, mitral regurgitation, VSD, patent ductus arteriosus. Sent heaving impulse, a prolonged, forceful impulse plus pressure overload, hypertension, HOCM, aortic stenosis character. Asterisk myocardial infarction, conditions that impair transmission of the apex impulse to the chest wall, obesity, pericardial effusion, left-sided pleural effusion, pneumothorax, COPD. Asterisk hypodynamic impulse, a weak or absent apex impulse. Tapping apex beat, palpable first heart sound. Mitral stenosis dyskinetic apex beat, uncoordinated impulse over a diffuse area left ventricular dysfunction, example anterior myocardial infarction. Other impulses. Parasternal heave, a heaving motion felt over the left parasternal area while palpating with the heel of the right hand. Copyright suggests right ventricular hypertrophy. Sent thrills, a palpable heart murmur, usually over the region where the murmur is heard best. Palpable heart sounds. Palpate over valve areas, see auscultatory locations. A palpable P2 suggests pulmonary hypertension. Sent epigastric pulsations. Copyright visible or palpable pulsations over the epigastric region of the abdomen. Degree associated with right ventricular hypertrophy or an abdominal aortic aneurysm. GVU. OE. Chest percussion. Although cardiac percussion can provide some information about the size and shape of the heart, it is very unreliable and dependent on the examiner and is thus of limited clinical use. WA. OXE. Cardiac auscultation. Approach I. Sent the patient should be in a supine position with the torso elevated to 45 degrees. Equals QAL. Collapse fine text outline. Cardiac auscultation. Approach 1. Sent the patient should be in a supine position with the torso elevated to 45 degrees. Sent ask the patient to refrain from speaking while the heart sounds are being assessed. Asterisk the radial pulse should be palpated while auscultation is performed. Sent if heart sounds are weakly audible, ask the patient to hold their breath after exhaling. Sent assess the following: copyright location, timing, changes in intensity, and splitting of heart sounds. Abnormal heart sounds. Murmurs. Auscultatory locations. Heart sound auscultation sites. Name of area location. Point, cardiolo, GY, plus 3 degrees RD Jeft parasternal I intercostal space -A plus systolic, murmurs, HOCM. Asterisk aortic stenosis aortic area plus 24 right parasternal intercostal space asterisk aortic regurgitation coarctation of the aorta. Asterisk pulmonary stenosis pulmonary regurgitation plus ASD pulmonic area 24 left parasternal intercostal space. Asterisk mitral stenosis mitral area mitral regurgitation sent mitral valve prolapse, MVP, 5 left intercostal space in the midclavicular line. Tricuspid stenosis tricuspid regurgitation sent VSD tricuspid area 4 left parasternal intercostal space. Pathology. Diastolic murmurs, aortic regurgitation, pulmonic regurgitation. And all physicians earn too much, aortic, pulmonary, point, tricuspid, mitral. IME. IMI. OES. Lee heart sounds. Normal heart sounds, 1. Sent the first, S1, and second, S2, heart sounds are physiological sounds heard in all healthy individuals. Sent the third, S3, and fourth, S4, heart sounds may be physiological, particularly in young adults, pregnant women, and the elderly, or pathological. Normal heart sounds sound origin location. Sent closure of the mitral valve end. Timing at the onset of systole first heart sound, S1. Aortic component of the second heart sound S2. Heard just before the carotid pulsation is felt OE asterisk heard best in the mitral area, cardiac apex, tricuspid valve. Asterisk heard best in the aortic area at the right upper asterisk during the transition from systole asterisk closure of the aortic valve, louder, to diastole sternal border 1 heard immediately after the carotid D asterisk closure of the pulmonary valve pulsation BIP heart sound. Physiological heart sounds. Extra heart sounds, 1. Heard best in the pulmonary region, softer, PEC also splitting of S2. Extra hard sounds, gallops, dash. 2 equals A. Collapse fine text. A. Outline. Extra hard sounds. Extra hard sounds, gallops, sound origin timing occurrence. Scent physiological, young individuals. Asterisk physiological, advanced age, asterisk due to late diastolic contraction of the atria. Scent pathological if palpable, atrial kick, against high ventricular pressure. 1 asterisk late diastolic, presystolic, sound heard immediately before S1. Copyright ventricular hypertrophy, example EY heard best with the bell of the stethoscope and the plus. S1 rapidly follows S4, resembling the cadence of the word Tennessee. Hypertension, aortic stenosis, COR mitral area with the patient lying in a left lateral, 10s, S4, $1. C, S2, on auscultation. Pulmonal, position E ischemic cardiomyopathy. Copyright acute myocardial infarction. FT sound RT sound. At gallops that originate from the left side of the heart, the most common, become softer with inspiration, while those that originate from the right side become louder. Changes in intensity, degree. Increased or decreased intensity, loudness, of the heart sounds may indicate certain pathologies. Copyright tachycardia, O hyperdynamic states, example left to right shunts, copyright short PR interval, example AVRT, Sensofts S11. Severe mitral stenosis - copyright conditions that impair the transmission of heart sounds to the chest wall, COPD, pneumothorax, pericardial effusion, obesity. Copyright prolonged PR interval, example first degree heart blocks, E variable intensity. Copyright atrial fibrillation. Copyright AV dissociation. O auscultatory alternans, severe LV failure, large pericardial effusion. S2 intensity. E loud. A2, arterial hypertension, coarctation of the aorta. Scent loud. P2, pulmonary hypertension, atrial septal defects. 10. Splitting of heart sounds. If the aortic and pulmonary valves do not close simultaneously, an apparent splitting of S2 can be heard upon auscultation. Splitting of heart sounds. Type of split description. Causes. Occurs when the closure of the tricuspid valve is delayed, example due to an RBBB, resulting in the conduction disorders. Split S1. I sound of tricuspid valve closure heard shortly after mitral valve closure, asterisk hemodynamic cause. Scent. The sound of aortic valve closure, A2, precedes the sound of pulmonary valve closure, P2, during inspiration. Physiological split. A copyright inspiration. Fall in intrathoracic pressure, increase in venous return to the right side of the asterisk, especially pronounced among young individuals. 1 heart prolonged right ventricular systole, delayed closure of P2. Copyright pooling of blood in pulmonary circulation, shortened left ventricular systole, premature. A2 plus pulmonary hypertension. An exaggerated physiological split, which is more pronounced during inspiration, A2 precedes P2, asterisk pulmonary valve stenosis. Wide split. Scent caused by any condition that increases right ventricular afterload or decreases left ventricular, asterisk RBBB preload. Massive pulmonary embolism, severe mitral regurgitation. Degree. Increased right ventricular afterload, prolonged right ventricular systole. Copyright decreased left ventricular preload, shortened left ventricular systole equals QL. Collapse fine text outline. Wolff-Parkinson-White syndrome. Type of split. Split $1. Physiological split. A. Wide split. AE. Splitting of heart sounds. Description. Sound of tricuspid valve closure heard shortly after mitral valve closure. A. Inspiration. Heart prolonged right ventricular systole, delayed closure of P2. Occurs when the closure of the tricuspid valve is delayed, example due to an RBBB, resulting in the Copyright inspiration, fall in intrathoracic pressure, increase in venous return to the right side of the sound of aortic valve closure, A2, precedes the sound of pulmonary valve closure, P2, during. Copyright pooling of blood in pulmonary circulation, shortened left ventricular systole, premature A2. An exaggerated physiological split, which is more pronounced during inspiration, A2 precedes P2, Phe, 2 cubic centimeters and OOOMZZ 223 degrees SSA equals degree SSOEY equals 800 registered 000 equals 2 equals 00 equals 5252 AA00 equals FOOA FO8 QAEG 003 and 008 equals A. Prolonged right ventricular systole. Copyright decreased left ventricular preload, shortened left ventricular systole, split $2. A fixed split asterisk does not change with respiration and tends to be wide, i.e., the split is also audible during expiration. AA plus left to right shunt in ASDRV, volume overload delay in the closure of the pulmonary valve. Audible during expiration but not inspiration. Paradoxical split. Copyright expiration. A2 is heard after P2 during expiration due to delayed closure of the aortic valve. Split, reverse split, reversal, equals copyright inspiration. The closure of the pulmonary valve is also delayed, resulting in A2 and P2 occurring simultaneously, i.e., a paradoxical decrease in the split during inspiration. Absent split asterisk, no splitting of S2. VIT he ted heart te beat dad beer wer tie beer oe po sound G1, sound 2, scene GI, sound 2, sound 1, sound 52. PX. THT, TTTTT plus open hiata IH dash plus plus 4 plus hashtag F. HT sound with physiologic. Additional sounds, 1. Scent clicks are crisp sounds produced by the movement of abnormal valves. Scent other sounds may also be heard, such as an opening snap, pericardial friction rub, pericardial knock. Sound. Aortic ejection click. Mitral valve prolapse P, click. Mitral valve opening snap. Additional D. On cardi origin opening of a stiff aortic valve, I heard best with the diaphragm of a stethoscope at the aortic region with the patient seated and leaning forward. Mitral valve prolapse into the left atria during systole, heard best with the diaphragm of a stethoscope at the mitral region with the patient in left lateral position. Opening of a stiff mitral valve, heard best with the bell of a stethoscope at the mitral region with the patient in a left lateral position. I. Scent $1 and S2 sound like clicks. Scent heard best with the diaphragm of a stethoscope, mechanical valve clicks. Pericardial friction rub plus. Pericardial knock. Scratching sound due to friction between the visceral and parietal pericardium, heard best over the left sternal border during expiration with the patient sitting upright and leaning forward. Asterisk sudden cessation of ventricular filling against a rigid pericardial sac, heard best at the left sternal border. Causes conduction disorders, hemodynamic cause. Especially pronounced among young individuals. Pulmonary hypertension, pulmonary valve stenosis, RBBB, massive pulmonary embolism, severe mitral regurgitation, Wolff-Parkinson-White syndrome, constrictive pericarditis. Atrial septal defect, ASD, severe RV failure. Aortic stenosis, left bundle branch block, HOCM, LV outflow tract obstruction, early excitation of the right ventricle, example RV pacing, Wolff-Parkinson-White syndrome. Severe aortic stenosis, geriatric, 1 VSD with Eisenmenger syndrome, pediatric, 1. Timing. Early systolic sound, immediately after S1. Mid-systolic sound. Early diastolic sound, immediately after S2. Coincides with a normal S1 and S2. Systolic or diastolic sound. Diastolic sound. Etiology. Aortic stenosis. Mitral valve prolapse, mitral stenosis, prosthetic valve, pericarditis, constrictive pericarditis. The presence of an aortic ejection click can be used to differentiate a pathological systolic murmur of aortic stenosis from a flow murmur. When the click is present, the murmur is pathological. The absence of a click in patients with prosthetic valves may indicate valve failure. Lee heart murmurs. Overview, 11 VNA collapse. A. Find text. O. Outline. Lee heart murmurs. Overview, 1. Scent murmurs are blowing or whooshing sounds that occur as a result of turbulent blood flow. They are described according to the location, radiation, timing, intensity, configuration, frequency, and response to dynamic maneuvers. For specific auscultatory findings in valvular heart disease, see auscultation in valve. For specific auscultatory findings of heart defects, see Puller defects. Ital heart defects. Functional and pathological murmurs. Murmurs may be functional or pathological. Criteria. Difference B. Functional heart murmur, physiological or innocent. To a hyperdynamic circulation etiology. Intensity. Timing. Position change. Most commonly occurs in children and young adults. Cardiac pathology must be ruled out. Soft, grade. Most commonly mid-systolic or continuous. Position dependent, varies in intensity or disappears. Location and radiation, 1. Scent location, see auscultatory locations. Scent radiation. Copyright aortic stenosis, a systolic murmur radiates to carotid arteries. Copyright mitral regurgitation, a systolic murmur radiates to the left axilla, in the left lateral recumbent position. Copyright pulmonary stenosis, a systolic murmur radiates to the interscapular region. Timing 1. Murmur. Systolic murmur. Diastolic murmur Ma. Continuous murmur. Timing. During ventricular contraction, i.e., occurs with or after S1 and before S2, can be classified as copyright early systolic murmur, copyright mid-systolic murmur, copyright late systolic murmur, copyright hollow systolic murmur. During ventricular relaxation, i.e., occurs with or after S2 and before S1, can be classified as copyright early diastolic murmur, copyright mid-diastolic murmur, copyright late diastolic murmur, copyright hollow diastolic murmur. During systole and diastole. Pound ional and pathology murmurs. An ejection murmur due to increased or turbulent blood flow across normal aortic and / or pulmonary valves, example do. Heart defects. Typically grade 3/6 thrill may be present. Rarely disappears. Timing of heart murmurs. FN occurrence functional. Children pregnancy during states of excitement or strenuous activity, anemia, fever, sepsis, thyrotoxicosis, beriberi, arteriovenous fistula, still murmur. Copyright most common innocent murmur in children. Copyright grade 1 to 3 mid-systolic murmur, heard best at the left mid-sternal border or between the left lower sternal border and the apex, degree louder when the patient is supine and softer when the patient is upright. Copyright unknown etiology. Does not occur physiologically. Hyperdynamic state, cervical venous hum. Degree common benign finding in children due to turbulent flow in internal jugular veins, heard best at the infraclavicular and supraclavicular regions, more common on the right side, becomes softer or disappears with flexion of the head, compression of the jugular vein, or in the supine position may radiate to the $1 and 2 ICS4. Degree. 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 Pathological murmur. Caused by structural defects, valvular disease or Systolic, diastolic, or continuous. Pathological. Aortic stenosis, pulmonary stenosis, mitral regurgitation, tricuspid regurgitation, VSD, coarctation of the aorta, HOCM. Mitral stenosis, aortic regurgitation, tricuspid stenosis, pulmonary regurgitation. PDA, arteriovenous fistulas. Diastolic murmurs are almost always pathological. Diastolic murmurs may require certain maneuvers to make them more apparent, example letting the patient sit and lean forward to intensify the murmur of aortic regurgitation. WV equals A. Collapse, find text. Al. Outline. Intensity 1. The intensity refers to the loudness of the murmur on auscultation, grades I6. Grading of murmur intensity 2. Levine grading scale intensity grade sent very faint murmur only heard upon careful auscultation Fa. Grade IL sent faint murmur, but can be detected almost immediately. ENA sent easily heard hacks plus no thrill. Grade 4 loud murmur with a palpable thrill. Grade V sent very loud murmur with an easily palpable thrill sent audible with just the rim of the stethoscope touching the chest. Loudest possible murmur grade 6 audible with the stethoscope hovering above the chest. Copyright. While most grade 3 and above murmurs are pathological, the intensity of a murmur does not always correlate to the severity of the underlying lesion. For example, a larger VSD produces a softer murmur than a small VSD, and a murmur of severe aortic stenosis may disappear if a patient develops left heart failure. Copyright. All diastolic murmurs and any grade 2 and above systolic murmurs require further echocardiographic evaluation. Configuration. The configuration describes the change in intensity, loudness, of a murmur, which is determined by the pressure gradient driving the turbulent flow. Plus types dy. Copyright. Uniform, unchanging intensity. Copyright. Crescendo, increasing intensity. O decrescendo. Endo, decreasing intensity. Copyright. Crescendo decrescendo, initial increase followed by a decrease in intensity. Frequency, pitch, 1. The frequency of a murmur is determined by the velocity of turbulent flow, which is in turn affected by the pressure gradient. Sent high pitch, high pressure gradient and high velocity flow, example VSD, low pitch, low pressure gradient and low velocity flow, example mitral stenosis, maneuvers, 1. Certain maneuvers may be performed to elicit a change in the intensity of a murmur. Maneuvers and their effect on murmurs. Maneuver effect on cardiac parameters. Effect on murmurs. TRV preload 4 LV preload. No effect on LV after load. +7 intensity of murmurs arising from the right side of the heart. Sent J intensity of murmurs arising from the left side of the heart. See exceptions to maneuvers below. Inspiration. JRV preload 4 LV preload. JLV after load +7 intensity of MVP, with early mid-systolic click, and hypertrophic cardiomyopathy, HCM, murmurs. Valsalva maneuver /stand-in, AESY, U9J intensity of murmurs arising from the left side of the heart, see exceptions to maneuvers below. TRV preload 7 colonase intensity of all murmurs, see exceptions to maneuvers below. LV preload sent J intensity of MVP, with late mid-systolic click, and HCM murmurs. No effect on LV after load. After load may tetralogy of Fallot, the severity of TET spells and the associated murmurs decrease with squatting. Increase with squatting, MVP, click occurs later in systole. Squatting / lying down quickly / raising the legs. T intensity of murmurs resulting from backward flow of blood in the left side of the heart. Example * no effect on RV preload. Aortic regurgitation, mitral regurgitation, VSD, MVP, hand grip * no effect on LV preload. Sent J intensity of murmurs associated with forward flow of blood in the left side of the heart. Example 7 LV after load. Mitral stenosis, aortic stenosis, HCM, MVP, click occurs later in systole. Intensity of murmurs at or near the aortic valve, example aortic stenosis, aortic regurgitation, no effect, coarctation of the aorta, HOCM, sitting and leaning forward. Lying down in the left lateral position, no effect. Cent F intensity of murmurs at or near the mitral valve, example mitral stenosis, mitral regurgitation, MVP. Exceptions to maneuvers. Equals QAL. Collapse fine text outline. Exceptions to maneuvers. In the following conditions, maneuvers that increase preload decrease the intensity of the murmur and vice versa. Plus HOCM, 1, plus MVP. Maneuvers that decrease LV preload, example inspiration, Valsalva maneuver, usually decrease the intensity of murmurs arising from the left side of the heart, except in HOCM and MVP, in which a decrease in LV preload increases the intensity of the murmur. Audio clip examples of murmurs. Ductus arteriosus septal defect, DAR septal defect. 27 CE. Diagnostics. Imaging 13. Sent electrocardiography, sent cardiac stress test, sent chest x-ray, sent echocardiography, sent cardiac MRI/CT * cardiac scintigraphy, especially in ischemic cardiac disease. Chest x-ray, heart. The heart shadow can be viewed on a chest x-ray. Re heart contour in the lateral view. O anterior border, right ventricle copyright inferior border, left ventricle copyright posterior-superior border, left atrium sent heart contour in the postanterior, PA, view M copyright right border, from caudal to cranial right atrium, superior vena cava O left border, from caudal to cranial left ventricle, left atrial appendage, pulmonary trunk, aortic knuckle copyright inferior border, right ventricle 4 cent cardiothoracic ratio, heart size, copyright the cardiac diameter. Is divided by the thoracic diameter on the same horizontal level in a PA view. A copyright the normal cardiothoracic ratio is between 0.42 and 0.5. Copyright cardiomegaly, an enlarged heart, cardiothoracic ratio 0.5, due to a variety of conditions, example arterial hypertension, CAD, athletic heart syndrome M. L. High. Copyright a non-invasive ultrasonographic examination of the heart in which a transducer is placed on the anterior chest wall and the epigastrium. Plus assess the lung fields, example for signs of pulmonary edema. 5. Echocardiography. Sent transthoracic echocardiography, TTE. O recommended for initial evaluation of pathological murmurs, example diastolic murmur, late systolic murmur, all symptomatic murmurs. 14. Copyright used to assess valvular function by determining the following, equals average pressure gradient equals valve area, decreased in valvular stenosis, example a small valve area with a high pressure gradient indicates severe stenosis, equals amount of reflux via a color duplex scan, increased in valvular insufficiency O used to assess myocardial contractility, example. Decreased contractility in heart failure, cardiac wall motion abnormalities in myocardial infarction, right ventricular hypokinesia in pulmonary embolism, V equals A. Collapse fine text outline. Sent cardiac scintigraphy, especially in ischemic cardiac disease. Chest x-ray, heart. The heart shadow can be viewed on a chest x-ray. Sent heart contour in the lateral view O anterior border, right ventricle O inferior border, left ventricle O posterior-superior border, left atrium sent heart contour in the postanterior, PA, view, M O right border, from caudal to cranial right atrium, superior vena cava O left border, from caudal to cranial left ventricle, left atrial appendage, pulmonary trunk, aortic knuckle O inferior border, right ventricle, sent cardiothoracic ratio, heart size, copyright the cardiac diameter. Is divided by the thoracic diameter on the same horizontal level in a PA view. Copyright. The normal cardiothoracic ratio is between 0.42 and 0.5. Copyright. Cardiomegaly, an enlarged heart, cardiothoracic ratio 0.5, due to a variety of conditions, example arterial hypertension, CAD, athletic heart syndrome *. Cent. Assess the lung fields, example 4 signs of pulmonary edema. A equals IA EEI. EO. A non-invasive ultrasonographic examination of the heart in which a transducer is placed on the anterior chest wall and the epigastrium. Echocardiography. Cent. Transthoracic echocardiography, TTE. Copyright. Recommended for initial evaluation of pathological murmurs, example diastolic murmur, late systolic murmur, all symptomatic murmurs. 4.0 Used to assess valvular function by determining the following, equals average pressure gradient equals valve area, decreased in valvular stenosis, example a small valve area with a high pressure gradient indicates severe stenosis, equals amount of reflux via a color duplex scan, increased in valvular insufficiency. O. Used to assess myocardial contractility, example decreased contractility in heart failure, cardiac wall motion abnormalities in myocardial infarction, right ventricular hypokinesia in pulmonary embolism. O. Used to evaluate for other pathologies, example septal defects, aneurysms, thrombi, vegetations, pericardial effusions. Cent. Transesophageal echocardiography, T.O. An ultrasonographic examination of the heart, coronary vessels, and thoracic aorta performed by endoscopically inserting a transducer through the esophagus. Copyright. Used to identify atrial septal defects and infective endocarditis, as well as to differentiate between thoracic aortic diseases, example aneurysm, dissection. Also used during cardiac surgery or catheterization. Invasive tests, 13. Cent. Cardiac catheterization. Copyright. Coronary angiography and, possibly, PCI-1. Copyright. Direct measurement of the ventricular and aortic pressures to determine the degree of valvular stenosis. Copyright. Cardiac ventriculography to directly visualize and quantify the reflux of the contrast material in valvular insufficiencies. Copyright. Right heart catheterization. Electrophysiological study. Copyright. To assess cardiac arrhythmias. Copyright. The cardiac arrhythmia is often treated during the test itself, example by ablation. Myocardial biopsy. O. If there is suspicion for cardiomyopathies, myocarditis, or systemic illnesses with cardiac involvement, example sarcoidosis, amyloidosis, hemochromatosis. Copyright. Follow-up after heart transplantation, to rule out the possibility of organ rejection. FO. OE. Tips and links. Sources. Last updated October 30, 2023 equals QL. Collapse fine text outline. Erythema marginatum VV. Left upper arm of a child diagnosed with acute rheumatic fever, ARF, erythematous plagues with areas of central clearing are visible on the ventral aspect of the forearm. This is characteristic of erythema marginatum, the characteristic annular erythema occurring in 10% of attacks of acute rheumatic fever in children, caused by group A streptococcus. Source: Erythema marginatum by ADSI, Wikimedia Commons, licensed under CC by SA 4.0. Modifications: image has been cropped. Cardiovascular examination, 2/9. Subcutaneous nodules in rheumatic fever VV. Solitary subcutaneous, erythematous, warm, and tender protuberances are visible on the left shoulder. In conjunction with flu-like symptoms, ankle swelling, and an elevated anti-streptolysin O, ASO, titer, these skin findings indicate rheumatic fever. Source: Figure 1, in Acute Rheumatic Fever, a review of essential cutaneous and histological findings by M. A. Hurd, M. C. Green, M. Royer, Curious, licensed under CC by 4.0. Cardiovascular examination, 3/9. EERRR_, EE. A. RISFA. Osler nodes VV. There are multiple raised nodular lesions on the palm and palmar aspects of the first and second digits. The lesions appear dark brown, indicating subcutaneous hemorrhages. This is the typical appearance of Osler nodes. Source: Osler nodules, hand by Roberto J. Galindo, Wikimedia Commons, licensed under CC by SA 4.0. Cardiovascular examination, 4/9. Janeway lesions VV. Multiple erythematous macules are visible on the thenar eminence and the base of the thumb. These Janeway lesions are typically caused by septic microembolism secondary to infective endocarditis. Source: Janeway lesion by Warfieldian, Wikimedia Commons, licensed under CC by SA 4.0. Digital clubbing VV. There is a thickening of the distal phalanx, so-called drumstick appearance, with arched, markedly convex nails. These findings are consistent with hypertrophic osteoarthropathy. Copyright Embark. Splinter hemorrhages in endocarditis. The vertical hemorrhages, arrowheads, underneath this patient's fingernails are most commonly caused by trauma but can also occur as a result of immune complex deposition or microthrombosis in subacute, infective endocarditis, SLE, or rheumatoid arthritis. Source: Splinter hemorrhage, Splarka, Wikimedia Commons, licensed under public domain. Xanthelasma VV. Well-defined yellow plagues, xanthelasma, are visible on the medial aspect of the upper eyelids bilaterally. These cutaneous lipid deposits are a common finding in patients with hypercholesterolemia. Source: courtesy of Dr. Gary M. White, MD. Arcus senilis VV. Slit lamp photography of the left eye. A white opacity, caused by lipid deposition, lines the lower and slightly also the upper periphery of the cornea while being clearly separated from the limbus by clear cornea. This is the typical appearance of an arcus senilis. In the early stages, it is usually seen in the inferior cornea. It may extend to a full circle in more advanced stages. If present in young individuals, blood lipid levels should be examined. Source: Figure 1, in Correlating Corneal Arcus with Atherosclerosis in Familial Hypercholesterolemia by Lauren A. Zeck, Jeffrey M. Hogue, Lipids in Health and Disease, licensed under CC by 2.0. Modifications: cropping. Varicose veins VV. Photograph of the medial aspect of the ankle. Multiple dilated and tortuous veins are visible around the medial malleolus. Numerous bluish telangiectasias can be seen toward the inferior spect, while reddish-brown pigmentation can be seen adjacent to the Achilles tendon. These are typical features of chronic venous insufficiency due to varicose veins. Source: courtesy of Dr. Gary M. White, MD. Pressure, mmHg. 3 euros for 160 plus 1 is systolic S_ blood pressure, arterial 1 bay pressure, inflation of AE 120 plus ID. The cuff BES. I80. Re so add cuff pressure, diastolic I blood pressure O copyright O at 40-I. 1. Approximate 120 mm Hg, approximate 80 mm Hg. See Korokov sounds for gradual deflation further of the cuff, scent deflation 4. Blood pressure measurement. 1. Apply the cuff so that the bladder lies over the brachial artery. 2. Palpate the radial artery. 3. Inflate the cuff slightly above the pressure where the radial pulse cannot be felt, and then deflate slowly until the pulse returns. This gives an estimation of where to expect the systolic value, the appearance of the first Korokov sound. 4. Place the diaphragm of the stethoscope over the brachial artery, underneath the distal end of the cuff's bladder. 5. Inflate the cuff again to a value higher than the expected systolic value, and deflate gradually while listening for the Korokov sounds. Interpretation. The first sound heard is the systolic blood pressure. The diastolic pressure is the pressure at which the Korokov sounds disappear. Copyright Embark. Diastole systole diastole. Central venous pressure. Pressure, mmHg, no. Jugular venous pressure waveform VV. Normal jugular venous pressure, JVP, waveforms have three waves, A, C, V, and two descents, X, Y, that occur in the following order: a wave, caused by atrial contraction, C wave, caused by tricuspid valve closure, X descent, caused by atrial relaxation, V wave, caused by venous refilling of the atria, Y descent, caused by passive filling of the right ventricle when the tricuspid valve opens. Copyright Embark. Pressure, mmHg. Pressure. Diastole systole diastole. Con ejection relaxation filling 120 - traction. 80, time RR $1 $2 I. 1 pill 2. OMVR. QSI. ECG/heart sounds. R. A wave X descent, V wave Y descent. Jugular venous pressure waveform VV. The jugular venous pressure, JVP, reflects the pressure changes in the right atrium during the cardiac cycle. Normal JVP waveforms have three waves, A, C, V, and two descents, X, Y. A wave, caused by atrial contraction and, therefore, corresponds with the P wave of the ECG, and the late diastolic phase of the aortic pressure curve, C wave, caused by tricuspid valve closure and, therefore, corresponds with the S1 heart sound and occurs during the early systolic phase of the aortic pressure curve, X descent, caused by atrial relaxation and, therefore, corresponds with the T wave of the ECG, V wave, caused by venous refilling of the atria, Y descent, caused by passive filling of the right ventricle when the tricuspid valve opens and, therefore, corresponds with the mid-diastolic phase of the aortic pressure curve. Copyright Embark. Normal jugular venous pressure, congenital and valvular defects, severe tricuspid regurgitation, I, X equals pound E2A% 2A. Time, restrictive heart conditions, rhythm disorders, constrictive pericarditis, tricuspid stenosis, complete AV block of EVEA. XYM. Pericardial tamponade, atrial septal defect, atrial fibrillation. V25C, AOG VYXX. Y. Jugular venous pressure waveforms in common cardiac conditions, VV. A normal jugular venous pressure, JVP, waveform is composed of a wave, atrial contraction, C wave, tricuspid valve closure, X descent, atrial relaxation, V wave, venous refilling of the atria, Y descent, passive filling of right ventricle when the tricuspid valve opens. Common abnormalities of the JVP waveform include constrictive pericarditis, elevated JVP, due to increased external atrial pressure, with a prominent X, exaggerated atrial relaxation, and Y, early rapid ventricular filling, descent, cardiac tamponade, elevated JVP, due to increased external atrial pressure, a prominent X descent, exaggerated atrial relaxation, and a blunt or absent Y descent, minimal ventricular filling, tricuspid regurgitation, prominent V wave as the blood from the right ventricle regurgitates into the right atrium during CAEENEOE, 224:00. Normal jugular venous pressure, congenital and valvular defects, severe tricuspid regurgitation, I, X equals pound E2A% 2A. Time, restrictive heart conditions, rhythm disorders, constrictive pericarditis, tricuspid stenosis, complete AV block of EVEA. XYM. Pericardial tamponade, atrial septal defect, atrial fibrillation. V25C, AOG VYXX. Y. Jugular venous pressure waveforms in common cardiac conditions, VV. Common abnormalities of the JVP waveform include constrictive pericarditis, elevated JVP, due to increased external atrial pressure, with a prominent X, exaggerated atrial relaxation, and Y, early rapid ventricular filling, descent, cardiac tamponade, elevated JVP, due to increased external atrial pressure, a prominent X descent, exaggerated atrial relaxation, and a blunt or absent Y descent, minimal ventricular filling, tricuspid regurgitation, prominent V wave as the blood from the right ventricle regurgitates into the right atrium during ventricular systole, atrial diastole, increasing interatrial pressure and volume, tricuspid stenosis, giant A wave due to high right atrial systolic pressure, atrial septal defect, V wave equals a wave due to the left to right shunting of blood, third degree atrioventricular, AV, block, Cannon waves due to the loss of AV synchronization and contraction of the atria against a closed tricuspid valve. Atrial fibrillation, absenta waves due to ineffective contraction of the atria. Sites of palpation for pulse measurements 4_Dorsales pedi palpation should be performed systemically to include all important peripheral pulses. An example of a cranial to caudal approach to peripheral pulse examination is shown. Copyright Embark. Facial artery pulse. The facial artery is a branch of the external carotid artery. Although the facial artery is easily palpable against the mandible, it is not commonly used for pulse measurement. Source: Copyright IMPP. External carotid artery, internal carotid artery, common carotid artery, vertebral artery, subclavian artery, brachiocephalic artery, axillary artery, aortic arch, pulmonary trunk. Brachial artery, celiac artery, superior mesenteric renal artery, artery, abdominal aorta, inferior mesenteric artery, common iliac artery, internal iliac artery. Aortic bifurcation. External iliac artery, radial artery, ulnar artery, femoral artery. Superficial palmar arch. Deep palmar arch, profunda femoris artery. Popliteal artery. Anterior tibial artery, fibular artery, posterior tibial artery. Dorsalis pedis artery. Major arteries of the body A. At luminal aorta. Superficial mearal artery, subclavi, infraclavicular V5. Examples of auscultation points of major arteries VV. Copyright Embark. Aortic valve, IL, pulmonary valve, IL, tricuspid valve, 4 mitral valve. Location of heart valves VV. Copyright Embark. Urocardiovascular examination, 2/3. At aortic valve NKY, 2. Pulmonary valve Q, tricuspid valve, at mitral valve G, herb point. Auscultatory sites for heart sounds VV. 1. Aortic area, 2. For right parasternal intercostal space, ICS, ideal site for auscultation of aortic valve murmurs, 1A. The murmur of aortic stenosis also radiates to the carotid arteries, 1B. 2. Pulmonary area, 2. Left parasternal ICS, ideal site for auscultation of pulmonary valve murmurs, 3. Tricuspid area, 4. Left parasternal ICS, ideal site for auscultation of tricuspid valve murmurs, 4. Mitral area, 5. Left ICS in the midclavicular line, over the cardiac apex, ideal site for auscultation of mitral valve murmurs, 4A. The murmur of mitral regurgitation also radiates to the left axilla, 4B. Urocardiovascular examination, 2/3. At aortic valve NKY, 2. Pulmonary valve Q, tricuspid valve, at mitral valve G, herb point. Auscultatory sites for heart sounds VV. 2. Pulmonary area, 2. Left parasternal ICS, ideal site for auscultation of pulmonary valve murmurs, 3. Tricuspid area, 4. Left parasternal ICS, ideal site for auscultation of tricuspid valve murmurs, 4. Mitral area, 5. Left ICS in the midclavicular line, over the cardiac apex, ideal site for auscultation of mitral valve murmurs, 4a. The murmur of mitral regurgitation also radiates to the left axilla, 4b. 5 Herb point, 3 left parasternal ICS, ideal site for auscultation of aortic regurgitation murmurs and for gaining an overview of heart sounds and murmurs from a single point. Urocardiovascular examination, 3/3. Aortic valve, pulmonary valve, tricuspid valve, 4. Mitral valve. Anatomical locations and auscultatory sites for heart valves, VV. 1 aortic area, 2 right parasternal intercostal space, ICS, ideal site for auscultation of aortic valve murmurs, 1a. The murmur of aortic stenosis also radiates to the carotid arteries, 1b. 2 pulmonary area, 2 left parasternal ICS, ideal site for auscultation of pulmonary valve murmurs, 3. Tricuspid area, 4 left parasternal ICS, ideal site for auscultation of tricuspid valve murmurs, 4. Mitral area, 5 left ICS in the midclavicular line, over the cardiac apex, ideal site for auscultation of mitral valve murmurs, 4a. The murmur of mitral regurgitation also radiates to the left axilla, 4b. First heart, second heart sound, S1, sound, S82. Expiration. Inspiration. Wide split of S2. Wide split describes an exaggerated physiological split, A2 precedes P2, more pronounced in inspiration. This can be caused by any condition that increases right ventricular afterload and so prolongs right ventricular systole, delaying P2, example pulmonary hypertension or pulmonary valve stenosis. A2, closure of aortic valve, P2, closure of pulmonary valve. Copyright Embark. First heart, second heart sound, S1, sound, S82. Expiration I. Inspiration. Fixed split of S2. A fixed split does not change with respiration and tends to be wide, i.e., the split is also audible during expiration. It may occur in atrial septal defect or severe right ventricular failure. A2, closure of aortic valve, P2, closure of pulmonary valve. Copyright Embark. First heart, second heart sound, S1, sound, S82. Expiration, E. Inspiration. Paradoxical, reversed, split of S2. P2 precedes A2, audible during expiration but not inspiration. Certain conditions, example aortic stenosis, left bundle branch block, delay the closure of the aortic valve, resulting in P2 preceding A2. In inspiration, P2 is also delayed, physiological, causing a paradoxical decrease in the split. A2, closure of aortic valve, P2, closure of pulmonary valve. Copyright Embark. Urocardiovascular examination, 1/2. /7 click IE click lot let DB Mikael. Apuihel la mil ml ali, mili ihid mmy. L/FF/ if I electrocardiogram, ECG, midsystolic click ejection click A2 P2 lick. Phonocardiogram of systolic heart murmurs. Systolic murmurs, orange waveform, occur in a. Mitral/tricuspid regurgitation and or ventricular septal defect, hollow systolic murmur, b. Aortic/pulmonary stenosis, crescendo-decrescendo murmur, c. Aortic/pulmonary stenosis with an ejection click, d. Mitral valve prolapse, midsystolic click followed by crescendo murmur, e. Pulmonary stenosis with a split second heart sound. Copyright Embark. Urocardiovascular examination, 2/2. 1. /if electrocardiogram /VV dial. 3 SRNI via R. Phonocardiogram of diastolic murmurs. Diastolic murmurs, orange waveform, occur in a. Mitral stenosis, decrescendo endo murmur with OS, B. Tricuspid stenosis, mid-diastolic decrescendo endo murmur, C. Patent ductus arteriosus, continuous crescendo decrescendo murmur, D. Aortic and pulmonary regurgitation, decrescendo endo murmur. Note, patent ductus arteriosus produces a continuous murmur heard in both systole and diastole. OS, opening snap copyright Boss. Urocardiovascular examination, 1/9. G. Overlay. Normal chest radiograph, lateral view, A. Normal chest radiograph, lateral view, A. Urocardiovascular examination, 2/9. Cardiac silhouette left lateral view. A. Inferior vena cava. B. Left atrium. C. Right ventricle and transition to the pulmonary trunk. D. Right ventricle. E. Cardiac apex source, copyright IMPP. ENA equals. Ed. B. A. Overlay. Normal chest radiograph VV. X-ray chest, PA view, the lung volumes are normal. No abnormal pulmonary parenchymal opacities are seen. The cardiac silhouette, outlined in white, pulmonary hyla, example indicated by green overlay, and superior mediastinum are normal in size and configuration. The lateral costophrenic sulci, outlined in green, are sharp, with no evidence of effusion. No concerning skeletal lesions are identified. LV, left ventricle, RV, right ventricle, RA, right atrium, PT, pulmonary trunk, white arrow, AK, aortic knob, trachea, red overlay, breast shadow, white dotted outline source, copyright IMPP. Overlay. Normal chest radiograph VV. X-ray chest, PA view, the lung volumes are normal. No abnormal pulmonary parenchymal opacities are seen. The cardiac silhouette, outlined in white, pulmonary hyla, example indicated by green overlay, and superior mediastinum are normal in size and configuration. The lateral costophrenic sulci, outlined in green, are sharp, with no evidence of effusion. No concerning skeletal lesions are identified. LV, left ventricle, RV, right ventricle, RA, right atrium, PT, pulmonary trunk, white arrow, AK, aortic knob, trachea, red overlay, breast shadow, white dotted outline source, copyright IMPP. Maximum horizon. X Center for Diagnostic and Interventional Radiology copyright overlay. Cardiothoracic ratio VV. Chest X-ray, PA view, the cardiothoracic ratio, CTR, is used to aid in the detection of cardiac silhouette enlargement on a PA radiograph. The maximum transverse diameter of the cardiac silhouette is divided by the maximum transverse diameter, inner edges of ribs or pleura, of the thorax. A value 0.50 may be considered an indicator of cardiac silhouette enlargement. The CTR is influenced by several factors, including dilatation of cardiac chambers, rotation of the heart, phase of respiration, posture, and measurement error. Our great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Urocardiovascular examination, 5/9. Onto diameter sill, E. Overlay. Cardiac silhouette enlargement VV. X-ray chest, PA view, of a patient with peripartum cardiomyopathy. There is marked generalized enlargement of the cardiac silhouette, which correlated with biventricular enlargement on subsequent echocardiography. Cardiothoracic ratio, CTR, is calculated as the maximum transverse diameter of the cardiac silhouette divided by the maximum transverse diameter of the thorax on a postanterior, PA, chest radiograph. A CTR greater than 0.50 is usually considered cardiac silhouette enlargement, although a larger CTR can be seen in certain normal situations, example expiratory radiograph, prominent fat pad. Source, Fig 1, in an unusual case of peripartum cardiomyopathy manifesting with multiple thromboembolic phenomena, Figure 1 by Uzoma N. I. Buagu, John W. Thornton and Guy L. Reed, Thrombosis Journal, licensed under CC by 2.0. Overlay. Left ventricular enlargement, 1/2, VV X-ray chest, PA view, the cardiac silhouette is enlarged, with the left heart border displaced laterally, green overlay, from its normal position, green outline, as a result of left ventricular enlargement. Source, copyright IMPP. A. Overlay. Left ventricular enlargement, 1/2, VV X-ray chest, PA view, the cardiac silhouette is enlarged, with the left heart border displaced laterally, green overlay, from its normal position, green outline, as a result of left ventricular enlargement. Source, copyright IMPP. Overlay. Left ventricular enlargement, 2/2, VV. X-ray chest, lateral view, the prominent convexity of the posterior border of the cardiac silhouette, green overlay, normal cardiac silhouette indicated by green outline, represents left ventricular, LV, enlargement, indicated by arrow. There is no obliteration of the retrosternal space, red overlay, to indicate right ventricular, RV, enlargement. Source, copyright IMPP. Overlay. Left ventricular enlargement, 2/2, VV. X-ray chest, lateral view, the prominent convexity of the posterior border of the cardiac silhouette, green overlay, normal cardiac silhouette indicated by green outline, represents left ventricular, LV, enlargement, indicated by arrow. There is no obliteration of the retrosternal space, red overlay, to indicate right ventricular, RV, enlargement. Source, copyright IMPP. Overlay. Hydrostatic pulmonary edema VV. X-ray chest, AP view, the cardiac silhouette is enlarged, hatched green overlay, and the perihilar air space opacities, green overlay, have a bat wing, or butterfly, configuration. Linear interstitial opacities representing curly A lines, orange dashed lines, radiate from the hyla to the apices, and curly B lines, white dashed lines, are seen in the lateral midzones. The costophrenic angles are blunted, arrows, from bilateral pleural effusions. These features are characteristically seen in cardiogenic pulmonary edema. Our great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Urocardiovascular examination, 8/9. Overlay. Hydrostatic pulmonary edema VV. X-ray chest, AP view, the cardiac silhouette is enlarged, hatched green overlay, and the perihilar air space opacities, green overlay, have a bat wing, or butterfly, configuration. Linear interstitial opacities representing curly A lines, orange dashed lines, radiate from the hyla to the apices, and curly B lines, white dashed lines, are seen in the lateral midzones. The costophrenic angles are blunted, arrows, from bilateral pleural effusions. These features are characteristically seen in cardiogenic pulmonary edema. Our great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Overlay. Thrombus in the left atrial appendage V. Transesophageal echocardiogram in a 78-year-old patient with atrial fibrillation, aphasia, dysarthria, and numbness in the left leg, Mid-esophageal short axis view of the left atrium, a hyperechoic structure, red overlay, fills most of the lot, white arrow, green outline. This finding is typical of a large thrombus in the left atrial appendage. Transesophageal echocardiography is highly sensitive for cardiac thrombus. AV, aortic valve, LA, left atrium, LAD, left anterior descending artery source, figure 1, transesophageal echocardiogram, T, in, a left atrial appendage thrombus that developed during prophylactic low-dose dabigatran treatment resolved after switching to epazoban by Taku Koyama, Yoritaka Otsuka, Masaaki Kawahara, Yuki Yamato, Kita Nakamura, Suneo Kadama, Hiro Noguchi, Wiley Online Library, licensed under CC by 4.0. Copyright. Overlay. Thrombus in the left atrial appendage V. Transesophageal echocardiogram in a 78-year-old patient with atrial fibrillation, aphasia, dysarthria, and numbness in the left leg. Mid-esophageal short axis view of the left atrium, a hyperechoic structure, red overlay, fills most of the lot, white arrow, green outline. This finding is typical of a large thrombus in the left atrial appendage. Transesophageal echocardiography is highly sensitive for cardiac thrombus. AV, aortic valve, LA, left atrium, LAD, left anterior descending artery source, figure 1, transesophageal echocardiogram, T, in, a left atrial appendage thrombus that developed during prophylactic low-dose dabigatran treatment resolved after switching to epazoban by Taku Koyama, Yoritaka Otsuka, Masaaki Kawahara, Yuki Yamato, Kita Nakamura, Suneo Kadama, Hiro Noguchi, Wiley Online Library, licensed under CC by 4.0. X. Cyanotic congenital heart defects. Cyanotic heart defects, CHDs, are congenital cardiac malformations that commonly affect the atrial walls, example the right atrium, RA, or left atrium, LA, ventricular walls, example the left ventricle, LV, or right ventricle, RV, heart valves, or large blood vessels. Common causes include genetic defects, example DiGeorge syndrome, maternal conditions, example diabetes, and spontaneous genetic mutations. Pathophysiologically, cyanotic heart defects are characterized by a right-to-left cardiac shunt, which leads to deoxygenated blood entering the systemic circulation. The resulting hypoxemia manifests clinically as cyanosis, which may occur as acute, life-threatening episodes. Other symptoms include failure to thrive, characteristic heart murmurs, and symptoms of heart failure. Diagnosis is confirmed through visualization of the defect on echocardiography. Further diagnostic findings include low oxygen saturation and characteristic X-ray findings. Heart defects requiring treatment are repaired via catheter procedures or surgery. Supportive medical therapy is required in patients with heart failure, example diuretics, inotropic agents, or if surgery cannot be performed, example prostaglandin. If untreated, most cyanotic heart defects are fatal within the first year of life. OOS. Overview of cyanotic congenital heart defects. Commonly associated conditions and risk factors of cyanotic congenital heart defects. Most IATD and risk factors: DiGeorge syndrome, Down syndrome, maternal risk factors, tetralogy of Fallot, alcohol consumption, phenylketonuria, degree diabetes. Tition of great maternal risk factors, diabetes. Tricuspid valve atresia, Down syndrome. Epstein anomaly, prenatal lithium exposure. Total anomalous pulmonary venous return, heterotaxy syndromes. Persistent truncus arteriosus, DiGeorge syndrome. Trisomy 13, trisomy 18, Turner syndrome, left heart, SYND, Jacobson syndrome. General pathophysiological processes. Since CHDs result from the disruption of the normal cardiac morphogenesis sequence. Stent CHDs may lead to the formation of connections between the right and left heart, i.e., shunts. Plus in cyanotic CHDs, right to left cardiac shunting blood flow from the right to the left heart deoxygenated blood entering the systemic circulation cyanosis, I, copyright M A \, Al as general clinical features. Blue babies, pale gray or blue skin color caused by cyanosis. Scent feeding problems and failure to thrive, exertional dyspnea, tachypnea, and fatigue, scent hypoxemia, T2 symptoms of heart failure, C acyanotic congenital heart defects, plus nail clubbing may occur later in life. IS. Copyright in approximately 50% of infants with CHDs, a routine newborn physical examination reveals no abnormalities. A normal physical examination does not rule out CHPLL4. General treatment considerations 5. Ductal-dependent CHDs, a group of CHDs that require the patent ductus arteriosus, PDA, which supplies either pulmonary or systemic circulation, to sustain life until surgery can be performed. I. Back collapse. Find text outline. General treatment considerations 51. Scent ductal-dependent CHDs, a group of CHDs that require the patent ductus arteriosus, PDA, which supplies either pulmonary or systemic circulation, to sustain life until surgery can be performed. 6. OPDA supplies systemic circulation in the following, equals transposition of the great arteries, equals hypoplastic left heart syndrome, equals coarctation of the aorta, equals critical aortic valve stenosis. Copyright PDA supplies pulmonary circulation in the following, equals tricuspid atresia, equals critical pulmonary valve stenosis, tetralogy of Fallot 1. Copyright treatment, administration of prostaglandin E1 infusion, equals example, 4-alprostadil infusion. Mechanism of action, prevents the ductus arteriosus from closing, creating an intentional shunt to allow mixing of deoxygenated with oxygenated blood. Plus in patients with heart failure. 9. Copyright decrease fluid volume and lower pulmonary vascular resistance with diuretics or ACE inhibitors. Copyright improve the contractility of the heart with inotropic agents, example digoxin. Asterisk antibiotic prophylaxis for bacterial endocarditis during dental procedures, 0LL11. Copyright for all patients with unrepaired cyanotic CHDs. Copyright during the first 6 months after surgery. Scent surgical repair is required in most cases. The 5 Ts of cyanotic CHDs, tetralogy of Fallot, transposition of the great vessels, tricuspid valve anomalies, total anomalous pulmonary venous return, and persistent truncus arteriosus. Tetralogy of Fallot. Overview, 12. Scent definition, tetralogy of Fallot, TOF, is the simultaneous occurrence of the following 4 defects. Copyright right ventricular outflow tract obstruction, Ravato, due to pulmonary infundibular stenosis, O right ventricular hypertrophy, RVH, copyright ventricular septal defect, VSD, O overriding aorta, the aorta is displaced above the VSD, plus other cardiac defects associated with TOF. 3. Copyright atrial septal defect, ASD, OPDA. Copyright anomalous coronary arteries 1, 4I. And Ravato, right ventricular hypertrophy, ventricular septal defect, overriding aorta are the characteristics of tetralogy of Fallot. Epidemiology. Plus prevalence, 4-5/10,000 live births in the US. 15 the most common cyanotic CHD. 16 etiology. Plus typically sporadic, 17 associated with the following genetic disorders, copyright DiGeorge syndrome, 8LL19. Copyright Down syndrome. 20121 maternal exposures during pregnancy. Alcohol consumption. Copyright phenylketonuria. 22123 diabetes. J241L25, pathophysiology. Scent during fetal development, anterior and superior deviation of the infundibular septum misaligned VSD with overriding aortic root and subsequent Ravato-sent physiologic blood flow is determined by the severity of Ravato. Copyright a large VSD equal pressures in the right and left ventricles blood flow along the path of least resistance. Copyright severe Ravato flow from RV to LV desaturated blood entering the circulation via the aorta. Back collapse. Find text outline. Clinical findings. Infants with mild TOF may be asymptomatic on initial examination. Mild to severe cyanosis, which depends on the severity of the Ravato. Copyright mild obstruction more pronounced left to right shunt via VSD equals little or mild cyanosis, O severe obstruction more pronounced right to left shunt via VSD severe cyanosis, sent TET spells, intermittent hypercyanotic, hypoxic episodes with a peak incidence at 2 to 4 months after birth. 26-27 O associated with psychological and physical stress, example crying, feeding, defecation. Copyright caused by either an increase in pulmonary vascular resistance, PVR, or a decrease in systemic vascular resistance, SVR, intermittent worsening of Ravato and sent right to left shunting. 28,129 Copyright spells occur suddenly and are potentially lethal. Untreated children tend to squat, squatting TSVRJ right to left shunt FT blood flow to pulmonary circulation hypoxemia relief of symptoms sent cardiac examination findings. Copyright harsh systolic ejection murmur at the left upper sternal border. Copyright single S2 Copyright possible RV heave and systolic thrill sent CHF symptoms, see overview in heart failure. Copyright in patients with TOF, the auscultated murmur is determined by the amount of blood flow across the Ravato. Therefore, during TET spells, the murmur may disappear. Sent. Diagnostics. Sent prenatal diagnosis. Most cases are now diagnosed before birth due to improvements in fetal echocardiography. 30 Sent imaging O echocardiography, confirmatory test, equals detection of the main features of TOF equals quantification of right ventricular outflow tract pressure gradient equals supplementary cardiac catheterization may be performed. O chest X-ray equals boot-shaped heart, due to upturned cardiac apex and RVH, equals normal or decreased pulmonary vascular markings equals concave pulmonary artery segment ECG. Copyright right axis deviation. Copyright prominent anterior R waves, V1 V2, copyright prominent posterior S waves. Copyright right atrial enlargement and RVH, P pulmonal, sent pulse oximetry, SPO, sent hyperoxia test, helps to distinguish cardiac from pulmonary causes of cyanosis. Trademark. Treatment/5I31. Severe Ravato, PGE1 infusion until surgery, 8, plus acute hypoxia, TET spells, 7. 2 Copyright initial interventions equals administer oxygen, equals knee to chest position, squatting equals IM morphine, O subsequent interventions, consider if no improvement. Equals 4 Sodium bicarbonate to correct metabolic acidosis. 4 Fluid resuscitation. 4 equals vasopressors, example phenylephrine equals V beta blockers, example propranolol. 1 Sent heart failure. Copyright inotropic agents, example digoxin and loop diuretics, example furosemide. Copyright ACE inhibitors are not recommended in patients with TOF because they may decrease SVR and promote TET spells. Plus surgical repair, performed within the first year of life, 1, 831L34L. Copyright VSD repair, patch closure of the ventricular septal defect ensuring correct aortal positioning above the left ventricle. Copyright enlargement of the Ravato, resection of the obstructive infundibular musculature. Back collapse. Find text outline. Plus surgical repair, performed within the first year of life. 831/34 OVSD repair, patch closure of the ventricular septal defect ensuring correct aortal positioning above the left ventricle. Copyright enlargement of the Ravato, resection of the obstructive infundibular musculature. O if early surgical management is not possible, Palliative shunts, 35136 equals Blaylock-Thomas Tausig shunt, a palliative surgical procedure for TOF that connects the subclavian artery to the pulmonary artery within. Interposed graft equals central shunt equals others, example Potts shunt, Cooley shunt, Waterston shunt, Sano shunt, sent follow-up care, to prevent long-term complications, such as heart failure, arrhythmias, example ventricular tachycardia and neurodevelopmental impairment prognosis. Sent without surgery, 50% of patients do not live past the first 3 years of life. 37 sent with corrective surgery, over 90% of patients live to 25 years of age. 38. WY. CES. Transposition of the great vessels, TGV. Overview. Sent definition, anatomical reversal of the aorta and the pulmonary artery, sent other cardiac defects associated with TGV, degree VSD 189 pounds, O left ventricular outlet obstruction 401 O abnormal valves and / or coronary arteries epidemiology. Plus prevalence, 2-4/10,000 live births in the U.S., 5-16 plus accounts for 20% of all cyanotic CHD cases 116. Etiology. Sent often multifactorial or unknown plus intrauterine risk factors, infants born to mothers with diabetes, 151L24 sent genetic syndromes, seen in 1% of patients with DiGeorge syndrome. Pathophysiology/42. Sent failed spiraling of the aorticopulmonary septum RV emptying into the aorta and LV into the pulmonary artery complete isolation of the pulmonary and systemic circuits oxygenated blood entering the systemic circulation fatal, unless mixing occurs via an intracardiac shunt, example PFO, VSD, ASD, or via an extracardiac connection, example PDA. Clinical findings. Sent postnatal cyanosis, not affected by exertion or supplemental oxygen, asterisk tachypnea sent cardiac examination findings copyright single, loud S2 copyright there is often no murmur. Copyright diminished femoral pulses E if concurrent VSD is present, systolic murmur at the left sternal border. Diagnostics. Plus prenatal diagnosis, TGV is difficult to diagnose with fetal ultrasound. 43E imaging O echocardiography, confirmatory test, equals pulmonary artery arising from the left ventricle equals aorta arising from the right ventricle O chest X-ray equals egg on a string appearance of the heart equals the enlarged, globular heart resembles an egg lying on its side. Equals the string represents the superior mediastinum that appears narrow due to stress-induced thymic atrophy. Equals T pulmonary vascular markings O MRI, rarely done, showing the aorta arising from the right ventricle and the pulmonary trunk originating from the left ventricle. Back collapse fine text outline. Sent ECG, often normal sent pulse oximetry, SPO. U. Treatment 44. Sent initial postnatal management, initiate mixing between the two parallel circulations to ensure adequate systemic oxygenation. O infusion of PGE1 to prevent closure of the PDA 45 copyright balloon atrial septostomy, 461L47. Equals objective, to enhance atrial mixing if PGE1 administration is insufficient, and to alleviate hypoxemia 48 equals procedure, right heart catheterization with the creation or enlargement of an existing ASD plus surgical repair, recommended within the first 2 weeks of life. 1490-150 O arterial switch procedure, reversal of the aorta and pulmonary artery with insertion into the anatomically correct ventricle as well as correction of coronary artery supply, 1 LS2I copyright Rast Eli procedure, 53. 54 equals indication, TGV with concurrent large VSD and Lovato repair equals procedure, creation of a conduit from the Lovato through the VSD to the aorta and creation of a conduit from the RV to the pulmonary artery and. Prognosis. Sent without treatment, 90% of patients with TGA die within the first year of life. 55% long-term survival beyond 15 to 20 years of age is 90%. 51. 7 VOAE. Tricuspid valve atresia. Overview. Sent definition: O, absent or rudimentary tricuspid valve resulting in no blood flow between the RA and the RV. Copyright: patient survival is only possible if there are interatrial and interventricular communications. See other cardiac defects below. 56. Other cardiac defects associated with tricuspid valve atresia: OASD, OVSD, ORV, hypoplasia. Copyright: other defects, example pulmonary outflow obstruction, aortic stenosis, aortic coarctation. Epidemiology. Asterisk prevalence 0.2-1.2/10,000 live births in the US. 61 cent. Third most common cyanotic CHD. Pathophysiology. Tricuspid atresia is accompanied by RV hypoplasia and RA dilation due to volume overload. Univentricular heart. Sent circulation depends on the presence of interatrial and interventricular communications. Copyright: blood in the RA flows through the ASD into the LA. Venous blood mixes with arterial blood in the left heart. Cyanosis. Copyright: blood can only reach the RV and pulmonary system via OVSD. Clinical features. Asterisk central cyanosis occurs within days after birth, plus tachypnea. Cardiac examination findings: degree holosystolic murmur at the lower left sternal border. Back collapse. Fine text outline. Sent cardiac examination findings: O, holosystolic murmur at the lower left sternal border. O, single S2O. Jugular venous distension with a prominent A wave. Copyright: diminished peripheral pulses. Diagnostics. Sent prenatal diagnosis: fetal echocardiography at 18 to 22 weeks gestation. 57. Imaging. O, echocardiography, confirmatory test, equals absent tricuspid valve equals ASD equals RV hypoplasia. O, chest X-ray equals mild cardiomegaly equals abnormal pulmonary markings. ECC. 58. O, LVH with left axis deviation. Copyright: tall P waves. O, minimal R waves in precordial lead. Sent pulse oximetry, SPO. Treatment. Sent initial postnatal management, cardiopulmonary stabilization until surgical palliation. OPGE1 infusion. Copyright: cardiorespiratory support, example inotropes, mechanical ventilation, supplemental oxygen. Sent surgical repair, 3-stage surgical palliation to isolate both pulmonary and systemic circulations. See surgical repair in hypoplastic left heart syndrome. Sent optional temporary measures. O, in cases with concurrent pulmonary valve atresia or severe stenosis, systemic to pulmonary shunt. Blalock-Taussig shunt, to improve perfusion. Copyright: risk of pulmonary hypertension, pulmonary artery banding to control pulmonary hyperperfusion. Prognosis. With surgery, 90% of patients live to the age of 1 year and the 10-year survival rate is 80%. 56. OO. OFOS. Epstein anomaly. Overview. Sent definition: malformed tricuspid valve leaflets that are displaced into the right ventricle with subsequent tricuspid valve regurgitation and right heart enlargement, known as RV atrialization. Other cardiac defects associated with Epstein anomaly. Copyright: interatrial communication, example PFO, ASD seen in 90% of patients. 9O conduction disorders, example Wolff-Parkinson-White syndrome, supraventricular tachycardia. 60. Epidemiology. Plus prevalence, 0.5-1/10,000 live births in the US. 61 asterisk accounts for. Etiology. Asterisk multifactorial, most cases are sporadic. 21 plus associated with prenatal lithium exposure. Underscore 6 SLL 64 isolated genetic defects, example MYH7 which encodes B-myosin heavy chain. Pathophysiology. 5 degrees. Sent incomplete delamination, i.e., separation of valve tissue from the myocardium, during valve development can lead to one or more of the following: O. Incomplete closure of the right atrioventricular valve and reduction in RV volume, tricuspid regurgitation, RA dilation, right heart failure, O. RV atrialization, reduced function of the RV, insufficient systolic contraction, functional pulmonary valve atresia, pulmonary flow, J. Cardiac output, systemic hypoperfusion, dyspnea, and fatigue, O. Bulging of the large sail-like anterior tricuspid leaflet into the RV, Ravato equals TF, right heart pressure, T. Flow through the patent foramen ovale, right to left shunt, cyanosis. Back collapse, fine text outline. Clinical findings are O. Sent. The clinical presentation of Epstein anomaly varies according to the severity of the abnormality. 65. Copyright mild apical displacement, asymptomatic presentation throughout adulthood, O. Moderate tricuspid leaflet displacement, cyanosis or heart failure in infancy or childhood, O. Severe displacement in utero, heart failure, non-immune hydrops, fetalis death, E. Neonates and children, O. Cyanosis, O. Severe cardiomegaly and heart failure, O. Respiratory distress, E. Adolescents and adults, O. Arrhythmias, example Wolff-Parkinson-White syndrome 1, O. Exertional dyspnea and fatigue. Copyright palpitations and sudden cardiac death. Sent. Cardiac examination findings, O. Loud $1, J. Copyright widely split, S1 and S2. 4. Copyright hollow systolic murmur at the left sternal border, diagnostics. Sent. Prenatal diagnosis, fetal echocardiography, E. Imaging, O. Echocardiography, confirmatory test, equals enlarged right heart, equals tricuspid regurgitation, O. Chest X-ray 4 equals mild to severe cardiomegaly, equals RA enlargement, O. MRI 1, apical displacement of the septal and posterior tricuspid leaflets, ECG. Copyright tall and broad P waves, O. First degree atrioventricular block dash. Copyright right axis deviation 1. Copyright right bundle branch block. Copyright findings specific for WPW syndrome, example delta wave. Sent. Pulse oximetry, SPO. Treatment. Sent. Initial postnatal management, stabilization of cardiorespiratory status until PVR decreases and surgery can be performed. Copyright PGE1 infusion, O. Inhaled nitric oxide or infusion of milrinone 1. Sent. Surgical repair. Copyright objective, creation of a systemic pulmonary shunt, repair of the tricuspid valve, and reconstruction of the right ventricle, O. Age-related considerations equals neonates and infants, should be avoided in infancy and delayed as long as possible. Ill equals children and adults, recommended if concomitant heart failure or progressive RV dysfunction is present. 67. E. Arrhythmias, catheter ablation of the aberrant pathway. 68. Prognosis. E varies according to the severity of disease. E. Around 30% of patients die within the first year of life. 65. ZLRO, so. Total anomalous pulmonary venous return, TAPR. Overview. Sent. Definition, all four pulmonary veins drain into the systemic venous circulation, example SVC, sinus venosus, RA, IVC, instead of the left atrium. Sent. Other cardiac defects associated with TAPR allow for right to left shunting and the mixing of deoxygenated and oxygenated blood. Back collapse, fine text outline. Total anomalous pulmonary venous return, TAPR. Overview. Sent. Definition, all four pulmonary veins drain into the systemic venous circulation, example SVC, sinus venosus, RA, IVC, instead of the left atrium. Sent. Other cardiac defects associated with TAPR allow for right to left shunting and the mixing of deoxygenated and oxygenated blood, OASD-COPDA. Epidemiology. Plus prevalence, 0.6-1.2/10,000 live births in the US, 61. Etiology. Sent. Multifactorial, may be associated with genetic alterations, 69, plus associated with heterotaxy syndromes that involve asplenia, 7 degree 1L 71. Pathophysiology. The severity of symptoms and clinical presentation is determined by the following factors: venous mixing, oxygenated pulmonary venous return mixes with the systemic venous system, right to left shunting of partially oxygenated blood via an interatrial connection, example ASD, PFO, rarely PDA, into the systemic arterial circulation, cyanosis, pulmonary venous obstruction, obstruction of pulmonary venous return, T pulmonary venous pressure, T pulmonary edema, TTPVRRVH, ventricular dilation, and heart failure. Clinical features, 721. Scent cyanosis, scent respiratory failure, poor feeding and failure to thrive, scent hepatomegaly, 1 * cardiac examination findings, copyright O, fixed split S2 or loud S2, 4 copyright systolic ejection, murmur with diastolic rumble, or mild to no murmur. Diagnostics. Scent prenatal diagnosis, fetal echocardiography to detect abnormal pulmonary venous return, 173E imaging, copyright echocardiography, confirmatory test, equals malposition of pulmonary veins, equals enlarged right heart, equals right to left interatrial shunting, O chest x-ray, equals snowman sign, seen in supracardiac tap, where the orientation of the heart and superior mediastinum appear as the shape of a snowman, equals pulmonary hypervascularity, equals right heart enlargement, ECG, 72. Copyright nonspecific findings, copyright right axis deviation due to RVH, scent pulse oximetry, SPO, treatment. Scent initial postnatal management, stabilization of cardiorespiratory status until surgery is performed, example mechanical ventilation, supplemental OI, inotropes, scent surgical repair, recommended in all patients regardless of the severity of disease, 74. Prognosis. With surgical correction, the long-term survival rate is 80 to 90%. 75. Scent without treatment, 80% of patients die within the first year of life. 76. OO. OFON. Persistent truncus arteriosus. Overview. Back collapse, fine text outline. Persistent truncus arteriosus. Overview. Scent definition, underdevelopment of the aorticopulmonary septum, failure of the truncus arteriosus to divide into the aorta and pulmonary trunk, a single trunk that receives output from both ventricles. Scent other cardiac defects associated with persistent truncus arteriosus, OVSD. Copyright interrupted aortic arch, 77. Copyright coronary artery anomalies, 781. Epidemiology. Asterisk prevalence, 1/10,000 live births in the US4. Etiology. Scent the failure of neural crest cells to migrate during the development of the cardiac outflow tract results in incomplete AP septum formation. 79. Scent associated with DiGeorge syndrome, so S1. Pathophysiology. Scent deoxygenated and oxygenated blood mix via the VSD, the truncus arteriosus receiving both RV and LV output blood flow to both pulmonary and systemic circulations, plus the severity of disease is determined by pulmonary vascular resistance, PVR. Clinical features. Scent cyanosis, scent respiratory distress, scent failure to thrive, scent cardiac examination findings, copyright bounding peripheral pulses, O harsh systolic murmur at the lower left sternal border, copyright loud $2 diagnostics. Plus prenatal diagnosis, fetal echocardiography, 2. Scent imaging, copyright echocardiography, confirmatory test, single overriding great vessel arising from the heart, copyright chest x-ray equals right-sided aortic arch equals T pulmonary vascular markings equals absent thymus, if associated with DiGeorge syndrome. Scent ECG, often normal and nonspecific findings, scent pulse oximetry, SPO. Treatment. Scent initial medical management, stabilization of cardiopulmonary function, example diuretics, dopamine, ventilation, correction of metabolic acidosis, 9E. Surgical repair, surgical correction is recommended in the neonatal period. 83-84. Prognosis. Sent with surgical repair, the 30-year survival rate is 70%. 85. Hypoplastic left heart syndrome, HLHS. Overview. Sent definition, spectrum of disease consisting of severe hypoplasia of the left ventricle with possible stenosis and/or atresia of the mitral valve, aortic valve, or aortic arch. 8 cents. Epidemiology. Plus extremely rare, 2-3/10,000 live births in the U.S., 161/87 Fant. Back collapse fine text outline. At shared NC. Hypoplastic left heart syndrome, HLHS. Overview. Sent definition, spectrum of disease consisting of severe hypoplasia of the left ventricle with possible stenosis and/or atresia of the mitral valve, aortic valve, or aortic arch. 86 Epidemiology. Plus extremely rare, 2-3/10,000 live births in the US, 76 Li 87 plus sex at $1.5:1, 88, although rare, HLHS is responsible for 25 to 40% of all neonatal cardiac deaths. 89 Etiology. Sent multifactorial, associated with single gene polymorphisms, altered blood flow patterns, and intrauterine infection, Solf 91-192E syndromic associations, trisomy 13, trisomy 18, Jacobson syndrome, and Turner syndrome. 93-94 Pathophysiology. The hypoplastic left ventricle is non-functional, resulting in the RV becoming the primary supply for pulmonary and systemic circulations. Sent survival depends on the presence of a PDA, right-to-left shunt, and an ASD. 1. Clinical findings. Asterisk may be asymptomatic at birth if the open PDA provides adequate systemic perfusion, aggravation of symptoms following closure of the PDA plus postnatal cyanosis, not corrected by supplement 0, degree tachypnea 1 cent BPJ peripheral pulses, and cool extremities -1 cent heart failure and cardiogenic shock, 1 cent cardiac examination findings copyright typically no murmur 6, copyright loud, single S21 diagnostics. Plus prenatal diagnosis, fetal echocardiography 951 cent imaging copyright echocardiography, confirmatory test visualization of absent or hypoplastic LVO chest X-ray, variable and non-specific findings cent ECG, typically normal, cent pulse oximetry, SPO, treatment. Plus initial medical management, continuous PGE1 infusion prior to heart surgery. 96 cent surgical repair, palliative surgery is used in single ventricular cardiopathologies. 88 copyright 3-step staged surgical correction, 1 Norwood procedure, stage performed while the patient is a neonate 971 I98 equals Glenn procedure, stage 2 performed at 3 to 6 months of age 99 equals Fontan procedure, stage ill performed after 2 to 3 years of age 100 O alternative, heart transplant, 107 prognosis. Sent even with surgical correction, the 5-year survival rate remains low, 65%. 97 for patients that survive to 1 year of age, long-term survival, up to 18 years of age, is 90%. FROS 103. OOOE. Sources. Last updated January 29, 2024. Back collapse fine text outline. Fetal circulation postnatal circulation. Aorta fetal ductus arteriosus. Plus TTT. Pulmonary ligamentum arteriosum, obliterated ductus arteriosus. Pulmonary veins. Foramen ovale, closed, lung, inflated. Ligamentum venosum ductus venosus, obliterated ductus venosus, umbilical vein ligamentum teres navel, obliterated left umbilical vein, portal vein umbilical vessels, ligated. Umbilical medial umbilical ligament cord, umbilical artery, obliterated portion. Common iliac artery, external iliac artery, internal iliac artery. Umbilical artery, open portion artery to the ductus deferens, superior vesicle artery, blood oxygen content low hine. Fetal and postnatal circulation. Fetal circulation, left, is connected to the maternal circulation via the placenta. The umbilical vein delivers oxygen-rich blood from the placenta to the fetus, and the umbilical arteries return the blood to the placenta for oxygenation. Blood bypasses pulmonary circulation, entering from the right to the left atrium via the foramen ovale. Deoxygenated blood entering the right atrium through the superior vena cava bypasses pulmonary circulation via the ductus arteriosus, which connects the pulmonary trunk to the aorta. Postnatal circulation, right, is formed under the influence of postnatal pulmonary ventilation and the disconnection of umbilical vessels. These alterations cause a change in pressure within the circulatory system, leading to the opening of the pulmonary circulation and obliteration of the umbilical vessels and bypass structures. Blue, deoxygenated blood; red, oxygenated blood; pink, mixed blood. Copyright Embark. Cyanotic congenital heart defects, 2 halves. Digital clubbing VV. There is bulbous enlargement of the distal phalanges and the nail curvatures are markedly increased. Source: Congenital Heart Case 133 by Herbert L. Fred MD and Hendrik A. van Dijk, OpenStack CNX, licensed under CC by SA 3.0. Eurocyanotic congenital heart defects, 1/4. Tetralogy of Fallot VV. Tetralogy of Fallot is the simultaneous occurrence of a. Pulmonary stenosis, b. Right ventricular hypertrophy, c. Ventricular septal defect, VSD, d. An overriding aorta, above the VSD. The hemodynamic effects depend on the extent of right ventricular outflow tract obstruction. With mild obstruction, 1. A left-to-right shunt is more pronounced and there is mild cyanosis. With severe obstruction, 2. A right-to-left shunt is more pronounced, which results in severe cyanosis. Pulmonary circulation may be supplied via a patent ductus arteriosus. Copyright Embark. And hemodynamics. Cyanotic congenital heart defects, 2/4. TET spell in TOF. SE hypernia / cyanosis. Psychological or physical stress UIJ SVR and / or TPVR. T Ravato. T right to left shunting J blood flow to pulmonary circulation. TET spell in tetralogy of Fallot. Knee to chest positioning. At end normalization of = P breathing and = I2 blood oxygenation / trademark. J blood flow to the legs T SVR. J Ravato. J right to left shunting TT blood flow to pulmonary circulation. TET spells, hypercyanotic spells, are caused by a sudden decrease in systemic vascular resistance, SVR, or increase in pulmonary vascular resistance, PVR, leading to intermittent worsening of right ventricular outflow tract obstruction, Ravato, and increased right-to-left shunting. The resulting decrease in blood flow to the pulmonary circulation results in decreased blood oxygenation. Knee-to-chest positioning or, in older children, squatting relieves symptoms by increasing SVR, which in turn reduces right-to-left shunting and improves blood flow to the lungs. Copyright Embark. Cyanotic congenital heart defects, 3/4. Left ventricle. Ventricular septal. Defect left atrium. Tetralogy of Fallot. Echocardiography, transthoracic, modified parasternal long axis view, the ascending aorta overrides a large ventricular septal defect. The right ventricular wall is notably thickened from hypertrophy. These are characteristic findings in tetralogy of Fallot. Source, Figure 8 in Tetralogy of Fallot by Frederic Bale-Liard and Robert H. Anderson, Orphanet Journal of Rare Diseases, licensed under CC by 2.0. Modifications, added illustration. Urocyanotic congenital heart defects, 4/4. Overlay. Boot-shaped heart in tetralogy of Fallot VV. X-ray chest, PA view, of a patient with a history of tetralogy of Fallot. The cardiac apex is upturned from right ventricular hypertrophy, and the pulmonary artery segment is small and concave in appearance as a result of pulmonary stenosis. These findings produce a characteristic boot-shaped heart, green overlay, cf. Illustration, seen in some patients with tetralogy of Fallot. Pulmonary vascular markings are diminished as a result of reduced blood flow to the lungs. White dashed outline, normal size and shape of the heart source, boot-shaped heart by Medicalpol, Wikimedia Commons, licensed under CC by SA 4.0. Urocyanotic congenital heart defects, 4/4. Copyright. Overlay. Boot-shaped heart in tetralogy of Fallot VV. X-ray chest, PA view, of a patient with a history of tetralogy of Fallot. The cardiac apex is upturned from right ventricular hypertrophy, and the pulmonary artery segment is small and concave in appearance as a result of pulmonary stenosis. These findings produce a characteristic boot-shaped heart, green overlay, cf. Illustration, seen in some patients with tetralogy of Fallot. Pulmonary vascular markings are diminished as a result of reduced blood flow to the lungs. White dashed outline, normal size and shape of the heart source, boot-shaped heart by Medicalpol, Wikimedia Commons, licensed under CC by SA 4.0. Cyanotic congenital heart defects, 1/5. Normal. Transposition of the great vessels, TGV, VV. TGV is a cyanotic congenital heart disease in which the pulmonary artery arises from the left ventricle and the aorta from the right ventricle, resulting in the formation of parallel circulatory systems. The left ventricle pumps oxygenated blood into the pulmonary circulation, red, and the right ventricle pumps deoxygenated blood into the aorta, blue, resulting in cyanosis. TGV is fatal unless a shunt between the two circulations is present, i.e., a patent ductus arteriosus or a patent foramen ovale, or a surgical intervention is performed in the neonatal period. Copyright Embark. Urocyanotic congenital heart defects, 2/5. Patent ductus arteriosus. Atrial septal defect. Intracardiac shunt in the transposition of the great vessels. In transposition of the great vessels, deoxygenated blood enters the systemic circulation. Survival after birth is only possible via an intracardiac shunt, example across a patent ductus arteriosus and/ or a patent foramen ovale. The shunt diverts oxygenated blood from the pulmonary circulation into the systemic circulation, white arrows. Copyright Embark. Interventricular foramen C. Aorticopulmonary D. membranous, septum interventricular septum B. muscular interventricular EP septum. Ventricular septation VV. Development of the muscular interventricular septum and interventricular foramen. The primary ventricle is a single cavity that is separated from the atrial cavity by the endocardial cushion. Ventricular septation begins with the formation of a muscular interventricular septum, which arises from the floor of the primitive ventricle and grows cranially toward the endocardial cushion. The interventricular foramen is the space between the endocardial cushion and the growing edge of the muscular interventricular septum, and it allows for interventricular communication. LL, development of the aorticopulmonary septum. The aorticopulmonary septum develops from ridges of tissue derived from neural crest cells within the ventricular outflow tract, truncus arteriosus. These ridges are continuous with the bulbar ridges of the bulbar cordis, not shown here. 2. development of the membranous interventricular septum and closure of the interventricular foramen. The membranous interventricular septum develops from the bulbar ridges and the endocardial cushion. The caudal end of the aorticopulmonary septum fuses with the muscular interventricular septum and closes the interventrioulnar foramen. Cyanotic congenital heart defects, 3/5. Interventricular foramen C. Aorticopulmonary D. Membranous, F. Septum interventricular septum B. Muscular interventricular PP septum. Ventricular septation VV. LL, development of the aorticopulmonary septum. The aorticopulmonary septum develops from ridges of tissue derived from neural crest cells within the ventricular outflow tract, truncus arteriosus. These ridges are continuous with the bulbar ridges of the bulbar cordis, not shown here. IL, development of the membranous interventricular septum and closure of the interventricular foramen. The membranous interventricular septum develops from the bulbar ridges and the endocardial cushion. The caudal end of the aorticopulmonary septum fuses with the muscular interventricular septum and closes the interventricular foramen. 4. Division of the ventricular outflow tract. The aorticopulmonary septum fuses and rotates 180 degrees, dividing the outflow tract into the aorta, from the left ventricle, and pulmonary trunk, from the right ventricle. Copyright Embark. Cyanotic congenital heart defects, 4/5. Copyright. Overlay. Transposition of the great vessels. MRI cardiac, oblique sagittal plane, the aorta, AO, arises from the right ventricle, RV, while the pulmonary trunk, pulmonary artery, PA, originates from the left ventricle, LV. Source, Figure 5a in, The Role of Cardiovascular Magnetic Resonance in Pediatric Congenital Heart Disease by Hopewell N. Sanjana, Marina L. Hughes and Andrew M. Taylor, Journal of Cardiovascular Magnetic Resonance, Biomed Central, licensed under CC by 2.0. Modifications, removed NG. Cyanotic congenital heart defects, 5/5. Balloon atrial septostomy VV. IHE heart with transposition of the great vessels, 1 GV. Slight oxygen saturation of the blood occurs via the ductus arteriosus as well as a small atrial septal defect. This left-to-right shunt is enlarged using balloon atrial septostomy. 1. A balloon catheter is advanced into the right atrium through the inferior vena cava, then through the patent foramen ovale into the left atrium. 2. The correct positioning of the balloon is controlled via ultrasound. The balloon is expanded with a saline solution. 3. The balloon is pulled back through the foramen ovale into the right atrium, resulting in the fossa ovalis of the atrial septum tearing and creating an enlarged left-to-right shunt. 4. This results in an increase of oxygenated blood in the systemic circulation and a corresponding rise in saturation, usually directly following the procedure. However, balloon atrial septostomy is only a temporary measure. Patients with TGV will undergo an arterial switch surgery, which will result in a normal circulation of blood in the body. Urocyanotic congenital heart defects, 1/1. Normal heart tricuspid atresia patent ductus arteriosus. Patent foramen ovale tricuspid atresia ventricular septal defect underdeveloped right ventricle. Tricuspid valve atresia VV. A. Ascending aorta PT, pulmonary trunk PV, pulmonary valve RA, right atrium SVC, superior vena cava TV, tricuspid valve. Copyright Embark. Patent ductus arteriosus. Patent foramen ovale. Epstein anomaly. In the Epstein anomaly, the tricuspid valve is displaced into the lumen of the right ventricle, resulting in atrialization of the right ventricle. The remaining ventricle is small and hypocontractile. Because tricuspid valve regurgitation is also usually present, there is retrograde flow in the right atrium, which is dilated by the volume overload, in addition to antegrade pulmonary blood flow. Blood flows through the patent foramen ovale or, commonly associated, atrial septal defect from the right atrium to the left atrium, right to left shunt, and then via the left ventricle into the circulation, resulting in pronounced cyanosis. The pulmonary circulation system may also be perfused through blood from the aorta, via the ductus arteriosus. Copyright Embark. Epstein anomaly VV. AL, elongated anterior leaflet of the tricuspid valve, ARV, right ventricle, FRV, functional right ventricle, RA, right atrium, SL, septal leaflet of the tricuspid valve, asterisk, tethering of the septal leaflet of the tricuspid valve to the ventricular wall, LA, left atrium, LV, left ventricle, dotted lines, black in the autopsied heart, white in the ultrasonographic image identify the division between the RA and the RV. The leaflets of the tricuspid valve are tethered to the ventricular wall and displaced inferiorly into the lumen of the right ventricle. This results in the atrialization of the ARV, a small FRV, and a large RA. Cyanotic congenital heart defects, 3/3. Copyright. Overlay. Cardiomegaly in Epstein anomaly. X-ray chest, PA view, of a neonate with Epstein anomaly. The cardiac silhouette is markedly enlarged. Prominent convexity of the right heart border, green line, is the result of caudal displacement of the tricuspid valve with atrialization of the right ventricle and tricuspid regurgitation. The central pulmonary arteries, green arrowheads, and aortic knob, red arrowhead, are diminutive in appearance. An endotracheal tube is present, along with an umbilical venous catheter and nasogastric tube. Radiographic findings in Epstein anomaly may vary with the severity of the condition. Source, Figure 1, in, pure duplication of the distal long arm of chromosome 15 with Epstein anomaly and clavicular anomaly by R. O'Connor A. Al-Marani, S. Aftimos et al., Hindawi, Case Reports in Genetics, licensed under CC by 3.0. Cyanotic congenital heart defects, 3/3. Overlay. Cardiomegaly in Epstein anomaly. X-ray chest, PA view, of a neonate with Epstein anomaly. The cardiac silhouette is markedly enlarged. Prominent convexity of the right heart border, green line, is the result of caudal displacement of the tricuspid valve with atrialization of the right ventricle and tricuspid regurgitation. The central pulmonary arteries, green arrowheads, and aortic knob, red arrowhead, are diminutive in appearance. An endotracheal tube is present, along with an umbilical venous catheter and nasogastric tube. Radiographic findings in Epstein anomaly may vary with the severity of the condition. Source, Figure 1, in, pure duplication of the distal long arm of chromosome 15 with Epstein anomaly and clavicular anomaly by R. O'Connor A. Al-Marani, S. Aftimos et al., Hindawi, Case Reports in Genetics, licensed under CC by 3.0. Cyanotic congenital heart defects, 1/1. Normal heart total anomalous pulmonary venous return. Connecting vein. Pulmonary veins do not connect, to left atrium atrial septal equals defect. Total anomalous pulmonary venous return. A congenital heart defect in which the pulmonary veins merge to form a connecting vein that drains into the systemic venous circulation, example the vena cava, rather than the left atrium. Without return of blood to the left heart, there is no systemic circulation. Survival after birth depends on the presence of a right to left shunt, usually an atrial septal defect, to allow for blood to enter the left heart, then systemic circulation. Copyright Embark. Cyanotic congenital heart defects, 1/1. Normal heart persistent truncus arteriosus. Persistent truncus arteriosus ventricular septal defect. Persistent truncus arteriosus. Persistent truncus arteriosus, PDA, is a congenital cyanotic heart defect in which the truncus arteriosus fails to divide into the pulmonary trunk and aorta and instead remains as a single trunk that receives blood from both ventricles. The pulmonary circulation and systemic circulation are not separated from one another, therefore, deoxygenated and oxygenated blood mix. After birth, the pulmonary vascular resistance, PVR, drops, resulting in blood being shunted to the pulmonary circulation, leading to pulmonary congestion and subsequent heart failure. Copyright Embark. Normal heart hypoplastic left heart syndrome. Underdeveloped aorta patent ductus arteriosus. Atrial septal defect, underdeveloped mitral valve, underdeveloped aortic valve, hypoplastic left ventricle. Cyanotic congenital heart defects, hypoplastic left heart syndrome VV. Hypoplastic left heart syndrome is a cyanotic congenital heart defect in which the left ventricle, LV, does not form properly, resulting in an absent or hypoplastic LV stenosis and/or atresia of the mitral valve, aortic valve, and/or aortic arch are also possible. The left ventricle is non-functional, resulting in the RV becoming the primary supply for the pulmonary and systemic circulations. An atrial septum defect ensures that oxygenated blood from the lungs flows from the left atrium into the right atrium. A right-to-left shunt across the patent ductus arteriosus then ensures that blood flows from the main pulmonary artery to the aorta, to reach the systemic circulation. Copyright Embark. XX Acyanotic congenital heart defects. Acyanotic congenital heart defects, CHDs, are cardiac malformations that affect the atrial or ventricular walls, heart valves, or large blood vessels. Common causes include genetic defects, example trisomies, maternal infections, example rubella, or maternal use of drugs or alcohol during pregnancy. Acyanotic heart defects are pathophysiologically characterized by a left-to-right shunt, which causes pulmonary hypertension and right heart hypertrophy. The symptoms depend on the extent of the malformation and the resulting impairment of cardiac function. Infants may be asymptomatic or present with exercise intolerance, failure to thrive, and symptoms of heart failure. Characteristic heart murmurs are important clues for establishing the diagnosis, which is typically confirmed by visualizing the defect on echocardiography. Chest X-ray, MRI, or cardiac catheterization may also be required to determine indications for surgery and plan the procedure. Acyanotic heart defects requiring treatment are repaired via catheter procedures or surgery. Supportive medical therapy is required in cases of heart failure, example diuretics, inotropic agents, or if surgery cannot be performed, example prostaglandin. Complications are more likely the longer treatment is delayed, and include arrhythmias, embolisms, infective endocarditis, and reversal of shunt physiology, i.e., Eisenmenger syndrome. A. CE. Overview. Common acyanotic CHDs. Overview of acyanotic CHDs TTL, description associated conditions and risk factors. Defect in the interatrial septum Down syndrome, 1 atrial left to right shunt RA and RV volume overload atrial septal defect, ASD, fetal alcohol syndrome, 5, intrauterine infections, example torch, 6LT7. Defect in the interventricular septum sent ventricular left to right shunt sent RV and LV volume overload can cause pulmonary hypertension. Maternal diabetes. Ventricular septal defect, VSD, 8, Down syndrome 4 intrauterine infections, example torch, 6L, 7. Variable deficiency in atrioventricular, AV, septa atrioventricular septal defect plus AV left to right shunt possible, AVSD, AV valve regurgitation complete form associated with pulmonary hypertension Down syndrome 4. Persistence of the foramen ovale cordis after 1 year of age *, often asymptomatic, may be associated with other congenital heart diseases and syndromes, example Lewy sent in adults, may precipitate embolic strokes or be diagnosed Dietz syndrome, incidentally patent foramen ovale, PFO, 19. Fetal alcohol syndrome patent ductus arteriosus, PDA, degree persistence of the ductus arteriosus postnatally s congenital rubella I, left to right shunt from the aorta to the pulmonary artery Down syndrome 13. Stent narrowing of the aortic arch plus LV outflow tract obstruction coarctation of the aorta 151 * collateral circulation differential blood pressures distal systemic hypoperfusion in long segment coarctation. Turner syndrome 16. Narrowing at the pulmonary valve stenosis 7I18 plus RV outflow tract obstruction RV hypertrophy congenital rubella. And the 3DS of acyanotic CHDs, in order of frequency VSD, ASD, PDA. Pathogenesis, 19. Principles. Stent congenital heart defects, CHDs, are caused by the disruption of the normal sequence of cardiac morphogenesis. CHDs may lead to the formation of pathological connections, shunts, between the right and left heart chambers, allowing blood to flow along the pressure gradient from high pressure to low pressure. Plus the shunts are classified according to the direction of the blood flow as either left to right or right to left. 4. Shunt types. Stent left to right shunt. Back collapse fine text outline. Shunt types. Sent left to right shunt copyright oxygenated blood from the lungs is shunted back into the pulmonary circulation via an atrial septal defect, ASD, ventricular septal defect, VSD, or patent ductus arteriosus, PDA, pulmonary hypertension or right ventricular pressure overload right-sided heart hypertrophy, cardiomegaly on X-ray, and heart failure but no cyanosis, plus right to left shunt. Blood flows from the right to the left heart via a shunt deoxygenated blood entering the systemic circulation cyanosis dash. See Eisenmenger syndrome for details on how a left to right shunt can develop into a right to left shunt over time. QB left to right shunts equals later cyanosis. Right to left shunts equals early cyanosis. General clinical features. For specific features, see clinical features in the respective subsections. Nonspecific findings. Stent failure to thrive, stent recurrent bronchopulmonary infections, stent normal skin tone, stent exercise intolerance 1 copyright fatigue, pallor, and diaphoresis, sweating, copyright tachycardia o dyspnea copyright grunting, nasal flaring, retractions, and slash or head bobbing may be seen 20. Heart failure. Stent right heart failure copyright hepatic venous congestion with hepatomegaly copyright peripheral edema is rarely seen in infants. Val, stent left heart failure copyright tachypnea, pulmonary edema copyright low cardiac output, blood pressure, pallor, sweating, cool extremities, syncope. Medical management of acyanotic CHDs, 3. Nutritional support and routine vaccinations. Stent ductal dependent CHDs, prostaglandin E1 infusion to prevent PDA closure. Manage heart failure. Copyright respiratory support as needed. Copyright diuretics to decrease fluid volume. Copyright ACE inhibitors to lower systemic vascular resistance. Copyright inotropic agents, example digoxin, to improve cardiac contractility. Stent determine the need for surgical repair and postoperative antibiotic prophylaxis. Manage Eisenmenger syndrome if it develops. WA. OE. Cardiac septal defects. Comparison of a VSD and ASP3 ventricular septum defect, VSD, MS, 8, atrial septum defect, ASD, M. Epidemiology * most common congenital heart defect. Third most common CHD 22. Sent-Holt-Oram syndrome * intrauterine infections, example torch, 6L7 etiology plus Down syndrome M4 * Down syndrome I plus maternal diabetes degree. Sent fetal alcohol syndrome 15. Small defect usually asymptomatic. Clinical scent failure to thrive features medium-sized or large * recurrent bronchopulmonary infections exertional dyspnea, fatigue defect exercise intolerance recurrent bronchopulmonary infections degree CHF. Harsh hollow systolic murmur over the left lower sternal border RM degree typically louder in small defects systolic ejection murmur auscultation scent maneuvers that increase left ventricular afterload, example plus widely split second heart sound, S2, over the second left ICS, which is fixed, does hand grip, 7 intensity not change with respiration. Back collapse fine text outline. Harsh hollow systolic murmur over the left lower sternal border. Copyright typically louder in small defects systolic ejection murmur widely split second heart sound, S2, over the second left ICS, which is fixed, does hand grip, 7 intensity not change with respiration, auscultation E maneuvers that increase left ventricular afterload, example. Mid-diastolic murmur in case of pulmonary hypertension, loud pulmonic S. Small defect normal ECG findings ECG scent signs of RV hypertrophy ISN. Scent enhanced pulmonary vascular markings. 5F scent enlarged right atrium and ventricle chest X-ray * left atrial and ventricular enlargement enhanced pulmonary vasculature later stages, enlarged right ventricle and pulmonary artery. OO. AELI atrial septal defect, ASD. Description. Scent a defect in the atrial wall that may result from impaired growth or excessive resorption of the atrial septum epidemiology 3. Plus third most common CHD, 1/2,000 live births, 22 sex, etiology. Plus Down syndrome 4E fetal alcohol syndrome 5 scent intrauterine infections, example torch, LEL 7 plus Holt Oram syndrome, hand-heart syndrome, 5O autosomal dominant disorder copyright effects 1/100,000 children copyright characterized by ASD, a first-degree heart block, and abnormalities of the upper limbs, example absent radial bones, pathophysiology. Scent impaired growth or excessive resorption of the atrial septa in utero leads to atrial septal defects, absent atrial septa tissue. O ostium primum atrial septal defect, ASD 15 to 20%, usually accompanied by other heart defects, O ostium secundum atrial septal defect, ASD 270%, usually isolated, typically a low pressure, low volume, minor left to right shunt, therefore, patients are asymptomatic, sent ASD oxygenated blood shunting from LA to RA7 OS saturation in the RA7 ounces saturation in RV and pulmonary artery in more severe defects, the shunts may lead to supraventricular arrhythmias, pulmonary hypertension, and /or Eisenmenger syndrome. Clinical features 31. General. Scent depend on defect size and shunt volume small defects, usually asymptomatic E medium size to large defects O symptoms can vary from asymptomatic to heart failure. OASDs typically manifest with advancing age. 3C general clinical features above. Auscultation 1. Back collapse fine text outline. Auscultation 1. Scent systolic ejection murmur over the second left ICS sternal border scent widely split second heart sound, S, over the second left ICS. Which is fixed, does not change with respiration, scent soft mid-diastolic murmur over the lower left sternal border. AL. Septal defect. Diagnostics 23. Scent echocardiography, confirmatory test interatrial communication, best visualized in the apical forechamber and subcostal views 24 Scent ECG, signs of RV hypertrophy, vertical or right axis deviation, P pulmonale, PR prolongation, complete or incomplete right bundle branch block, Scent chest X-ray copyright enlarged right atrium, right ventricle, and pulmonary artery O enhanced pulmonary vasculature. Treatment/31. E-medical management, rarely required stent surgical repair, example transcatheter closure, patch. 4. Copyright right ventricular enlargement o large left to right shunts. Copyright clinical features of congestive heart failure. Copyright prior paradoxical embolism. Copyright up to 40% of ASDs spontaneously close by the age of 5 years. 25. Complications. 26. Paradoxical embolism, TF risk of ischemic stroke. Small blood portions from inferior vena cava bypass pulmonary circulation. Direct emptying into left atrium. Paradoxical embolism and stroke in the case of thromboembolism. Stent heart failure. WACE. Leventricular septal defect, VSD. Description: an abnormal communication between the left and right ventricle that results in left-to-right shunting of blood flow. Epidemiology. Asterisk most common congenital heart defect, 4/1,000 live births, 27% occurs as an isolated heart defect or in combination with others, example with AVSD, tetralogy of Fallot, TGA, etiology. Genetic syndromes. 3OE most commonly, Down syndrome, Edwards syndrome, Patau syndrome. EO less commonly, Cri-du-Chat syndrome, Apert syndrome. Asterisk intrauterine infections, example Torch, 6L7 maternal risk factors, diabetes, obesity, smoking. 27/9 pathophysiology. Most commonly located in the membranous part of the ventricular septum, pars membranacea, stent defect in ventricular septum. Left to right shunt with the following consequences, asterisk, EORV volume overload. RV eccentric hypertrophy. Copyright excessive pulmonary blood flow plus TT pulmonary artery pressure. Pulmonary hypertension. O cardiac output. OLV volume overload. LV eccentric hypertrophy. Copyright FT up saturation in right ventricle and pulmonary artery. Back collapse. Fine text outline. Clinical features. 18. General. Stent small defects, usually asymptomatic. Stent medium-sized or large defects. O lead to heart failure by the age of 2 to 3 months. O become symptomatic after high pulmonary vascular resistance, PVR, present at birth starts to decrease. PVRJ right ventricular pressure. 7 left to right shunt symptoms. Copyright see nonspecific findings and heart failure in overview above. Stent hyperdynamic precordium may be detected in hemodynamically relevant defects. Auscultation. Stent harsh hollow systolic murmur over the left lower sternal border. O becomes more intense with maneuvers that increase left ventricular afterload, example hand grip. Copyright typically louder in small defects. Mid diastolic murmur over cardiac apex. Stent loud pulmonic S, if pulmonary hypertension develops. Systolic thrill, 1. UI. Ular septal defect. Add, symptoms of heart failure in children with VSD only develop when PVR decreases to adult levels and thus allows left to right shunting to occur. Diagnostics aid. Stent echocardiography, confirmatory test, copyright to assess defect size and shunt volume. Copyright Doppler ultrasound findings of pathological left to right blood flow can help diagnose minor ventricular defects. EECG. Copyright small defects, normal ECG findings. O medium-sized or large defects equals signs of LV hypertrophy, due to volume loading. TQRS amplitude, left axis deviation, left atrial enlargement equals signs of RV hypertrophy, due to pulmonary hypertension or obstruction of the pulmonary outflow tract. Vertical or right axis deviation, P pulmonal, PR prolongation, complete or incomplete right bundle branch block. Stent chest X-ray. O enhanced pulmonary vascular markings. Copyright left atrial and ventricular enlargement. Copyright in later stages, enlarged right ventricle and pulmonary artery, due to elevated PVR. Treatment. 823. Stent small defects. O often close spontaneously and rarely require surgical interventions. Copyright follow-up echocardiography is recommended. Stent symptomatic and large defects. O all patients, provide medical management of acyanotic CHDs as needed. Copyright surgical repair, example patch, equals infants with large left to right shunts with clinical symptoms, example failure to thrive, treatment-resistant congestive heart failure, equals asymptomatic older children with large left to right shunts or evidence of left atrium or left ventricular dilatation equals VSD with aortic insufficiency or aortic valve prolapse into the VSD equals pulmonary hypertension. At VSD closure results in lower right ventricular and left atrial pressures and higher left ventricular pressures than pre-closure values. 28. CQ, VSD closure is contraindicated in patients with Eisenmenger syndrome. 3. Back collapse. Find text outline. Complications: arrhythmia, heart failure, Eisenmenger syndrome, infective endocarditis, aortic regurgitation. OOG. G. Atrioventricular septal defect, AVSD. Definition 3. A defect of atrioventricular valves, i.e., mitral and tricuspid valves, as well as the atrial and/or ventricular septum, previously referred to as endocardial cushion defects. Complete form, ASD and VSD, common AV valve. Partial form, only ASD and minor AV valve abnormalities. Etiology plus strongly associated with Down syndrome __, 29,130. Association with maternal diabetes and obesity has been shown in some studies. 31. Pathophysiology 3. Complete form, ASD and VSD, equals atrial and ventricular left to right shunt, excessive pulmonary blood flow and biventricular volume overload, pulmonary hypertension and heart failure. Partial form, ASD only, atrial left to right shunt, symptoms that may remain minimal until adulthood. In both forms, abnormal AV valve regurgitation in utero, heart failure, non-immune hydrops fetalis. 32. Clinical features. 31. Complete form, see nonspecific findings and heart failure in overview above. Plus partial form, see clinical features in atrial septal defect, ASD. 1. Diagnostics. 33. Antenatal echocardiography, findings of endocardial cushion defect in first trimester, screening for Down syndrome. Echocardiography, confirmatory test to assess defect size, shunt volume, and global cardiac function. ECG, left axis deviation due to LVH. Chest X-ray. Copyright. Complete form, global cardiomegaly, T. Pulmonary markings. Copyright. Partial form, enlarged right heart and pulmonary artery. 1. Treatment, 141 I331 I3. All patients, provide medical management of acyanotic CHDs as needed. Surgical management, patch closure and AV valve reconstruction. WAOE. Patent foramen ovale, PFO. Description: a variant of cardiac anatomy in which the foramen ovale remains patent beyond 1 year of age. Epidemiology plus prevalence, 25% of the general population. 34. Etiology * associated with Louis-Dietz syndrome. Pathophysiology plus failure of the atrial septum primum to fuse with the septum secundum following birth. Persistence of foramen ovale. Mild left to right shunt. Shunt reversal may be induced by certain maneuvers that increase right atrial pressure, example Valsalva maneuver, coughing. QBASD equals septal tissue deficiency. PFO equals enough tissue, but problems with fusion. Clinical features. Back collapse. Find text outline. Clinical features. Affected individuals are usually asymptomatic until complications occur. Diagnostics. 35. PFOs are sometimes an incidental finding during procedures, example PCI, cardiac surgery, or must be evaluated for after an embolic event, example ischemic stroke. TTE with agitated saline, best initial test to evaluate for a right to left shunt. Indications for T with agitated saline. Copyright inconclusive. TTE. Copyright high index of suspicion for PFO despite negative TTE. Treatment, 10. Sent asymptomatic PFO, treatment is not usually required. Plus confirmed PFO after embolic event, example ischemic stroke. 4L copyright requires multidisciplinary evaluation by cardiology and neurology to determine the likelihood of paradoxical embolism from PFO. Degree treatment may include antiplatelet agents or anticoagulation equals surgical or percutaneous closure of the defect. Copyright PFO is one of many possible causes of stroke. Reducing subsequent stroke risk should include the evaluation of other potential causes, example arrhythmia, hypercoagulability, endocarditis. 10. Complications 36. Stent paradoxical embolism. Stent ischemic stroke. Systemic embolisms, example renal infarction. VA. And patent ductus arteriosus, PDA. Description: failure of the ductus arteriosus to completely close postnatally. Epidemiology: plus incidence, 5 to 10% full-term births. 37 plus in premature infants, 20 to 60%. 37 plus sex, 27, 2:1, 8. Etiology: stent prematurity. Maternal exposure during pregnancy or rubella infection, during the first trimester of pregnancy. Copyright alcohol consumption. Copyright phenytoin use, fetal hydantoin syndrome. Copyright prostaglandin use. Stent respiratory distress syndrome. Stent trisomies, example Down syndrome. Pathophysiology: stent ductus arteriosus enables the underdeveloped lungs to be bypassed by the fetal circulation, normal right to left shunt, and remains patent in utero via PGE and low O tension. Stent after birth, pulmonary vascular resistance decreases and thus allows for the reversal of the shunt from right to left to right. Stent failure of the ductus arteriosus to close after birth. Persistent communication between the aorta and the pulmonary artery. Left to right shunt. Volume overload of the pulmonary vessels. Continuous RV, and/or LV, strain. Heart failure. See also overview above. Eisenmenger syndrome may occur with shunt reversal and manifest with differential cyanosis. Y and AOO. Back collapse. Fine text outline. Clinical features: general, small PDA, asymptomatic with normal findings on physical examination. Large PDAO. Nonspecific symptoms, example failure to thrive, and symptoms of heart failure in infancy. See the overview above. Copyright bounding peripheral pulses, wide pulse pressure 3 degrees O. Heaving, laterally displaced apical impulse 1. Auscultation: small PDA, a murmur is sometimes heard incidentally during routine primary care visits. Stent large PDA, machinery murmur, loud continuous murmur heard best in the left infraclavicular region, and loudest at soma as WK. Ductus asteriosut. Copyright PDA comes with prolonged deafening auscultation findings. Diagnostics 111,139. Stent echocardiography, confirmatory test. Copyright findings may show left atrial and ventricular dilatation O used to assess shunt volume and pulmonary artery pressure. Copyright color Doppler, findings may show blood flow from the aorta into the pulmonary artery. Stent ECG. Copyright normal findings in small PDA. Copyright left axis deviation due to LVH seen in large PDA. Stent chest X-ray. Copyright prominent pulmonary artery and aortic knob at the upper left heart border. Copyright increased pulmonary markings. Stent cardiac catheterization and angiography, only necessary prior to repair or in more complex CHDs. Treatment 111L12. Management of PDA is complex and based on the specific PDA, example size of left to right shunt, and patient characteristics, example weight, age. PDA closure, 14. Scent indications copyright heart failure symptoms copyright left atrial and / or left ventricular enlargement copyright pulmonary hypertension without right to left shunt scent contraindications copyright ductal dependency HDO pulmonary hypertension with right to left shunt methods copyright transcatheter occlusion copyright surgical ligation. Pharmacological closure in premature infants 1. The management of premature infants with a PDA is complex and requires a multidisciplinary team including a neonatal intensivist and pediatric cardiologist. Scent indications copyright infants with birth weight 1 kg with symptomatic PDA, example heart failure symptoms, respiratory distress, scent contraindications copyright ductal dependency HD copyright persistent pulmonary hypertension of the newborn scent treatment, indomethacin and ibuprofen induce PDA closure by inhibiting prostaglandin synthesis. OA3 scent alternatives. Back collapse fine text outline. Scent treatment, indomethacin and ibuprofen induce PDA closure by inhibiting prostaglandin synthesis. A. Degree E alternatives O. Percutaneous catheter occlusion copyright surgical ligation. Copyright PDA closure is contraindicated if the PDA is required for survival, example ductal dependent CHDs initiate a prostaglandin E1 infusion to keep the ductus arteriosus patent until definitive treatment can be performed. 40. Complications 38. Scent heart failure in infancy scent infective endocarditis common cause of pulmonary hypertension and Eisenmenger syndrome in adolescents and adults scent differential cyanosis. WA. CE. Coarctation of the aorta. Definition. Scent narrowing of the aorta at the aortic isthmus or, rarely, in the descending thoracic or abdominal aorta epidemiology 41. Prevalence, 3/10,000 live births e-sex, $7. Etiology 21. Congenital. Scent exact cause is unknown, but two hypotheses have been proposed. O. Hemodynamic, caused by underdevelopment of the aorta due to an abnormally decreased antegrade intrauterine blood flow copyright ductal, caused by closure of the ductus arteriosus tissue that extends into the thoracic aorta scent associated with Turner syndrome, in 5 to 15% of female patients with coarctation, 4216** often accompanied by a bicuspid aortic valve, VSD, and / or PDA. Acquired. Itakeasu arteritis E. Severe atherosclerosis pathophysiology, L2. Scent genetic defects and / or intrauterine ischemia medial thickening and intimal hyperplasia formation of a ridge encircling the aortic lumen narrowing of the aorta T-flow proximal to the narrowing and J-flow distal to the narrowing copyright coarctation is most commonly juxtadictal. Copyright the coarctation most commonly occurs distal to the left subclavian artery, where the ductus arteriosus originates. Rarely, the coarctation occurs in the lower segments of the thoracic aorta or in the abdominal aorta in discrete coarctation, left ventricular outflow obstruction myocardial hypertrophy and increased collateral blood flow, example intercostal vessels, scapular vessels. In long segment coarctation, closure of PDA after birth left ventricular pressure and volume overload hypoperfusion of organs and extremities distal to the stenosis 43. Clinical features 21. General. Neonates OE asymptomatic if the coarctation is mild and PDA is present asymptomatic in critical stenosis, blood flow to the lower body is PDA dependency overview. May be asymptomatic in older infants, children, and adults. Potential features include, copyright differential cyanosis, cyanosis of the lower extremities C. brachial femoral delay, weak femoral pulses ET blood pressure, BP, in upper extremities and BP in lower extremities. Back collapse fine text outline. Scent may be asymptomatic in older infants, children, and adults. Potential features include, copyright differential cyanosis, cyanosis of the lower extremities, brachial femoral delay, weak femoral pulses degree T blood pressure, BP, in upper extremities and BP in lower extremities equals in distal narrowing of the left subclavian artery, TBP in both arms and JBP in both legs equals in origin of left subclavian artery is involved, BP in the right arm in left arm 4, copyright cold feet and lower extremity. Claudication upon physical exertion copyright strong apical impulse displaced to the left O headache, epistaxis, tinnitus copyright in severe stenosis, shock and multi-organ failure when ductus arteriosus closes O in severe stenosis, see nonspecific findings and heart failure in overview above. Auscultation plus systolic ejection murmur over left posterior hemithorax and / or continuous murmur below the left clavicula and between the shoulder blades. Diagnostics. Sent blood pressure measurements, best initial test BP measurements for upper and lower extremities to check for brachial femoral delay. Sent post-coarctation pulse oximetry, SPO, may be present, EECG O newborns, signs of RV hypertrophy copyright older children, normal or signs of LV hypertrophy. Sent Doppler echocardiography, confirmatory test location and extent of stenosis, detection of concurrent anomalies, VSD, PDA, bicuspid aortic valve, degree X-ray copyright cardiomegaly and T pulmonary vascular markings. O figure of 3 sign, the result of an hourglass-like narrowing of the aorta caused by predilatation and post-dilatation of the aorta with an indentation at the site of coarctation. Copyright rib notching, a radiographic sign caused by collateral circulation between the internal thoracic and intercostal arteries equals enlarged vessels compress the neighboring ribs, causing pressure atrophy. Equals classically affects the inferior border of the 3/8 ribs. Sent MRI or CT. Copyright in complicated cases and in adults. Copyright to determine the length of coarctation and for intervention planning. Sent genetic testing, for Turner syndrome, 16. BFA. Treatment, 1I15. Sent neonates with critical coarctation. Copyright initiate prostaglandin E1 infusion. O medical management of acyanotic CHDs, example inotropic support, respiratory support. Sent non-critical coarctation, 145. Copyright surgical correction, preferred in neonates. 3. Copyright balloon angioplasty. Copyright stent placement. Sent follow-up, monitor for restenosis, aortic aneurysm, and aortic dissection. Complications. Sent secondary hypertension. Sent aortic dissection and rupture. Sent Berry aneurysm. Cerebral hemorrhage, 46. Sent heart failure. Infective endocarditis. OOCES. Pulmonary valve stenosis. Description. Sent avalvular heart disease characterized by obstruction of blood outflow from the right ventricle into the pulmonary arteries during systole. Epidemiology. Back collapse. Find text outline. Pulmonary valve stenosis. Description. A valvular heart disease characterized by obstruction of blood outflow from the right ventricle into the pulmonary arteries during systole. Epidemiology. Sent relatively common in the general population, 10% of all CHDs, 3, plus usually congenital, rarely acquired. Pathophysiology. Pulmonary valve stenosis. Right ventricular outflow obstruction. Pressure overload. Right ventricular hypertrophy. Clinical features. Sent depending on the grade of stenosis, symptoms of heart failure may occur. Sent systolic murmur heard best over the second left ICS at the sternal border plus S wide splitting 1. Diagnostics, 171. Sent echocardiography, confirmatory test to assess the severity of stenosis. Chest X-ray, may show pulmonary artery dilatation. 1 treatment, 171 I18. Plus neonates with critical pulmonary valve stenosis. 4715. Copyright maintain PDA until definitive treatment can be performed. O method, prostaglandin E1 infusion. Sent non-critical pulmonary valve stenosis. O repair is indicated in symptomatic patients, with moderate to severe pulmonary valve stenosis. O procedures include balloon valvuloplasty of the pulmonary valve, first line, and surgical commissurotomy. 7 degrees. A. Eisenmenger syndrome. Description 31L48. A complication of acyanotic heart disease in which the shunt reverses over time and cyanotic heart disease develops. Stent can occur at any age, but usually develops during late stages of CHD's etiology. 31. Eisenmenger syndrome may develop with any cardiac defect with a left-to-right shunt, but common defects include complete AVSD stent persistent truncus arteriosus stent VSD * PDA pathogenesis. 31I48. 1 left-to-right shunt prolonged pulmonary hypertension reactive constriction with permanent remodeling of pulmonary vessels irreversible pulmonary hypertension. 2. Pulmonary hypertension RV hypertrophy increased RV pressure. 3. RV pressure exceeds LV pressure shunt reversal, development of right-to-left shunt, cyanosis, digital clubbing, and polycythemia. Clinical features. 31. Children at risk of Eisenmenger syndrome are often minimally symptomatic, symptoms worsen with age and with increasing pulmonary resistance. Stent cyanosis. Copyright central cyanosis is prominent. Copyright differential cyanosis, cyanosis in the lower extremities, seen in patients with PDA, stent digital clubbing. Chest pain. Diagnosis. Back collapse. Fine text outline. Acyanotic congenital heart defects. Stent systolic murmur heard best over the second left ICS at the sternal border * so wide splitting. 1. Diagnostics, 171. Echocardiography, confirmatory test to assess the severity of stenosis * chest X-ray, may show pulmonary artery dilatation. 1 treatment, 171 I18. Plus neonates with critical pulmonary valve stenosis. 4713. Copyright maintain PDA until definitive treatment can be performed. O method, prostaglandin E1 infusion. Stent non-critical pulmonary valve stenosis. O repair is indicated in symptomatic patients. 1 with moderate to severe pulmonary valve stenosis. O procedures include balloon valvuloplasty of the pulmonary valve, first line, and surgical commissurotomy. OI, OE. Eisenmenger syndrome. Description 31L48. Stent a complication of acyanotic heart disease in which the shunt reverses over time and cyanotic heart disease develops. Stent can occur at any age, but usually develops during late stages of CHD's etiology. 31. Eisenmenger syndrome may develop with any cardiac defect with a left-to-right shunt, but common defects include complete AVSD * persistent truncus arteriosus VSD PDA. Pathogenesis. 31I48. 1 left-to-right shunt prolonged pulmonary hypertension reactive constriction with permanent remodeling of pulmonary vessels irreversible pulmonary hypertension. 2. Pulmonary hypertension RV hypertrophy increased RV pressure. 3. RV pressure exceeds LV pressure shunt reversal, development of right-to-left shunt, cyanosis, digital clubbing, and polycythemia. Clinical features. 3. Children at risk of Eisenmenger syndrome are often minimally symptomatic, symptoms worsen with age and with increasing pulmonary resistance. Cyanosis. Copyright central cyanosis is prominent. Copyright differential cyanosis, cyanosis in the lower extremities, seen in patients with PDA, stent digital clubbing. Stent chest pain. Diagnosis. Echocardiography, to assess the underlying defect, evaluate shunt direction, and estimate RV and pulmonary arterial pressures. Stent cardiac catheterization, to evaluate the extent of the shunt and measure the pressure in the heart and pulmonary circulation. Treatment. 3. Treatment should be guided by specialists in pulmonary hypertension and pediatric cardiology. Treatment includes stent medical management of acyanotic heart defects, treatment of pulmonary hypertension, stent rare cases, surgical treatment. Copyright heart-lung transplant or lung transplant with correction of CHD. Copyright limited by lack of donors and poor prognosis. Back collapse fine text outline. Equals acyanotic congenital heart defects, 1/2. Brachiocephalic artery left common carotid artery aorta left subclavian artery superior vena cava ligamentum arteriosum right pulmonary artery pulmonary artery pulmonary trunk, left pulmonary veins right pulmonary veins left atrium. Pulmonary valve aortic valve. Right atrium mitral valve. Opening of coronary sinus tendinous cords left ventricle tricuspid valve on /1 papillary muscle right ventricle AA interventricular septum inferior vena cava. Anatomy of the heart and adjacent large vessels VV. Blue, structures that carry deoxygenated blood. Red, structures that carry oxygenated blood. Copyright Embark. Fetal circulation postnatal circulation. Aorta fetal ductus arteriosus. Plus TTT. Pulmonary ligamentum arteriosum, obliterated ductus arteriosus. Pulmonary veins. Foramen ovale, closed, lung, inflated. Ligamentum venosum ductus venosus, obliterated ductus venosus, umbilical vein ligamentum teres navel, obliterated left umbilical vein, portal vein umbilical vessels, ligated. Umbilical medial umbilical ligament cord, umbilical artery, obliterated portion. Common iliac artery external iliac artery internal iliac artery. Umbilical artery, open portion artery to the ductus deferens superior vesicle artery blood oxygen content low hine. Fetal and postnatal circulation. Fetal circulation, left, is connected to the maternal circulation via the placenta. The umbilical vein delivers oxygen-rich blood from the placenta to the fetus, and the umbilical arteries return the blood to the placenta for oxygenation. Blood bypasses pulmonary circulation entering from the right to the left atrium via the foramen ovale. Deoxygenated blood entering the right atrium through the superior vena cava bypasses pulmonary circulation via the ductus arteriosus, which connects the pulmonary trunk to the aorta. Postnatal circulation, right, is formed under the influence of postnatal pulmonary ventilation and the disconnection of umbilical vessels. These alterations cause a change in pressure within the circulatory system, leading to the opening of the pulmonary circulation and obliteration of the umbilical vessels and bypass structures. Blue, deoxygenated blood. Red, oxygenated blood. Pink, mixed blood. Copyright Embark. Cardiac hemodynamics in ventricular septal defect VV. A defect in the ventricular septum leads to a left-to-right shunt, the volume of which is dependent on the size of the defect. Blood flows from the left ventricle to the right ventricle, white arrow, along the pressure gradient, 1. This leads to increased RV and LV preload, due to increased end diastolic volume, ventricular hypertrophy and dilation, double-headed white arrows, and pulmonary hypertension resulting from excessive pulmonary blood flow, 2. In end-stage disease, the pressure gradient is reversed because of Eisenmenger syndrome, shunt reversal, leading to the flow of mixed blood to the systemic circulation, white arrow, and subsequent cyanosis, 3. Blue, structures that contain deoxygenated blood. Red, structures that contain oxygenated blood. Purple, structures that contain mixed blood. Copyright Embark. Equals acyanotic congenital heart defects, 2/5. Cardiac hemodynamics in atrial septal defect VV. An atrial septal defect causes blood to flow from the left to the right atrium, left to right shunt, white arrow, resulting in volume overload of the right atrium and ventricle, 1. As a result, there is dilation and compensatory hypertrophy, double-headed white arrows, of the right atrium and ventricle, 2. In the late stages, Eisenmenger syndrome with shunt reversal, right to left shunt, white arrow, and cyanosis can occur, 3. Blue, structures that contain deoxygenated blood. Red, structures that contain oxygenated blood, purple, structures that contain mixed blood. Copyright Embark. Euroacyanotic congenital heart defects, 3/5. In electrocardiogram, ECG. Heart murmur in ventricular septal defect, mitral regurgitation, and tricuspid regurgitation. Holosystolic murmur, often referred to as pansystolic murmur in the case of a ventricular septal defect. Copyright Embark. Copyright Overlay. Ventricular septal defect VV. Color Doppler echocardiography. There is a moderate defect in the mid part of the septum. The blood flow through the defect is displayed in different colors. The red mark in the trace, lower left, shows the moment during the cardiac cycle that the image was captured. This is the typical presentation of a ventricular septal defect. IVs, interventricular septum, LA, left atrium, LV, left ventricle, MV, mitral valve, RA, right atrium, RV, right ventricle, TV, tricuspid valve. Source, ventricular septal defect, Echo, Wikimedia Commons licensed under public domain. Acyanotic congenital heart defects, 5/5. Atrial septal defect VV. Transesophageal echocardiography. A defect, white arrow, located between the left atrium, LA, and right atrium, RA, can be seen on the regular ultrasound image, A. There is also an atrial septal aneurysm bulging into the left atrium just below the defect. The color Doppler ultrasound image, B, shows the blood flow through the defect. This is the typical echocardiographic appearance of the atrial septal defect. Source, Figure 1 in, platypnea orthodoxia associated with a fenestrated atrial septal aneurysm, case report by William J. Van Gaal Dr., Majo Joseph Dr., Elizabeth Jones Dr., George Modelanis Dr. and Mark Horrigan Dr., Cardiovascular Ultrasound Journal, Biomed Central, licensed under CC by 2.0. Ascending aorta. Pulmonary trunk superior vena cava. At the level of the tricuspid valve. Inferior vena cava. Types of atrial septal defects VV. A. ASD2/ostium secundum. Atrial septal defect is the impaired growth of the septum secundum or excessive resorption of the septum primum. The defect is located in the fossa ovalis, in the cranial part of the atrial septum. B. ASDI/ostium primum. Atrial septal defect is the incomplete fusion of the septum primum with the endocardial cushion, caudal part of the atrial septum, near the ventricular septum. C. Sinus venosus ASD, rare defect. D. Coronary venosus ASD, rare defect. Copyright Embark. Acyanotic congenital heart defects, 2/3. Cardiac hemodynamics in atrial septal defect VV. An atrial septal defect causes blood to flow from the left to the right atrium, left to right shunt, white arrow, resulting in volume overload of the right atrium and ventricle. 1. As a result, there is dilation and compensatory hypertrophy, double-headed white arrows, of the right atrium and ventricle. 2. In the late stages, Eisenmenger syndrome with shunt reversal, right to left shunt, white arrow, and cyanosis can occur. 3. Blue, structures that contain deoxygenated blood, red, structures that contain oxygenated blood, purple, structures that contain mixed blood. Copyright Embark. Acyanotic congenital heart defects, 3/3. Atrial septal defect VV. Transesophageal echocardiography. A defect, white arrow, located between the left atrium, LA, and right atrium, RA, can be seen on the regular ultrasound image, A. There is also an atrial septal aneurysm bulging into the left atrium just below the defect. The color Doppler ultrasound image, B, shows the blood flow through the defect. This is the typical echocardiographic appearance of the atrial septal defect. Source, Figure 1 in, platypnea orthodoxia associated with a fenestrated atrial septal aneurysm, case report by William J. Van Gaal Dr., Majo Joseph Dr., Elizabeth Jones Dr., George Modelanis Dr. and Mark Horrigan Dr., Cardiovascular Ultrasound Journal, Biomed Central, licensed under CC by 2.0. Cardiac hemodynamics in ventricular septal defect VV. A defect in the ventricular septum leads to a left-to-right shunt, the volume of which is dependent on the size of the defect. Blood flows from the left ventricle to the right ventricle, white arrow, along the pressure gradient, 1. This leads to increased RV and LV preload, due to increased end diastolic volume, ventricular hypertrophy, and dilation, double-headed white arrows, and pulmonary hypertension resulting from excessive pulmonary blood flow, 2. In end-stage disease, the pressure gradient is reversed because of Eisenmenger syndrome, shunt reversal, leading to the flow of mixed blood to the systemic circulation, white arrow, and subsequent cyanosis, 3. Blue, structures that contain deoxygenated blood, red, structures that contain oxygenated blood, purple, structures that contain mixed blood. Copyright Embark. EAS in electrocardiogram, ECG, $1.52s1s52. Heart murmur in ventricular septal defect, mitral regurgitation, and tricuspid regurgitation VV holosystolic murmur, often referred to as pansystolic murmur in the case of a ventricular septal defect, copyright Embark. Copyright Overlay Ventricular septal defect VV. Color Doppler echocardiography. There is a moderate defect in the mid part of the septum. The blood flow through the defect is displayed in different colors. The red mark in the trace, lower left, shows the moment during the cardiac cycle that the image was captured. This is the typical presentation of a ventricular septal defect. IVs, interventricular septum, LA, left atrium, LV, left ventricle, MV, mitral valve, RA, right atrium, RV, right ventricle, TV, tricuspid valve source, ventricular septal defect, echo, Wikimedia Commons licensed under public domain. Euro_acyanotic congenital heart defects, 1/1. Copyright Overlay Patent foramen ovale VV. Echocardiography, transesophageal, with color Doppler, bicable view, color Doppler reveals a left-right shunt, red arrow, across a patent foramen ovale. LA, left atrium, RA, right atrium, PFO, patent foramen ovale source, figure 2a, in, recurrent arterial ischemic strokes in a patient with patent foramen ovale and ductus arteriosus, presentation of our management and review of the literature by D. Panagopoulos, S. Lakopoulou, E. Karanagios et al., Global Cardiology Science and Practice, licensed under CC by 4.0. Acyanotic congenital heart defects, 1/3. Cardiac hemodynamics in patent ductus arteriosus VV. In patent ductus arteriosus, there is a left-to-right shunt, with blood flowing from the aorta to the pulmonary arteries during both systole and diastole, 1. This shunt leads to volume overload, recirculation, of the blood within the pulmonary vessels, the left atrium, and left ventricle, 2. Eventually, because of the increased blood flow to the pulmonary circulation, pulmonary hypertension may develop as well as Eisenmenger syndrome, which involves a shunt reversal. The left-to-right shunt without cyanosis becomes a right-to-left shunt with cyanosis, 3. Blue, structures that contain deoxygenated blood, red, structures that contain oxygenated blood, pink, structures that contain mixed blood. Copyright Embark. Acyanotic congenital heart defects, 2/3. Electrocardiogram. Heart murmur in patent ductus arteriosus. Continuous systolic and diastolic heart murmur, machinery murmur. Copyright Embark. ECG. Overlay. Patent ductus arteriosus. Doppler echocardiography. In a newborn there is blood flow, indicated by red chevrons, through the blood vessel connecting the pulmonary trunk, P, and the aorta, AO. This finding is characteristic of patent ductus arteriosus, DA. Copyright Embark. Overlay. Patent ductus arteriosus. Doppler echocardiography. In a newborn there is blood flow, indicated by red chevrons, through the blood vessel connecting the pulmonary trunk, P, and the aorta, AO. This finding is characteristic of patent ductus arteriosus, DA. Copyright Embark. Euro__acyanotic congenital heart defects, 1/3. TBP. Obliterated ductus arteriosus. Obliterated ductus arteriosus. Coarctation of the aorta VV. 1. Stenosis distal to the left subclavian artery results in hypertension, TBP, in the upper extremities and the head, and hypotension, JBP, in the lower extremities and abdomen. 2. If coarctation involves the origin of the left subclavian artery, BP in the right arm and head will be higher than in the left arm, lower extremities, and abdomen. Copyright Embark. Euroacyanotic congenital heart defects, 2/3. Overlay. Coarctation of the aorta VV. X-ray chest, PA view, focal indentation of the distal aortic arch is seen at the location of aortic coarctation, illustration. An additional finding is inferior rib notching, Roessler sign, examples indicated by arrowheads, which is produced by dilated intercostal arteries. The figure 3 sign of coarctation, indicated by red line, is seen in this patient. It is produced by prestenotic dilatation of the aortic arch and left subclavian artery in combination with poststenotic dilatation of the descending aorta. The presence of bilateral rib notching indicates that the coarctation is distal to the origin of both subclavian arteries. Source: Aortic coarctation chest X-ray by Gibson C.M., Singh P., Zorkin C., ETAL, Wikidoc, licensed under CC by SA 3.0. Modifications: image enlarged. Euroacyanotic congenital heart defects, 2/3. Copyright. Overlay. Coarctation of the aorta VV. X-ray chest, PA view, focal indentation of the distal aortic arch is seen at the location of aortic coarctation, illustration. An additional finding is inferior rib notching, Roessler sign, examples indicated by arrowheads, which is produced by dilated intercostal arteries. The figure 3 sign of coarctation, indicated by red line, is seen in this patient. It is produced by prestenotic dilatation of the aortic arch and left subclavian artery in combination with poststenotic dilatation of the descending aorta. The presence of bilateral rib notching indicates that the coarctation is distal to the origin of both subclavian arteries. Source: Aortic coarctation chest X-ray by Gibson C.M., Singh P., Zorkin C., ETAL, Wikidoc, licensed under CC by SA 3.0. Modifications: image enlarged. Euroacyanotic congenital heart defects, 3/3. Rib notching in coarctation of the aorta. Chest radiograph, PA view, there is mild cardiomegaly with a cardiothoracic ratio 50%, and bilateral rib notching is visible on the inferior border of the ribs, white arrows. These features indicate coarctation of the aorta. Source: Figure 1, in, two-stage hybrid approach for complex aortic coarctation repair by F. Stratios Kolitzis, Stella Economides, Nikolaos Panagopoulos et al., Journal of Cardiothoracic Surgery, licensed under CC by 2.0. Digital clubbing. The fingers show symptoms of gross clubbing. The distal end of the finger is thickened, with increased convexity of the nail. Fold. Source: Akapaquia by Disharinka, Wikimedia Commons, licensed under CC by SA 4.0. X. Valvular heart diseases. Valvular heart disease, VHD, comprises a group of conditions that affect the heart valves. Valvular defects are either acquired or congenital and manifest as stenosis and/or insufficiency, regurgitation, of the valves. Acquired defects, which are primarily found in the left heart, are the most common form of VHD and often occur secondary to infections, post-inflammatory, degenerative processes, or underlying heart disease. The type of valvular disease determines the type of cardiac stress and subsequent symptoms. Valvular stenosis leads to a greater pressure load and concentric hypertrophy, while insufficiencies are characterized by volume overload and eccentric hypertrophy of the preceding heart cavities. Diagnostic procedures typically include ECGs, chest X-ray, and echocardiograms. Management consists of medical therapy for symptoms, example due to heart failure, as well as interventional or surgical procedures to repair, reconstruct, or replace valves. WA. CE. Epidemiology. Cent aortic stenosis. Most common valve defect in industrialized countries. Mostly degenerative. Copyright degenerative stenosis usually becomes symptomatic after the age of 75 and is most common in men. Copyright aortic stenosis in young people is usually secondary to congenital defects, example bicuspid aortic valve. Cent aortic regurgitation. Copyright age of onset, 40 to 60 years. Copyright severity increases with age. Mitral stenosis, symptom onset between 20 and 39 years. Hill East mitral regurgitation. Copyright overall prevalence of 0.6 to 2.4%. Copyright second most common valve defect. More common in women. Cent tricuspid valve defects, occur in. Epidemiological data refers to the U.S., unless otherwise specified. OI. 2. Etiology. Valvular heart defects may either be acquired or congenital. Acquired defects are more common and typically occur secondary to infections, post-inflammatory, degenerative processes, or heart disease. Etiology of valvular heart conditions, 23, valve stenosis, valve regurgitation. Mitral valve prolapse, dilated cardiomyopathy, ischemic heart disease, example following myocardial infarction, degenerative calcification, rheumatic fever. Rheumatic fever, mitral valve rheumatic diseases, example SLE, RA. Infective endocarditis, left heart acute, infective endocarditis, aortic dissection type A, chest trauma chronic degenerative calcification, most common, aortic valve rheumatic endocarditis, degree Bioder Sore naive 70 GEZ, copyright connective tissue diseases, example Marfan syndrome, Ehlers-Danlos syndrome, congenital, example unicuspid, bicuspid, or hypoplastic valve, 2 degrees rheumatic fever, copyright rheumatic diseases, example Besset disease, RA, SLE. Cent right ventricular dilation, example in right-sided heart failure, pressure overload infective endocarditis, for drug use. Rheumatic fever equals, tricuspid valve equals 95 plus connective tissue diseases, example Marfan syndrome, infective endocarditis, mostly for drug abuse, carcinoid syndrome, right heart, P plus pulmonary hypertension, COR pulmonale, secondary to mitral stenosis, left-sided heart failure. Congenital plus pulmonary hypertension, example tetralogy of Fallot, ventricular septal defects, pulmonary valve OE. Carcinoid syndrome, dilated cardiomyopathy. WAA equals A. Back collapse, find text outline. Clinical features. All valvular defects can eventually lead to symptoms of heart failure as a result of excessive strain on the ventricles. 1. Physical examination. Complete heart examination. See cardiovascular examination and auscultation of the heart for details. Maximum point murmur equals. Characteristics. Radiation to the carotid's aortic valve, parasternal GND right sent harsh Y aortic stenosis intercostal space, asterisk soft SZ, O ejection murmur, sent herb point Slochan urine, A possibly ejection click B. Plus immediately following the 2. Heart sound, immediate asterisk aortic valve, parasternal 2 right ICS, plus diastolic murmur with AD due TSEE2, aortic regurgitation law equals. Diastolic murmur, sent herb point sent possible additional quiet systolic murmur A sent Austin Flint murmur C1. 5.3, TH plus delayed diastolic murmur with a decrescendo endo copyright tympanic 1 degree heart sound mitral stenosis. Asterisk heart apex, midclavicular 5 trademark left ICS, my asterisk mitral opening murmur / opening snap, OS. Mid-systolic high-frequency click, due to the tensing of the late systolic crescendo la chordae tendineae, loudest before SZ mitral valve prolapse heart apex, midclavicular 5 left ICS. Hollow systolic murmur NM heart apex, midclavicular 5 left ICS, left axilla 4 blowing radiation into the axilla mitral regurgitation A3 heart sound audible degree. Quiet 1 degree heart sound. Possible radiation into the back pulmonary valve, parasternal 2 trademark left crescendo decrescendo ejection systolic ICS, murmur M pulmonary stenosis possible early systolic pulmonary ejection click and / or widely split 2 heart sound DY. Graham Steele murmur, high frequency decrescendo endo diastolic murmur pulmonary valve, parasternal 204 left pulmonary re-regurgitation regurg ICS, diastolic murmur with a decrescendo endo. TH delayed diastolic murmur with a decrescendo endo tricuspid stenosis tricuspid valve, parasternal 4 trademark left ICS, RA _ extremely rare, possible pre-systolic crescendo. Augmentation of the murmur's intensity with inspiration, Carvalho sign, tricuspid regurgitation AA * tricuspid valve, parasternal 4 left ICS, hollow systolic murmur. A. Halt, Olspi. Aortic stenosis. Fegurgiation mitral regurgitation. References, 4LL5L. Management. Copyright. The approach to management depends on the type and severity of VHD, the patient's individual risk profile, example comorbidities, age and fitness level, evaluation of risks and benefits of each procedure, and shared decision-making. VA. X no. ES medical treatment. Sense screen for and manage other traditional atherosclerotic cardiovascular disease risk factors. Manage complications, example treatment of heart failure. Sent consider indications for endocarditis prophylaxis before procedures that may cause bacteremia. Sent secondary prevention of rheumatic fever if indicated, see prevention in acute rheumatic fever, prevention of thromboembolism if indicated, example anticoagulant therapy after heart valve replacement. Back collapse. Find text outline. YS interventional treatment. Valve repair, 61. Sent valve reconstruction. Copyright annuloplasty, 7. Airing shape device is attached to the outside of the valve opening to re-establish the shape and function of the valve. Equals commonly used to treat mitral valve regurgitation. 8. Copyright leaflet repair, involves the use of a clip device, may be performed in patients with mitral valve regurgitation. Sent valvuloplasty. A procedure performed in patients with valvular stenosis, example aortic valve stenosis or mitral stenosis, to separate fused or calcified valve leaflets. O approach equals percutaneous balloon valvuloplasty. A balloon is advanced into the target valve, either transfemorally or transapically, and inflated, opening the stenotic valve. Equals open commissurotomy, open surgical procedure to separate fused and/or calcified leaflets. Prosthetic heart valve replacement 6. Indications. Advantages. Overview of prosthetic heart valve replacement options. 6 Mechanical prosthetic valve. Younger patients, copyright patients. Valve has a long lifespan. Sent lifelong anticoagulation is necessary, example with a vitamin K disadvantages antagonist. Biological prosthetic valve. Older patients, 265 years of age. 6. Patients with a high risk of bleeding. Patients who are currently pregnant or have a desire to carry a pregnancy in the future. Anticoagulation is only necessary for 3 months after surgery. Short lifespan due to sclerotic degeneration. Biological prosthetic valves may need to be replaced every 10 years, 51/64. O. The choice of mechanical versus bioprosthetic valve replacement should be based on shared decision-making, patient age and preference, presence of comorbidities, example conditions that increase the patient's surgical risk, and ability to take anticoagulation. Replacement route. Stent surgical heart valve replacement may be done in conjunction with a CABG in suitable patients who require both procedures. Transcatheter aortic valve replacement, TAVR, OE. A minimally invasive, percutaneous procedure that utilizes an endovascular technique to replace the aortic valve. Copyright. A collapsible replacement valve is inserted via a catheter and placed over the native valve. Copyright. Once the replacement valve is expanded, it displaces the old valve and assumes its function. Stent transcatheter mitral valve replacement. Complications of heart valve intervention, _6LL9L. Stent patient prosthesis mismatch. Copyright caused by implantation of a prosthetic valve with a functional area that is too small for the cardiac demand of the patient. Copyright leads to left ventricle hypertrophy and impaired exercise capacity. Copyright increased risk of other cardiac events, example arrhythmia, MI, and increased mortality plus prosthetic valve thrombosis, LL11. Copyright. Etiology equals mechanical valves are more prone to thrombosis than biological prosthetic valves. Equals insufficient anticoagulatory therapy after valve replacement. Copyright. Clinical features equals signs of acute heart failure due to valve dysfunction, example dyspnea, fatigue, peripheral edema, equals new murmur consistent with valve obstruction and/or regurgitation. Thromboembolic event, example TIA. Copyright. Diagnostics. First-line imaging, transthoracic or transesophageal echocardiography. 1. If echocardiography is negative, cardiac CT to assess leaflet anatomy and motility. Copyright. Treatment. Anticoagulation and fibrinolysis, surgical valve replacement. Stent prosthetic valve dysfunction, example paravalvular leak. 4. Plus prosthetic valve stenosis or regurgitation. Clinical presentation is similar to native valve disease. Back. Equals FOOO. Collapse. Find text outline. X. Valvular heart diseases. Stent valvuloplasty EA procedure performed in patients with valvular stenosis, example aortic valve stenosis or mitral stenosis, to separate fused or calcified valve leaflets. EO approach equals percutaneous balloon valvuloplasty. A balloon is advanced into the target valve, either transfemorally or transapically, and inflated, opening the stenotic valve. Equals open commissurotomy, open surgical procedure to separate fused and/or calcified leaflets. Prosthetic heart valve replacement 6. Overview of prosthetic heart valve replacement options. 1. Mechanical prosthetic valve. Biological prosthetic valve. Younger patients. Copyright patients. Patients taking anticoagulants. 1. Patients with a high surgical risk for re-intervention. Advantages. Stent valve has a long lifespan. Anticoagulation is only necessary for 3 months after surgery. Asterisk lifelong anticoagulation is necessary, example with a vitamin K short lifespan due to sclerotic degeneration, biological prosthetic valves may need to be replaced every disadvantages antagonist, 10 years, 161. The choice of mechanical versus bioprosthetic valve replacement should be based on shared decision-making, patient age and preference, presence of comorbidities, example conditions that increase the patient's surgical risk, and ability to take anticoagulation. Replacement route. Surgical heart valve replacement may be done in conjunction with a CABG in suitable patients who require both procedures. Stent transcatheter aortic valve replacement, TAVR, minimally invasive, percutaneous procedure that utilizes an endovascular technique to replace the aortic valve. Copyright. A collapsible replacement valve is inserted via a catheter and placed over the native valve. Copyright. Once the replacement valve is expanded, it displaces the old valve and assumes its function. Stent transcatheter mitral valve replacement. Complications of heart valve intervention, E6LL9L. Stent patient prosthesis mismatch. Copyright caused by implantation of a prosthetic valve with a functional area that is too small for the cardiac demand of the patient. Copyright leads to left ventricle hypertrophy and impaired exercise capacity. Copyright increased risk of other cardiac events, example arrhythmia, MI, and increased mortality plus prosthetic valve thrombosis. 01L11 Copyright. Etiology equals mechanical valves are more prone to thrombosis than biological prosthetic valves. Equals insufficient anticoagulatory therapy after valve replacement. Copyright. Clinical features equals signs of acute heart failure due to valve dysfunction, example dyspnea, fatigue, peripheral edema, equals new murmur consistent with valve obstruction and / or regurgitation. Thromboembolic event, example TIA. Diagnostics. First-line imaging, transthoracic or transesophageal echocardiography in equals if echocardiography is negative, cardiac CT to assess leaflet anatomy and motility. Copyright. Treatment, anticoagulation and fibrinolysis, surgical valve replacement. Plus prosthetic valve dysfunction, example paravalvular leak. Stent prosthetic valve stenosis or regurgitation. Clinical presentation is similar to native valve disease. Stent cardiac complications, example prosthetic valve endocarditis, heart failure, pericarditis, high-grade AV block, atrial fibrillation. 1. Plus vascular complications, example bleeding, femoral artery dissection, hemolytic anemia in patients with a mechanical valve, thromboembolism. 6. Stent other, example stroke, acute kidney injury. WA. No equals, A. Urovalvular heart diseases, 11/11ths. Aortic valve. Pulmonary valve. Tricuspid valve. 4. Mitral valve. Anatomical locations and auscultatory sites for heart valves. VV. 1. Aortic area, 24 right parasternal intercostal space, ICS, ideal site for auscultation of aortic valve murmurs. 1a. The murmur of aortic stenosis also radiates to the carotid arteries. 1b. 2. Pulmonary area, 2 left parasternal ICS, ideal site for auscultation of pulmonary valve murmurs. 3. Tricuspid area, 4 left parasternal ICS, ideal site for auscultation of tricuspid valve murmurs. 4. Mitral area, 5 left ICS in the midclavicular line, over the cardiac apex, ideal site for auscultation of mitral valve murmurs. 4a. The murmur of mitral regurgitation also radiates to the left axilla. 4b. Urovalvular heart diseases, 10/11ths. 5. SZS1 heart murmur in tricuspid stenosis. Delayed diastolic murmur with a decrescendo endo, possible presystolic crescendo. Copyright Embark. Electrocardiogram, ECG. Urovalvular heart diseases, 9/11. ECG, I/var_electrocardiogram ejection. Click A2P2EJ. A hill and T backslash HNDH dot cardiogram V. IFO cardiogra WM. S1 $2 $1 $2. Ejection click A2P2. Heart murmur in pulmonary stenosis VV crescendo decrescendo murmur with ejection click and widely split second heart sound copyright Boss. EAS in electrocardiogram, ECG, $1.52 S1 S52. Heart murmur in ventricular septal defect, mitral regurgitation, and tricuspid regurgitation VV hollow systolic murmur, often referred to as pansystolic murmur in the case of a ventricular septal defect, copyright Boss. Eurovalvular heart diseases, 7/11. Re7 electrocardiogram, ECG, midsystolic click click. $1 $2 $1.52. Heart murmur in mitral valve prolapse VV high frequency, midsystolic click with a late systolic crescendo murmur. Copyright Boss. Eurovalvular heart diseases, 6/11. Aux/RAI electrocardiogram, ECG. OSOS. I. S152 $1.52. Heart murmur in mitral stenosis VV delayed decrescendo endo-diastolic murmur. A pre-systolic crescendo murmur and / or mitral valve opening snap, OS, may also be present. Copyright Boss. N/UAE7X electrocardiogram, ECG. Heart murmur in aortic and pulmonary insufficiency VV early diastolic decrescendo endo murmur, directly after the second heart sound, consistent with aortic regurgitation and / or pulmonary regurgitation. Copyright Boss. Eurovalvular heart diseases, 4/11. Ejection click. In electrocardiogram, ECG, ejection click. S1 $2 S1 S2. Heart murmur in aortic and pulmonary stenosis VV crescendo decrescendo ejection murmur with an ejection click in aortic stenosis, there is usually radiation into the carotids. Copyright Boss. Eurovalvular heart diseases, 3/11. EASSXA electrocardiogram, ECG. OLSCSLY no. Heart murmur in hypertrophic obstructive cardiomyopathy, aortic stenosis, and pulmonary stenosis. A crescendo-decrescendo late systolic murmur is depicted. In the case of aortic stenosis, the murmur may radiate to the carotid arteries. Copyright Boss. 1. / if electrocardiogram / VV dial. 3s. Phonocardiogram of diastolic murmurs. Diastolic murmurs, orange waveform, occur in a. Mitral stenosis, decrescendo endo murmur with OS, b. Tricuspid stenosis, mid-diastolic decrescendo endo murmur, c. Patent ductus arteriosus, continuous crescendo-decrescendo murmur, d. Aortic and pulmonary regurgitation, decrescendo endo murmur. Note, patent ductus arteriosus produces a continuous murmur heard in both systole and diastole. OS, opening snap. Copyright Boss. Eurovalvular heart diseases, 1/11. / 7 click IE click lot let DB MKL. Apuihel LA mil ML Ali, Mili IHID MMY. L /FF _ if I electrocardiogram, ECG, midsystolic click ejection click A2P2 lick. Phonocardiogram of systolic heart murmurs. Systolic murmurs, orange waveform, occur in a. Mitral / tricuspid regurgitation and / or ventricular septal defect, hollow systolic murmur, b. Aortic / pulmonary stenosis, crescendo-decrescendo murmur, c. Aortic / pulmonary stenosis with an ejection click, d. Mitral valve prolapse, mid-systolic click followed by crescendo murmur, E, pulmonary stenosis with a split-second heart sound. Copyright Embark. Bileaflet mechanical prosthetic heart valve VV. Mechanical valves are constructed entirely of non-biological materials, here a pyrolytic carbon valve with a Dacron cuff. Source, copyright IMPP. Bioprosthetic heart valve. Photographic image of a bioprosthetic heart valve. This particular bioprosthetic heart valve is a replacement for an aortic valve. It features 3 leaflets. Source, Biological Valves by Roberto Lira, Wikimedia Commons, licensed under CC by SA 3.0. Biological prosthetic heart valve VV. A stented bioprosthetic valve, consisting of xenograft material, most commonly porcine aortic valve leaflets or bovine. Pericardium, mounted on a manufactured supporting stent. Source, copyright IMPP. XX aortic regurgitation. Aortic regurgitation, AR, is a valvular heart disease characterized by incomplete closure of the aortic valve leading to the reflux of blood from the aorta into the left ventricle, LV, during diastole. Aortic regurgitation can be acute, primarily caused by bacterial endocarditis or aortic dissection, or chronic, example due to a congenital bicuspid valve or rheumatic fever, and may be caused by a valvular defect or an abnormality of the aorta. In most cases, acute AR leads to rapid deterioration of LV function with subsequent pulmonary edema and cardiac decompensation. Chronic AR may remain compensated for a long period of time, becoming symptomatic only when left heart failure develops. Auscultation reveals an S3 and a high-pitched, decrescendo endo early diastolic murmur. Another characteristic diagnostic finding is widened pulse pressure. Echocardiography is the most important diagnostic tool, both for confirming the diagnosis and determining the severity of disease. In asymptomatic patients, conservative treatment consists of symptom management and physical activity as tolerated. Symptomatic patients or those with severely reduced LV function require surgical intervention, most commonly aortic valve replacement. Z. Ooises. Etiology. Acute aortic regurgitation, 1L2. Plus infective endocarditis aortic dissection, ascending aorta, sent chest trauma * latrogenic complications. Chronic aortic regurgitation ILS. Sent primary valvular defect, copyright congenital bicuspid aortic valve, most common cause of AR in young adults in high-income countries. Copyright calcific aortic valve disease, most common cause of AR in older patients in high-income countries. BID, a rheumatic heart disease, most common cause of AR in lower-income countries. 4. Plus aortic dilatation for copyright connective tissue disorders, example Marfan syndrome, Ehlers-Danlos syndrome, copyright chronic hypertension. Copyright aortitis of any etiology, example tertiary syphilis, copyright thoracic aortic aneurysm. OS. Good. Pathophysiology. Sent general regurgitation of blood from the aorta into the left ventricle, LV, leads to increased systolic blood pressure and decreased diastolic pressure. 1 equals widened pulse pressure water hammer pulse. See diagnostics below. Sent acute ARO because LV cannot sufficiently dilate in response to regurgitant blood. LV and diastolic pressure increases rapidly. Pressure transmits backwards into pulmonary circulation. Pulmonary edema and dyspnea. Copyright decreased cardiac output if severe cardiogenic shock and myocardial ischemia. Sent chronic AR. Copyright initially, a compensatory increase in stroke volume can maintain adequate cardiac output despite regurgitation. Compensated heart failure. Copyright over time, increased left ventricular end diastolic volume. LV enlargement and eccentric hypertrophy of myocardium. Left ventricular systolic dysfunction. Decompensated heart failure. References, 6L. OO. CO. Clinical features. Acute aortic regurgitation 2117. Signs and symptoms. Sudden, severe dyspnea. Back collapse. Find text outline. C00888 Clinical features. Acute aortic regurgitation 227. Signs and symptoms. Scent sudden, severe dyspnea. Scent rapid cardiac decompensation secondary to heart failure. Pulmonary edema. Symptoms related to underlying disease, example fever due to endocarditis, chest pain due to aortic dissection. Auscultation. Asterisk soft S, 5 cent soft and short early diastolic murmur. Chronic aortic regurgitation 2. Signs and symptoms. May be asymptomatic for up to decades despite progressive LV dilation. Scent palpitations. Symptoms of high pulse pressure. Water hammer. Pulse of peripheral arteries characterized by rapid upstroke and downstroke. Copyright Corrigan pulse. Pulse of carotid arteries characterized by rapid upstroke and downstroke. Traub sign. Pistol shot-like sounds heard over the femoral artery on auscultation. Copyright Duroche's sign. To and fro brute over the femoral artery that is heard when slight pressure is applied with a stethoscope. Copyright Quink sign. Visible capillary pulse when pressure is applied to the tip of a fingernail. De Musset sign. Rhythmic nodding or bobbing of the head in synchrony with heartbeats. Symptoms of left heart failure. Exertional dyspnea. Angina. Orthopnea. Easy fatigability. Syncope. Point of maximal impulse. PMI. Diffuse, hyperdynamic, and displaced inferolaterally. Auscultation. Asterisk S34 high-pitched, blowing, decrescendo endo early diastolic murmur, OAR due to valvular disease, heard best in the left third and fourth intercostal spaces and along the left sternal border, herb point. Copyright AR due to aortic root disease, example aortic dissection heard best along the right sternal border. Worsens with squatting and hand grip. Scent Austin Flint murmur. Rumbling, low-pitched, mid-diastolic or pre-systolic murmur heard best at the apex. Caused by regurgitant blood striking the anterior leaflet of the mitral valve, which leads to premature closure of the mitral leaflets. Plus in more severe stages, possibly a harsh, crescendo-decrescendo mid-systolic murmur that resembles the ejection murmur heard in aortic stenosis. Asterisk see also auscultation in valvular defects. Why? Copyright J. Physiological heart sounds. Aortic. OL. Regurgitation. Diagnostics. Echocardiography, 5LL8. Asterisk indication, assessment of aortic valve structure and function, cause and severity of regurgitation, the left ventricle and other heart valves, 2 OTTE, modality of choice for initial assessment of all patients with suspected AROT. Equals moderate to severe AR, if TTE findings are equivocal. Equals preoperative planning. Scent supportive findings. 3. Back collapse. Find text outline. Scent supportive findings. 3. Copyright general findings. Abnormal aortic valve leaflets, 1 asterisk fluttering of the anterior mitral valve leaflet, LLS regurgitant AR jet on Doppler flow tracing equals dilated aorta F119, copyright findings specific to acute AR7 equals reduced cardiac output, elevated end diastolic left ventricular pressure, early mitral valve closing equals rapid equilibration of aortic and left ventricular pressure. Findings specific to chronic AR, increased LV size and volume 1. 2. Other 5. ECG, nonspecific, helps rule out differential diagnoses, example ACS, cardiac arrhythmia, copyright acute AR, possible signs of the underlying cause, example signs of myocardial ischemia in aortic dissection, copyright chronic AR equals ECG signs of LVH equals ST segment depression and T wave inversion in I, AVL, VS, and VG2 plus chest X-ray, used to assess for pulmonary edema and rule out other causes of acute dyspnea. Copyright acute AR. equals normal heart silhouette equals X-ray signs of pulmonary congestion or edema copyright chronic ARJ equals X-ray signs of LVH enlarged cardiac silhouette, M copyright chronic AR or acute AR caused by aortic dissection, possible prominent aortic root / arch 131,141 M. G0. OORD I manage. Treatment. Approach / LL2. Sent acute aortic regurgitation O severe acute AR requires surgical treatment as soon as possible. O medical management of complications, example pulmonary edema, should not delay definitive treatment. Asterisk chronic aortic regurgitation copyright surgery is the mainstay of treatment for symptomatic AR and severe asymptomatic AR. Copyright optimize medical management of comorbidities, example heart failure treatment. Copyright all patients with acute severe aortic regurgitation should undergo urgent surgical treatment. 2. IABP increases regurgitated volume and is contraindicated in acute severe AR. 8. Surgical management 5. Asterisk indications, 16 LL5, O acute severe AR O symptomatic chronic severe AR, O asymptomatic chronic severe AR with one of the following, 5, equals reduced LVEF 50 mm cardiac surgery for other indications asterisk surgical aortic valve replacement, standard procedure for acute and chronic AR, see prosthetic heart valve for details, 3. Medical management, 5. Back collapse find text outline. XX aortic regurgitation. Copyright acute AR. Equals normal heart silhouette equals X-ray signs of pulmonary congestion or edema copyright chronic AR2 equals X-ray signs of LVH equals enlarged cardiac silhouette M copyright chronic AR or acute AR caused by aortic dissection, possible prominent aortic root / arch, 13 LL14 IA equals. OI. Treatment. Approach 5 LL2. Sent acute aortic regurgitation O severe acute AR requires surgical treatment as soon as possible. Degree medical management of complications, example pulmonary edema, should not delay definitive treatment. Sent chronic aortic regurgitation copyright surgery is the mainstay of treatment for symptomatic AR and severe asymptomatic AR. Copyright optimize medical management of comorbidities, example heart failure treatment. 6. All patients with acute severe aortic regurgitation should undergo urgent surgical treatment. 2. 6. IABP increases regurgitated volume and is contraindicated in acute severe AR. 5. Surgical management 5 * indications, 6 LL50 acute severe ARO symptomatic chronic severe AR-O asymptomatic chronic severe AR with one of the following, 1 equals reduced LVEF 50 mm equals cardiac surgery for other indications * surgical aortic valve replacement, standard procedure for acute and chronic AR, see prosthetic heart valve for details, 3 medical management 5. All patients should be screened and treated for other cardiac risk factors. No medical treatments are known to influence the progression of the disease. 117 cent hypertension copyright initiate treatment if systolic blood pressure is 140 mm Hg. Cent heart failure, manage according to guideline recommendations, see treatment of heart failure. Monitoring. * serial echocardiography, regular follow-up imaging is indicated for asymptomatic patients to identify possible progression and indications for intervention. VAOE. Prognosis. Asymptomatic patients with normal LVEF, progression to symptoms or LV dysfunction at a rate of 25% per year. 19 symptomatic patients, mortality rate is 10% per year. F19. Back collapse find text outline. Euroaortic regurgitation, 1/1. N/UAE7X electrocardiogram, ECG. Heart murmur in aortic and pulmonary insufficiency VV early diastolic decrescendo endo murmur, directly after the second heart sound, consistent with aortic regurgitation and / or pulmonary regurgitation. Copyright Embark. Aortic regurgitation, 1/1. Overlay. Cardiomegaly and prominent thoracic aorta in aortic regurgitation VV chest X-ray, PA view, of a patient with a history of aortic regurgitation. The cardiac silhouette is enlarged. The left ventricle, ascending aorta, and aortic arch are prominent as a result of dilatation. Source, copyright IMPP. Euroaortic regurgitation, 1/1. Copyright overlay. Cardiomegaly and prominent thoracic aorta in aortic regurgitation VV chest X-ray, PA view, of a patient with a history of aortic regurgitation. The cardiac silhouette is enlarged. The left ventricle, ascending aorta, and aortic arch are prominent as a result of dilatation. Source, copyright IMPP. X. Kawasaki disease. Kawasaki disease is an acute, necrotizing vasculitis of unknown etiology. The condition primarily affects children under the age of 5 and is more common among those of Asian descent. The disease is characterized by a high fever, desquamative rash, conjunctivitis, mucositis, example strawberry tongue, cervical lymphadenopathy, as well as erythema and edema of the distal extremities. However, coronary artery aneurysms are the most concerning possible manifestation, as they can lead to myocardial infarction or arrhythmias. Kawasaki disease is a clinical diagnosis, further supported by findings such as elevated ESR or evidence of cardiac involvement on echocardiography. Treatment with 4 immunoglobulins and high-dose aspirin is essential and should be initiated immediately after diagnosis. GVO. CE. Epidemiology. Plus sex, #2, 1.5:1, *H, primarily children. Epidemiological data refers to the U.S., unless otherwise specified. WA. Etiology. * The exact cause of Kawasaki disease remains uncertain. Plus, however, it is associated with infectious and genetic factors. The prevalence is higher in patients of Asian descent and in siblings of affected children. A5. 7A6. Clinical features. * Clinical diagnosis requires fever for at least 5 days and one of the following, 6024 other specific symptoms. Copyright. Copyright always consider Kawasaki disease in small children with a rash and high fever unresponsive to antibiotics. BQ crash and burn, conjunctivitis, rash, adenopathy, strawberry tongue, hands and feet, and burn, fever equals 5 days, are the most common features of Kawasaki disease. Back collapse. Fine text outline. CE. Diagnostics. Kawasaki disease is a clinical diagnosis, see clinical features above, which is supported by the following diagnostic findings: laboratory findings OTTES RAN CRP copyright leukocytosis copyright thrombocytosis O7AST, alt-cent echocardiography O for evaluating coronary artery aneurysms copyright minimal evaluation, should be performed at diagnosis, at 2 weeks, and at 6 to 8 weeks after onset is. Or treatment. Sent for immunoglobulin, IVIG, copyright high single dose to reduce the risk of coronary artery aneurysms copyright most effective if given within the first 10 days following disease onset, 9 plus high dose oral aspirin, 0L11 sent for glucocorticoids, may be considered in addition to standard treatment, especially in cases of treatment refractory disease, as they lower the risk of coronary involvement. Copyright to avoid the risk of Reye syndrome, children should not be treated with aspirin, especially if a viral infection is suspected. Kawasaki disease is an exception to this rule. WA. CE. Complications. Asterisk coronary artery aneurysm, 1/8. Copyright. The risk of aneurysms is highest during the second and third weeks following symptom onset. 8. A rupture or thrombosis of the aneurysm can be lethal. Myocardial infarction, myocarditis, ventricular dysfunction. Copyright most commonly occurs within the first 2 weeks of onset of Kawasaki disease. 12. Copyright often seen in infants with untreated Kawasaki disease. 3. Copyright most commonly associated with lymphocytic myocarditis. 141 L12O manifests with symptoms, example tachypnea or diaphoresis with feeding, exertional dyspnea, and physical examination findings of congestive heart failure, example hepatomegaly, S3 gallop, rows or crackles on lung. Auscultation, 15. Copyright increased risk of sudden death, 3. Arrhythmias. We list the most important complications. The selection is not exhaustive. 470E. Tips and links. Sources. Last updated September 16, 2023. Back collapse, fine text outline. Greater than 5J fever, non-exudative conjunctivitis, cervical lymphadenopathy, polymorphous rash. Oropharyngeal mucositis at red, swollen tongue at cracked, red lips, coronary artery aneurysms, age. Desquamation of fingertips. Swelling and erythema of hands and feet. Clinical features of Kawasaki disease VV. Copyright Embark. Typical findings in Kawasaki disease VV. A. Bilateral, non-purulent conjunctivitis. B. Stomatitis with bright red lips. C. Erythema and edema of the hands. D. Erythema and edema of the feet. E. Truncal rash. F. Cervical lymphadenopathy. G. Ultrasound of an enlarged cervical lymph node, increased perfusion. H. Desquamation of fingertips. 1. Deep grooves in the nail, bowlines. Source, Figure 2, in Kawasaki disease by C. M. Heydrich, A. Schnabel, T. Hospake, Frontiers in Pediatrics, licensed under CC by 4.0. Strawberry tongue in Kawasaki disease VV. The tongue appears enlarged and is covered by a gray-white exudate. Prominent papillae are also visible. Source, Figure 1, in an adult Kawasaki disease with coronary artery involvement, a unique case report and literature review by Faizaluddin. M. Iftikhar P.M., K. ETAL, Curious, licensed under CC by 3.0. Copyright. Overlay. Coronary artery aneurysm in Kawasaki disease. Volume rendering of a thorax CT, anterior view, with contrast, showing aorta and coronary vessels. The proximal part of the left anterior descending branch of the left coronary artery, LCA, is dilating, green overlay, and there is significant variation of vessel diameters. This abnormal morphology suggests an aneurysm of the LCA. Source, Coronarinersimon-Bay Kawasaki syndrome, CT, volume rendering tree, 001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. XX acute rheumatic fever. Acute rheumatic fever, ARF, is an inflammatory sequela involving the heart, joints, skin, and central nervous system, CNS, that occurs 2 to 4 weeks after an untreated infection with group A streptococcus, GAS. The pathogenic mechanisms that cause rheumatic fever are not completely understood, but molecular mimicry between streptococcal M protein and human cardiac myosin proteins is thought to play a role. Because of the structural similarities between the two proteins, antibodies and T cells activated to respond to streptococcal proteins also react with the human proteins, causing tissue injury and inflammation. In addition to nonspecific symptoms, example fever, malaise, and fatigue, patients present with symptoms involving the heart, carditis or valvulitis, joints, migratory polyarthritis, skin, subcutaneous nodules, erythema marginatum, and / or CNS, sydenum chorea. The diagnosis of ARF is primarily clinical and based on the Jones criteria. Diagnostic evaluation in ARF typically shows elevated inflammatory markers, positive anti-streptococcal antibodies, and valvular damage on echocardiogram. The first-line treatment is penicillin combined with symptomatic anti-inflammatory treatment, typically with salicylates or glucocorticoids, if salicylates are not effective. ARF may be complicated by progressive, permanent damage to the heart valves, especially the mitral valve, resulting in chronic rheumatic heart disease. Preventing the cardiac complications of ARF is the main goal of both primary prophylaxis, i.e., antibiotic therapy for gas pharyngitis, and secondary prophylaxis, antibiotic administration following an episode of ARF. Cent AA Re 12. OOFO. Definition. Cent delayed inflammatory complication of group AB hemolytic streptococcal pharyngitis that usually occurs within 2 to 4 weeks of acute infection. T*1 of the non-suppurative complications of gas pharyngitis. Cent rheumatic heart disease refers to two clinical entities, copyright acute pancarditis as a sequela of gas infection, copyright chronic cardiac valvular changes as a complication of acute rheumatic fever. OS. CE. Epidemiology. Plus peak incidence, 5 to 15 years of age. 2. Plus prevalence, more common in resource-limited countries. 1. Epidemiological data refers to the U.S., unless otherwise specified. OE. Etiology. Cent previous infection with group AB hemolytic streptococcus, gas, also referred to as Streptococcus pyogenes. O. Usually acute tonsillitis or pharyngitis, strep throat, copyright gas infections of the skin, example erysipelas, impetigo, cellulitis, tend to be complicated by post-streptococcal glomerulonephritis rather than rheumatic fever. 2 Rs. Pathophysiology. The exact pathogenesis is not yet entirely understood. Most commonly accepted mechanism involves the following: acute tonsillitis / pharyngitis caused by gas without antibiotic treatment, development of antibodies against streptococcal M protein, cross-reaction of antibodies with nerve and myocardial proteins, most commonly myosins, due to molecular mimicry type IL hypersensitivity reaction, acute inflammatory sequela, 2 at 4. 00° FOT. Pathology. Back collapse, fine text outline. Pathology. Plus myocardial findings /IL equals granuloma of rheumatic inflammation equals central area of fibrinoid necrosis equals surrounded by characteristic multinucleated giant cells, Aschhoff cells, and other inflammatory cells, mononuclear cells, plasma cells, and T lymphocytes, due to a type 4 hypersensitivity reaction. O. Anitz cow cells equals cardiac histiocytes, mononuclear cells, appearing in Aschhoff bodies equals large and elongated cells equals longitudinal section, ovoid nucleus containing wavy, caterpillar-like bar of chromatin, caterpillar cell, equals transverse section, ally appearance. DN. Clinical features. Cent constitutional symptoms, fever, malaise, fatigue plus joints, migratory polyarthritis. Cent heart opancarditis, endocarditis, myocarditis, and pericarditis, OE valvular lesions, most commonly on high-pressure valves equals mitral valve, 65% of cases, equals early mitral regurgitation or prolapse equals late mitral stenosis. Rheumatic fever is the most frequent cause of mitral stenosis. Mixed mitral stenosis / regurgitation equals aortic valve, 25% of cases, equals aortic regurgitation equals aortic stenosis. Late manifestation, equals tricuspid valve, 10% of cases, Copyright dilated cardiomyopathy due to severe valvular disease, myocarditis CNS, sydenham chorea, involuntary, irregular, non-repetitive movements of the limbs, neck, head, and/or face, 70A, 2:1. Copyright most common cause of acute chorea in children in the U.S. Copyright occurs 1 to 8 months after the inciting infection. 1. Copyright clinical features equals sometimes asymmetrical or confined to one side, hemichorea. Equals additional motor symptoms, example billismus, muscle weakness, and speech disorders, slurred or jerky speech. Equals milkmaid grip, characterized by the inability to maintain muscle contraction in the hands. Intermittent loss of contraction results in alternating squeeze and release of grip. Milking, equals choreic hand, characterized by intermittent wrist flexion with extension of the digits. Spooning of the hand, equals neuropsychiatric symptoms, example inappropriate laughing/crying, agitation, anxiety, apathy, obsessive-compulsive behavior. O pathophysiology, streptococcal antigens lead to antibody production. Antibodies cross-react with structures of the basal ganglia, particularly the striatum, and cortical structures. Reversible dysfunction of cortical and striatal circuits. Scent skin. Copyright subcutaneous nodules. O erythema marginatum, centrifugally expanding pink or light red rash with a well-defined outer border and central clearing. Equals painless and non-pruritic. Equals location, the trunk and limbs are affected, the face is spared. May rapidly appear and disappear at different locations. Equals differential diagnosis. For details, see overview of annular skin lesions. And rheumatic heart disease tends to involve the high-pressure valves, i.e., the mitral and aortic valves. QB valvular lesions sometimes do not manifest until pregnancy, when blood volume is increased. At the symptoms of acute rheumatic fever can be remembered by reading the Jones criteria. See diagnostics below, as an acronym that replaces the O with a heart. J equals joints, AT equals pancarditis, N equals nodules, E equals erythema marginatum, S equals sydenham chorea. Back collapse. Find text outline. Diagnostics. Approach, 11I12. Scent patients should be evaluated for evidence of a preceding gas infection via throat culture, antigen, or antibody test. EARF is diagnosed using the revised Jones criteria. Scent all patients with suspected or confirmed ARF require a cardiac workup. Revised Jones criteria, 12-11. Scent diagnostic criteria for patients with laboratory findings of a preceding gas infection. FAD-O initial episode of ARF, 2 major criteria or 1 major plus 2 minor criteria. O recurrent ARF, either the same as for an initial episode of ARF or the presence of 3 minor criteria. Revised Jones criteria for the diagnosis of ARF low-risk populations. Migratory polyarthritis, primarily involving the large joints, *carditis, pancarditis, including valvulitis. J major criteria. Sydenham chorea, CNS involvement, *subcutaneous nodules. Erythema marginatum. Scent polyarthralgia. High fever, 238.5 degrees Celsius, T acute phase reactants, ESR 260 mm/hour and/or CRP equals 30 mg/L, ECG showing prolonged PR interval dash. Minor criteria. Routine laboratory studies, 11. Initial laboratory findings typically show nonspecific signs of infection. Plus complete blood cell count, 11. IL-13 copyright typically shows leukocytosis. O may show normochromic, normocytic anemia of chronic inflammation plus acute phase reactants. 111 OCRP, elevated, typically 30 mg/LOESR, elevated, typically 260 mm/hour. Confirmation of gas infection, 1. Scent used to rule out differential diagnoses. Scent any of the following test results can confirm recent gas infection. Copyright tests showing elevated or rising antibodies foot anti-streptolysin O titer, ASO, 1 anti-streptococcal DNA SEB titer, ADB, copyright positive throat culture copyright positive rapid gas carbohydrate antigen detection tests sent false positives are possible due to colonization of gas in the upper respiratory tract. Sent for more information on the diagnosis of gasopharyngitis, see acute tonsillitis. Assessment for cardiac involvement, 111 I-141 I-15. Moderate to high-risk populations. Arthritis, monoarthritis or migratory polyarthritis, polyarthralgia carditis, pancarditis, including valvulitis, 4 sydenham chorea, CNS involvement, subcutaneous nodules erythema marginatum. Monoarthralgia high fever, 238.5 degrees Celsius, TT acute phase reactants, ESR equals 30 mm/hour and/or CRP equals 30 mg/L, ECG showing prolonged PR interval. Sent all patients with confirmed or suspected rheumatic fever require an ECG and echocardiography. Cardiac workup for ARF modality. Most common, prolonged PR interval, first-degree AV block. Potential additional findings include, copyright second-degree AV block DS ECG degree complete heart block E sinus tachycardia copyright accelerated junctional rhythm degree ECG features of pericarditis. Echocardiography 16 chronic disease, mitral stenosis. Enlarged left atrium 8 enlarged left ventricle X-ray findings of pulmonary edema chest X-ray. 4-_. Characteristic findings 14-13-15. Acute infection, features of rheumatic valvulitis, example mitral regurgitation, aortic regurgitation. A. Find text. Al. Outline. Assessment for neurological involvement, 171 I-18. Sent the diagnosis of sydenham chorea is based on clinical and laboratory findings. Sent neuroimaging, MRI or CT brain, copyright not routinely indicated echocardiography should be obtained in all patients with sydenham chorea because concurrent cardiac involvement is common. 14 Pro. OE. Management. Treatment of ARF involves pain relief for arthritis, antibiotics to both treat acute gas infection and prevent recurrence, and medical management of associated complications. Gas eradication, 41. Sent first line, penicillin V+ in patients with penicillin allergy, use, ocephalosporins, hypersensitivity without anaphylaxis, copyright or macrolides, severe hypersensitivity to beta-lactam antibiotics, 141 symptomatic treatment of arthritis and fever. Plus first line, nonsteroidal anti-inflammatory drugs, NSAIDs, 2119 copyright aspirin naproxen sent second line, glucocorticoids, example prednisone. Oiophia. Lee management of complications. Cardiac involvement. Tacny non-egaliad. Cardiac complication acute management bed rest is not required. Mild to moderate consider an ACE inhibitor, particularly if the patient has aortic regurgitation. Bed rest with gradual ambulation is recommended. 12 Manage underlying heart failure using standard guideline-directed medical therapy. In suspected myocardial involvement, monitor and treat patients for arrhythmias, see myocarditis. Severe in acute mitral regurgitation, urgent valve replacement may be necessary. Sydenham chorea, 19 IL-14. In the majority of cases, sydenham chorea is self-limiting, with most patients seeing an improvement within a few weeks and nearly all patients fully recovered by 6 months. Sent supportive therapy, indicated for all patients, may be the only treatment required in mild disease. Copyright rest in a calm environment. Copyright avoidance of overstimulation. Patient and caregiver education about the condition. Pharmacotherapy. Copyright consider for patients with difficulties performing activities of daily living. Copyright options include carbamazepine and valproic acid. 1, 2-IL-20. Govio. Lee prevention. Primary prevention. 21. Aims to prevent ARF from developing as a result of gas infection. Patients should receive prompt antibiotic treatment for gas tonsillopharyngitis, example with penicillin V, and streptococcal skin infections. 19. Back collapse. Find text outline. X. Acute rheumatic fever. Cardiac involvement. 7 of cardilocations in ARF L191L14I. Cardiac complication. Acute management. Bed rest is not required. Mild T-Dirat emoterare. Consider an ACE inhibitor, particularly if the patient has aortic regurgitation. Bed rest with gradual ambulation is recommended. 12. Severe manage underlying heart failure using standard guideline-directed medical therapy. In suspected myocardial involvement, monitor and treat patients for arrhythmias, see myocarditis. In acute mitral regurgitation, urgent valve replacement may be necessary. A. Sydenham chorea, 191I-141. In the majority of cases, sydenham chorea is self-limiting, with most patients seeing an improvement within a few weeks and nearly all patients fully recovered by 6 months. Stent supportive therapy, indicated for all patients, may be the only treatment required in mild disease. Copyright rest in a calm environment. Copyright avoidance of overstimulation. Patient and caregiver education about the condition. Stent pharmacotherapy. Copyright consider for patients with difficulties performing activities of daily living. J. 1220. Copyright options include carbamazepine and valproic acid. 7.2 Shared. Lee prevention. Primary prevention. 21. Stent aims to prevent ARF from developing as a result of gas infection. Stent patients should receive prompt antibiotic treatment for gas tonsillopharyngitis, example with penicillin V, and streptococcal skin infections. 19. Secondary prevention. Patients with a history of ARF are at high risk for recurrence, which may worsen existing rheumatic heart disease. All patients require antibiotic prophylaxis. Copyright start immediately after completion of antibiotics for ARF. Copyright drug of choice, IM penicillin G benzathine every 4 weeks. Copyright alternatively, oral penicillin V. Copyright patients with penicillin allergy, sulfadiazine. Copyright antibiotic prophylaxis should be decided according to whichever of the following results in the longest treatment duration. 21 possible ARF, 12 months, 4 equals rheumatic fever without carditis, 5 years or until the patient reaches 21 years of age equals rheumatic fever with carditis, with no residual heart disease. 10 years or until the patient reaches 21 years of age equals rheumatic fever with carditis and permanent valvular heart defects. 10 years or until the patient reaches 40 years of age. Educate patients on early recognition of symptoms and the importance of adhering to prophylaxis. Stent emphasize the importance of dental care and regular dental checkups. Food S. Prognosis. Cardiac involvement is the most important prognostic factor. 1. Early death from rheumatic fever is usually due to myocarditis rather than valvular defects. Copyright patients with a history of carditis, and possible post-inflammatory scarring and calcification, during an initial rheumatic fever episode are at high risk of developing valvular heart defects with recurrent episodes. Rheumatic heart disease. And S. Back collapse. Find text outline. Acute rheumatic fever, 1/1. Acute rheumatic fever. Etiology: previous gas pharyngitis/tonsillitis without antibiotic treatment. Peak incidence 5 to 15 years of age. Diagnosis: evidence of a previous gas infection, example throat culture, rapid antigen detection test, anti-streptolysin O, anti-streptococcal DNase B test, revised Jones criteria. Treatment: antibiotic treatment of underlying gas infection, symptomatic treatment of arthritis and fever. Untreated gas/pharyngitis/tonsillitis FFE. Acute infection. /development / of antibodies Y. Constitutional. High fever, malaise, fatigue. Skin WAOL. Valvulitis, pancarditis. Erythema marginatum CNS. 1 to 8 months after infection, sydenum chorea, jerking, subcutaneous nodules, flinching. Joints. Migratory polyarthritis. X is /molecular / type 2 hypersensitivity / mimicry Y, reaction Y, cell damage FFE. W / inflammation and latent period, 2 to 4 weeks. Acute rheumatic fever fact sheet. Copyright Embark. Rheumatic fever onset. Overlay. Askhoff body and Anitz cow cells VV. Photomicrograph of a myocardial tissue specimen, H&E stain, high magnification, a collagenous nodule, green overlay, is seen within the myocardial tissue. The nodule contains a loose lymphoplasmacytic infiltrate and large eosinophilic cells with an ovoid nucleus, Anitz cow cells, arrowheads. Anitz cow cells are thought to be histiocytes. These nodules, referred to as Askhoff bodies, are thought to represent myocardial granulomas, which are typically found in rheumatic heart disease. Source: Askhoff body in rheumatic myocarditis by Ed Uthman, Flickr, licensed under CC by SA 2.0. Erythema marginatum VV. Left upper arm of a child diagnosed with acute rheumatic fever, ARF, erythematous plaques with areas of central clearing are visible on the ventral aspect of the forearm. This is characteristic of erythema marginatum, the characteristic annular erythema occurring in 10% of attacks of acute rheumatic fever in children, caused by group A Streptococcus. Source: Erythema marginatum by ADSI, Wikimedia Commons, licensed under CC by SA 4.0. Modifications: image has been cropped. Subcutaneous nodules in rheumatic fever VV. Solitary subcutaneous, erythematous, warm, and tender protuberances are visible on the left shoulder. In conjunction with flu-like symptoms, ankle swelling, and an elevated anti-streptolysin O, ASO, titer, these skin findings indicate rheumatic fever. Source: Figure 1, in Acute Rheumatic Fever, a review of essential cutaneous and histological findings by M.A. Hurd, M.C. Green, M. Royer, Curious, licensed under CC by 4.0. HR, 81 QRS, 106 milliseconds Pax 69 PD, 120 milliseconds QT, 400 milliseconds QRS AX, -22 PR, 302 ms _ QT 465 ms _ tax, 79 QRS TX, 3D. T.7:23-7.27. First degree atrioventricular block. 12 lead ECG, paper speed, 25 mm/s, normal sinus rhythm, heart rate, 80/min, normal axis, PR interval, 300 ms. The PR interval greater than 200 ms indicates first degree atrioventricular block. Our great thanks to Thomas Waldiak, MD, for kindly providing this case. 25 ms 10 mMv. Copyright. Overlay. Overlay. Mobitz type 2 second degree atrioventricular block and bifascicular block VV. Irregular rhythm, atrial rate 70/min, ventricular rate 40/min left axis deviation, lat RS in lead, plus, R. The intermittent non-conducted P waves, with constant PR in the conducted beats, indicate Mobitz IL second-degree atrioventricular block, which may have a regular conduction ratio or be completely irregular. The combination of RBBB and left anterior fascicular block represents a bifascicular block. TNB 96/44, 65, ohmic 6 mm RK14 He M/. Copyright. Overlay. Third degree atrioventricular block VV. Rhythm strip ECG, paper speed, 25 mm/s, atrial rate 100/min, ventricular rate 40/min, escape rhythm, RR intervals and PP intervals are regular. Atrioventricular, AV, dissociation, P waves, red overlay, and QRS complexes, green overlay, have regular but unrelated rhythms because there is no conduction between atria and ventricles, resulting in some P waves being completely or partially buried in QRS complexes, 6 P wave, or T waves, 4 and 9 P waves. AV dissociation with bradycardia is characteristic of third-degree AV block, complete heart block. Source, rhythm strip showing third-degree heart block, Moody Groove, Wikimedia Commons licensed under public domain. Acute rheumatic fever, 4/4. Overlay. Enlarged left atrial appendage VV. X-ray chest, PA view, a CONV exity between the moguls produced by the main pulmonary artery, PA, and left ventricle, LV, suggests enlargement of the left atrial appendage, LA, normal configuration indicated by dashed line. Breast shadow opacification, green overlay, simulates parenchymal airspace disease. A. Aortic arch source, copyright IMPP. Overlay. Enlarged left atrial appendage VV. X-ray chest, PA view, a CONV exity between the moguls produced by the main pulmonary artery, PA, and left ventricle, LV, suggests enlargement of the left atrial appendage, LA, normal configuration indicated by dashed line. Breast shadow opacification, green overlay, simulates parenchymal airspace disease. A. Aortic arch source, copyright IMPP. XX myocarditis. Myocarditis is an inflammatory disease of the myocardium that most often affects young individuals and is the cause of approximately 10% of sudden deaths in young adults. The disease is most commonly caused by viral infections, example parvovirus B19, Coxsackie virus, but it may also be seen in patients with acute rheumatic fever or autoimmune diseases, example systemic lupus erythematosus, vasculitic syndromes. Patients may be asymptomatic or present with new-onset chest pain, arrhythmias, and/or new-onset heart failure. Severe cardiac inflammation may lead to fulminant myocarditis characterized by cardiogenic shock, hemodynamically significant arrhythmias, example heart block, ventricular tachycardia, and multi-organ failure. Diagnostic testing should include ECG, inflammatory markers, and cardiac biomarkers, transthoracic echocardiography, TTE, and possibly diagnostic confirmation with endomyocardial biopsy. Management of myocarditis involves supportive measures and targeted treatment of any underlying disease as indicated. Most adults with viral myocarditis make a full recovery, but there is a small risk of the condition progressing to dilated cardiomyopathy. The prognosis is especially poor for infants. OOE. Epidemiology. The exact incidence is unknown. 1. 1 to 5% of viral infections are estimated to have cardiac involvement. Asterisk often occurs in young patients, average age 40 years, in 10% of sudden deaths in young adults, myocarditis is diagnosed in the post-mortem examination. One epidemiological data refers to the U.S., unless otherwise specified. OS. OE. Etiology. Infectious 21. Sent viral, 1 copyright most commonly implicated, Coxsackie B1b5, P. cornavirus, parvovirus B19, human herpes virus 6, HHV6, adenovirus, HCV, HIV. Other viruses, EBV, CMV, echovirus, H1N1 influenza A4, sent bacterial O group of B hemolytic streptococcus, acute rheumatic fever, copyright Corynebacterium diphtheriae, diphtheria, O Borrelia burgdorferi, borreliosis, O Mycobacterium, tuberculosis, O Mycoplasma pneumoniae. Sent fungal, Candida, Aspergillus, sent parasitic copyright protozoan, Toxoplasma gondii. Trypanosoma cruzi, Chagas disease, common in South America, copyright Helminthic, Trichinella, Echinococcus. Non-infectious 31. Asterisk connective tissue diseases, example systemic lupus erythematosus, sarcoidosis, dermatomyositis, polymyositis, sent vasculitis syndromes, example Kawasaki disease, sent toxic myocarditis. Copyright toxins, example carbon monoxide poisoning, black widow venom, copyright medications, example sulfonamides, immune checkpoint inhibitors, chemotherapy, example anthracycline, doxorubicin, e-alcohol, cocaine. Copyright radiation therapy. WA. OES. Clinical features. Sent often asymptomatic, but may range from acute, fulminant cases to chronically active or persistent myocarditis preceding 1 to 2 weeks, flu-like symptoms, fever, arthralgia, myalgia, upper respiratory tract infections indicate possible viral cause. Back collapse. Fine text outline. Clinical features. Often asymptomatic, but may range from acute, fulminant cases to chronically active or persistent myocarditis preceding 1 to 2 weeks, flu-like symptoms, fever, arthralgia, myalgia, upper respiratory tract infections indicate possible viral cause. Fatigue, weakness, dyspnea, nausea, vomiting. 4. Cardiac arrhythmias, sinus tachycardia, often dissonantly high in relation to patient's body temperature, ventricular extrasystoles with palpitations or syncope, heart block with bradyarrhythmia. Chest pain, indicates pericardial involvement, perimyocarditis, acute decompensated congestive heart failure with dilated cardiomyopathy. See symptoms of left heart failure and symptoms of right heart failure. Cardiogenic shock in fulminant cases. Auscultation findings. Copyright brief systolic murmurs. Copyright heart failure, S3 and S4 gallops. Copyright pericarditis, pericardial friction rub sent in infants and young children, poor feeding, irritability, respiratory distress, and failure to thrive. Add, the clinical manifestation of myocarditis is heterogeneous and nonspecific, ranging from asymptomatic courses to fulminant cardiac decompensation. References, 3IL5. YOE. Diagnostics. Approach L721. Sent obtain a minimal diagnostic workup for all patients. Copyright 12 lead ECG. Copyright routine laboratory studies. OTTE. Sent consider indications for. Copyright additional laboratory studies. O advanced imaging. Copyright endomyocardial biopsy. Registered suspect myocarditis in patients without risk factors who present with chest pain, arrhythmias, and/or heart failure not explained by another disease. 12 lead ECG/721. ECG findings in myocarditis are often abnormal but nonspecific, and may include 1. Sent sinus tachycardia. Arrhythmias. O frequent atrial or ventricular premature beats. Copyright supraventricular arrhythmia, example atrial fibrillation. Copyright ventricular arrhythmia, example ventricular fibrillation. Conduction abnormalities, example AV block, Bundle Branch Block 1 asterisk repolarization abnormalities 1 copyright nonspecific ST segment changes copyright diffuse, concave ST elevations, 1, IS copyright T-wave changes, example. T-wave inversion low QRS voltage due to pericardial effusion or myocardial edema sent abnormal Q waves. TTETT, SEESOS ta het AEOT as ETPs I port, Fed MOS SSB. Laboratory studies, 7 ll. Obtain routine studies for all patients. Sent routine studies copyright. Cardiac biomarkers equals CK, CKMB equals troponin T, troponin equals BNP and T progno T ESRCRP. Back collapse find text outline. Laboratory studies, IL sent L. Obtain routine studies for all patients. Sent routine studies degree 1 cardiac biomarkers equals CK, CKMB equals troponin T, troponin BNP and T progno T ESRCRP copyright CBC, leukocytosis. Imaging 7 9 10. Initial imaging. Sent X-ray and/or CT chest copyright commonly ordered to evaluate chest pain, not specifically indicated for the evaluation of myocarditis. O findings are nonspecific, example cardiac enlargement, pulmonary edema, pleural effusions. Sent echocardiography copyright obtained for all patients with suspected myocarditis. Copyright supportive findings equals global or regional wall motion abnormality, systolic or diastolic, equals reduced ejection fraction equals ventricular dilation equals increased wall thickness equals pericardial effusion equals complications, example endocavitary thrombus copyright may also identify alternative non-inflammatory causes of acute heart failure, example valvular dysfunction. Advanced imaging, Lilly 7. Cardiac MRIO may be used in stable patients to equals evaluate for suspected myocarditis equals identify sites for endomyocardial biopsy. O findings equals functional and structural abnormalities similar to TTE findings. Sent coronary angiography, consider in all patients to exclude coronary artery disease. Endomyocardial biopsy, EMB, and LEL 71I11. There is no consensus on when EMB should be performed. Consider in all patients with suspected myocarditis, especially, copyright patients with fulminant myocarditis copyright if results are expected to influence treatment procedure. Cardiac catheterization sample analysis includes, histopathology may show focal necrosis with lymphocytic infiltration. Copyright immunohistology copyright viral PCR 112. BF. Ad. EMB is considered the gold standard test for diagnostic confirmation and can identify the underlying cause of myocarditis. Differential diagnoses. Back. W via collapse. A. Find text. O. Outline. Differential diagnoses. C. Differential diagnosis of chest pain. Sent pericarditis, sent myocardial infarction. The differential diagnoses listed here are not exhaustive. FO, IEEE. Management. Approach 711111218. For hemodynamically unstable patients, see management of fulminant myocarditis. Admit for inpatient management for continuous cardiac monitoring. Start symptomatic treatment as needed. Sent identify and treat the underlying cause. Asterisk recommend avoiding aerobic activity for 3 to 6 months after diagnosis. 1. Symptomatic treatment 11-11-8. Asterisk pain management, reserve NSAIDs for patients with perimyocarditis. 1. Sent management of acute heart failure, management of arrhythmias. Add. Use NSAIDs with caution as they can increase sodium retention, exacerbate renal hypoperfusion, and may increase mortality in patients with myocarditis. 16. Treatment of the underlying cause 111. Scent consider under specialist guidance and tailor to the patient. GI scent treatment may include copyright systemic immunomodulators, example for giant cell myocarditis, cardiac sarcoidosis 1 copyright antiviral therapy O antibiotic therapy, example for Lyme carditis copyright intravenous immunoglobulins. All treatment should be guided by a specialist. WA fate. Is Rod T. Mar. Complications. Progression to dilated cardiomyopathy, 15% of cases, scent heart failure or sudden cardiac death, probably due to ventricular tachycardia or fibrillation, common in adults. OOE. Prognosis. Scent viral myocarditis, most adults make a full recovery, however, progression to dilated cardiomyopathy may occur. 14O however, prognosis is very poor for infants, 75% lethality rate. Copyright lethality rate for children is 25% and another 25% may develop chronic heart failure complications. Scent markers of poor prognosis 5 copyright poor ventricular function, left bundle branch block, low ejection fraction persistent viral genome, in the myocardium, copyright persistent, chronic myocarditis, 9, v. Back collapse fine text outline. Normal myocarditis. Myocarditis inflammation of the myocardium, muscular tissue of the heart. Myocarditis is most commonly caused by a viral, example Coxsackie virus, parvovirus, or bacterial, example B. hemolytic streptococcus group A, infection. Copyright Embark. Uromyocarditis, 1/7. V. Phytic poke Fay copyright. Overlay. ECG in perimyocarditis VV. 12 lead ECG, paper speed, 50 mm/s, sinus rhythm with a heart rate of approximate 80/min. Normal heart axis, RS in both NAVF. Concave ST elevations in, IL, AVF, V5, and V6. Ascending ST elevations in V2 V4. These findings suggest perimyocarditis. Source, copyright IMPP. ECG in, myocarditis VV. 12 lead ECG, paper speed, 25 mm/s. Sinus rhythm, heart rate approximate 65/min, normal heart axis, RSIN and AVF, PR interval duration approximate 120 to 160 milliseconds, narrow QRS complex, approximate 100 milliseconds, concave ST elevations from a descending R wave in leads 2, AVF, and V5 V6, ST elevation, I and V4. Unlike myocardial infarction, perimyocarditis does not manifest with ST elevations that correspond with the anatomy of coronary arteries. Overlay. Bilateral airspace and interstitial disease in acute pulmonary edema VV. X-ray chest, AP view, of a patient with symptoms of acute cardiogenic pulmonary edema extensive airspace disease, indicated by yellow overlay, predominates in the lower and middle zones of both lungs. Fissure thickening, examples indicated by green lines, and curly lines, examples indicated by red lines, are seen. The cardiac silhouette is prominent in the region of the apex, indicated by blue overlay. Source, AP Portable CXR of a patient in acute pulmonary edema by Frank Gaillard, Wikimedia Commons, licensed under CC by SA 3.0. At 17.00 HRS. Overlay. Bilateral airspace and interstitial disease in acute pulmonary edema VV X-ray chest, AP view, of a patient with symptoms of acute cardiogenic pulmonary edema extensive airspace disease, indicated by yellow overlay, predominates in the lower and middle zones of both lungs. Fissure thickening, examples indicated by green lines, and curly lines, examples indicated by red lines, are seen. The cardiac silhouette is prominent in the region of the apex, indicated by blue overlay. Source: AP Portable CXR of a patient in acute pulmonary edema by Frank Gaillard, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Pericardial effusion. Echocardiography, transthoracic, parasternal long axis. The image was taken in ventricular diastole with the mitral valve, M, open. Anechoic pericardial effusion, green overlay, surrounds the heart. LV, left ventricle, RV, right ventricle source, copyright IMPP. Overlay. Pericardial effusion. Echocardiography, transthoracic, parasternal long axis. The image was taken in ventricular diastole with the mitral valve, M, open. Anechoic pericardial effusion, green overlay, surrounds the heart. LV, left ventricle, RV, right ventricle source, copyright IMPP. Myocarditis VV. Thoracic MRI, T2 weighted, with gadolinium contrast, axial section, gadolinium enhancement is visible within the ventricular walls, white arrows, indicating a localized increase in perfusion, vasodilation, caused by myocardial inflammation. Source: Figure 1, typical magnetic resonance imaging image of myocarditis by Yves-Marie Vandeme, Alexandra Ducancella, Loic Beer et al., BMC Research Notes Journal, licensed under CC by 2.0. Myocarditis. Thoracic MRI, T2 weighted, with gadolinium contrast, sagittal section, gadolinium enhancement is visible at the apex of the left ventricle, white arrow, indicating a localized increase in perfusion, vasodilation, caused by myocardial inflammation. Source: Figure 3, T2 weighted contrast enhanced MRI view revealed gadolinium enhancement in the left ventricular wall, especially at the anterior inferior wall of the left ventricle, consistent with myocarditis by HSU Liang Chang, Zhuifeng HSU, Yingming Tsai, Shangyi Lin, Xuanfu Kuo, Qi Zhen Yang, BMC Pulmonary Medicine Journal, licensed under CC by 4.0. Myocarditis, 7/7. T0 IE/3 degrees 08 PS asterisk AA of OE cent equals. Overlay. Lymphocytic myocarditis VV. Photomicrograph of a cardiac tissue autopsy specimen, H&E stain, 200x magnification. A dense lymphocytic infiltrate is visible within severely damaged myocardial tissue. Vacuolization of the cytoplasm indicating cell damage, examples indicated by green overlay, can be seen in some cardiomyocytes, while others show complete cytolysis and infiltration of lymphocytes, single-cell necrosis, example indicated by blue overlay. This histopathological appearance is characteristic of lymphocytic myocarditis, most commonly viral or post-viral, autoimmune. Source: File Viral Myocarditis, 2, by KGH, Wikimedia Commons, licensed under CC by SA 3.0. X. Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, HCM, is a genetic condition characterized by left ventricular hypertrophy that is not caused by other cardiac or causative systemic diseases. Patients can be asymptomatic or have chest pain, dyspnea, dizziness, or syncope. Sudden cardiac death may occur. The diagnosis can be established with a resting ECG and echocardiography. Management for all patients involves lifestyle changes and possibly AICD placement, and for symptomatic patients, medical or surgical therapy is indicated. The goals of therapy are to decrease the heart rate to allow for improved left ventricular filling and to reduce LV outflow tract obstruction. PV0. CE. Definition. Non-obstructive HCM, hypertrophic cardiomyopathy without obstruction of the left ventricular outflow tract, LVOT, SENT hypertrophic obstructive cardiomyopathy, HOCM with left ventricular outflow tract obstruction, LVADO, that is dynamic. See pathophysiology for further details. NA. Epidemiology. SENT second most common cardiomyopathy. SENT two types are distinguished: copyright obstructive type / hypertrophic obstructive cardiomyopathy, HOCM 70% of cases copyright non-obstructive type, 30% of cases alongside myocarditis. HCM is one of the most frequent causes of sudden cardiac death in young patients, especially young athletes. Epidemiological data refers to the U.S., unless otherwise specified. WA. ROSA nates. Etiology. HCM is a genetic condition characterized by otherwise unexplained left ventricular hypertrophy. AIL2 most common hereditary heart disease. Autosomal dominant inheritance with varying penetrance. Copyright most commonly caused by mutations of the sarcomeric protein genes, example myosin heavy chain, myosin binding protein C, disorganization of myocyte architecture characterized by myofibrillar disarray and fibrosis. MYH7 gene on the long arm of chromosome 14 that codes for the beta-myosin heavy chain, which forms a part of type 2 myosin in skeletal and cardiac muscle cells. MYBPC3 gene on the short arm of chromosome 11 that codes for cardiac myosin binding protein C, which prevents the breakdown of thick filaments in cardiac sarcomeres, less commonly due to a mutation in cardiac sarcomeric proteins such as troponin and tropomyosin. SENT other conditions that are associated with left ventricular hypertrophy include the following. Chronic hypertension, most common cause of left ventricular hypertrophy. Degree aortic stenosis. Friedreich ataxia, Fabry disease, Noonan syndrome. Amyloidosis. Pathophysiology. HCM is characterized by hypertrophy of the left ventricle, most commonly occurs with asymmetrical septal involvement, which leads to diastolic dysfunction, impaired left ventricular relaxation and filling, reduced systolic output volume, reduced peripheral and myocardial perfusion. Cardiac arrhythmia and or heart failure and increased risk of sudden cardiac death. 3. A. Non-obstructive and obstructive HCM law. SENT typical features include, copyright increased LV wall thickness with septal predominance, no dilation of left ventricle. Myofibrillar disarray, interstitial fibrosis, and myocyte hypertrophy. Copyright concentric hypertrophy, a form of cardiac remodeling characterized by parallel duplication of sarcomeres that leads to thickening of the ventricular wall. In HOCM, concentric hypertrophy is caused by genetic mutations. See etiology. Concentric hypertrophy can also occur secondary to the following diseases, then potentially mimicking HCM, hypertension and aortic valve stenosis, due to chronic pressure and volume overload. Chronic hypertension increased after load. Increased myocardial wall tension. Changes in myocardial gene expression. Sarcomeres laid down in parallel. Increased left ventricular thickness. Decreased left ventricular size. Diastolic dysfunction. Storage disorders, example Fabry disease, amyloidosis, and hereditary syndromes, example Friedreich ataxia, Noonan syndrome. We. HOCJII5. Pathomechanism, LVOT obstruction. Increased LV systolic pressure. Prolongation of ventricular relaxation. Increased LV diastolic pressure. Exacerbation of HCM with further reduction of cardiac output. Mechanisms of obstruction. Copyright systolic anterior motion, SAM, of the mitral valve, results in mitral septal contact during mid to late systole, caused by either or both, Venturi effect. Accelerated blood flow through ventricular outflow tract creates negative pressure that pulls The mitral valve towards the septum increased outflow tract obstruction equals ejection against an elongated and distorted mitral valve causes leaflets to get pulled into the outflow tract. Potential secondary mitral regurgitation LJO muscular obstruction equals encroachment of the LVOT by the hypertrophic septum hypertrophy or anomalous insertion 1 of papillary muscles increased left ventricular apical pressure 7 risk for development of apical ventricular aneurysms. Sent LVOT obstruction is dynamic. Copyright the following factors can increase the degree of obstruction: TLV contractility, preload and afterload. For copyright clinically exacerbating factors equals physical exercise / stress equals dehydration. Pharmacologic provocation, example diuretics, acyl / ARBs, digoxin, hydralazine, equals Valsalva maneuver, strain phase. AI and clinical features. Sent symptoms, worsen with exercise, dehydration, and use of certain drugs, example diuretics, hydralazine, acyl / ARBs, digoxin. 6. Frequently asymptomatic, especially the non-obstructive type, degree exertional dyspnea. Copyright angina pectoris 1 degree dizziness, lightheadedness, syncope palpitations, cardiac arrhythmias. Sudden cardiac death, particularly during or after intense physical activity. Sent physical examination 6 copyright systolic ejection murmur, crescendo decrescendo, 1. Equals increases with Valsalva maneuver, standing, inotropic drugs, example digitalis, equals decreases with, equals hand grip, squatting, or passive leg elevation equals drugs that decrease cardiac contractility, example beta blockers. Copyright possible hollow systolic murmur from mitral regurgitation. Sustained apex beat. $4 gallop degree paradoxical split of S2, pulsus bisferens. LV outflow obstruction causes a sudden quick rise of the pulse followed by a slower longer rise, biphasic pulse. Equals, A. Add, HOCM is an important cause of sudden cardiac death in young patients. WA. CE. Diagnostics. Echocardiography is the best initial and confirmatory test. Other investigations, example ECG, CXR, cardiac MRI, exercise testing, and screening for coronary artery disease or genetic diseases, can be done on a case-by-case basis. Transthoracic echocardiography with Doppler, *1. Sent indications. Copyright initial assessment of patients with suspected HCMO. Repeat testing in patients with a new cardiovascular event or change in clinical status plus findings in patients with HCMO. Wall thickness asymmetrically thickened left ventricular wall, equals 15 mm, typically involving the septum. YC cyto LV wall thickness equals 30 mm is associated with a high risk of sudden death. 5. Copyright outflow tract abnormalities. Systolic anterior motion of the mitral valve, 1, 79, mitral regurgitation. TLVOT pressure gradient via Doppler echocardiography. Sent findings more specific to HOCMO. Asymmetrically thickened interventricular septum. Copyright dynamic LVOT obstruction due to contact between the septum and mitral valve during systole. ECG findings in HCM. Copyright sent indication, all patients with suspected HCM. Sent classic findings, commonly seen in obstructive HCM. Copyright ECG signs of LVH, see Sokolow-Lyon criteria, O deep Q waves, particularly in the inferior, 2, IL, and AVF, and lateral, I, AVL, V46, leads. Copyright giant inverted T waves in the precordial leads. 11. Sent other supportive findings. Copyright nonspecific ST segment and T wave changes. 71. OP wave changes indicating left atrial enlargement, example P mitral, 2111. OLBBBI. Sent associated dysrhythmias, ventricular tachycardia, atrial fibrillation, or atrial flutter. Registered and normal ECG should prompt further evaluation, as it is only seen in 5 to 10% of cases. 11. Chest X-ray. Plus indication, considered for patients presenting with dyspnea or chest pain of unknown etiology. 4 suggestive findings. Copyright: the heart can be normal or enlarged. Left atrial enlargement is commonly seen in mitral regurgitation. Copyright: possibly signs of pulmonary congestion, example pulmonary edema, in severe forms of CHF. Exercise testing. 5. Provocation tests, example exercise testing, are obligatory if no obstruction is discernible at rest. J+ exercise echocardiography, asterisk. Copyright indications, to confirm and quantify dynamic LVOT obstruction in patients with inconclusive TTE. 5 Copyright findings, LVOT obstruction and/or mitral regurgitation plus treadmill exercise testing. 5, WV. Back collapse. Fine text outline. Sent treadmill exercise testing. WI. Copyright indications, assessment of functional capacity and response to therapy, addition of ECG and blood pressure monitoring for SCD, risk stratification. Copyright findings asterisk. Clinical observation for development of symptoms, example dyspnea, palpitations, equals blood pressure monitoring, hypotension, equals ECG tracings with arrhythmias and/or signs of ischemia. Cardiac MRI, CMRI. Asterisk indications. Evaluation of ventricular morphology if echocardiographic findings are inconclusive. Copyright patients with known HCM if additional findings in MRI may require a change in management approach. Additional studies. Sent genetic testing and family screening. All patients should be assessed for familial inheritance and receive genetic counseling. 5e assessment for coronary artery disease. Copyright indicated for patients with chest discomfort for whom a diagnosis of CAD would impact HCM management. 5. Copyright includes coronary angiography with levocardiography. WA. OE. Treatment. All patients. 715. Lifestyle changes. Avoidance of dehydration. Scent maintaining a healthy body weight. Scent avoidance of excessive alcohol intake. Avoidance of strenuous exercise and situations that will likely cause vasodilation, example environmental factors such as high temperatures. Automated implantable cardioverter defibrillator, AICD. An AICD is considered for primary or secondary prevention of sudden cardiac death, SCD, in patients who are at high risk. Sent absolute indication, known prior history of ventricular fibrillation, sustained ventricular tachycardia, or cardiac arrest. Sent relative indications. Syncope of unknown cause. Copyright family history of SCD in a first degree. Relative copyright LV wall thickness equals 30 mm. Sent risk stratification, for sudden cardiac death, example documented NSVT. Symptomatic patients, 725. The goal of treatment is to alleviate the symptoms of HCM, by slowing the heart rate. Recommended pharmacotherapy, 131I14. Sent initial therapy, for all symptomatic patients with obstructive or non-obstructive HCM. First line, beta blockers. Second line, non-dihydropyridine CCBs equals. Consider in patients who do not tolerate or respond to beta blockers. Verapamil is preferred, but should be avoided if there is hypotension or dyspnea at rest. 0. These medications should be used with caution due to their potential for provoking dysrhythmias, E.G., AV block, QT prolongation, and worsening LVOT obstruction in specific situations, example hypovolemia. Cardiology consultation is advised. Pharmacotherapy to avoid. The following are relative contraindications and may not apply to all patients, example those with acute complications such as heart failure or atrial fibrillation. Medications to be avoided in LVOT obstruction. Copyright high-dose diuretics equals, A. Rhophic cardiomyopathy. All patients, 725. Lifestyle changes. Scent avoidance of dehydration, scent maintaining a healthy body weight, scent avoidance of excessive alcohol intake, avoidance of strenuous exercise and situations that will likely cause vasodilation, example environmental factors such as high temperatures. Automated implantable cardioverter defibrillator, AICD. An AICD is considered for primary or secondary prevention of sudden cardiac death, SCD, in patients who are at high risk. Scent absolute indication, known prior history of ventricular fibrillation, sustained ventricular tachycardia, or cardiac arrest. Scent relative indications, copyright syncope of unknown cause, copyright family history of SCD in a first degree, relative OLV wall thickness equals 30 mm, risk stratification, for sudden cardiac death, example documented NSVT, 1 symptomatic patients, 725I. The goal of treatment is to alleviate the symptoms of HCM1 by slowing the heart rate. Recommended pharmacotherapy, 13 Li 14. Scent initial therapy, for all symptomatic patients with obstructive or non-obstructive HCMO. First line, beta blockers. Copyright second line, non-dihydropyridine CCBs equals consider in patients who do not tolerate or respond to beta blockers equals verapamil is preferred, but should be avoided if there is hypotension or dyspnea at rest. Copyright these medications should be used with caution due to their potential for provoking dysrhythmias, E.G., AV block, QT prolongation, and worsening LVOT obstruction in specific situations, example hypovolemia. Cardiology consultation is advised. Pharmacotherapy to avoid. The following are relative contraindications and may not apply to all patients, example those with acute complications such as heart failure or atrial fibrillation. Asterisk medications to be avoided in LVOT obstruction, copyright high-dose diuretics, copyright digoxin, copyright spironolactone. Positive inotropic and after-load-reducing or pre-load-reducing drugs, example digoxin, nitrates, dihydropyridine CCBs, ACELs, are contraindicated in patients with obstructive HCM. Invasive therapy. These are generally indicated for symptoms that are refractory to medical therapy. Scent septal reduction therapy, copyright indication, severe symptoms, example dyspnea or chest pain, often NYHA 3 or 4, exertional syncope or presyncope, due to LVOT obstruction, LVOT gradient equals 50 mmHg, 20 O procedures. Surgical septal myectomy, MARO procedure, is preferred for most patients, involves thinning the hypertrophic muscular intraventricular septum to widen the left ventricular outflow tract equals transcoronary ablation of septal hypertrophy, alcohol septal ablation, when surgery is considered too high risk or is contraindicated. Scent dual chamber pacemaker, consider for patients who are poor candidates for septal reduction therapy. Scent heart transplant, consider in end-stage non-obstructive HCM when LVEF. OOCE. Related 1-minute telegram. Scent 1-minute telegram 76-2023-2/3, hypertrophic hearts can still flex. Interested in the newest medical research, distilled to just 1 minute? Sign up for the 1-minute telegram in the tips and links below. DSA. Eurohypertrophic cardiomyopathy, 1/3. Myofibrillar disarray. Photomicrograph of myocardial tissue, H&E stain, high magnification. There is loss of the normal striated histological architecture of myocardial tissue, with most of the cells arranged in swirls or clusters, myofibrillar disarray. Myofibrillar disarray is seen in a number of diseases, including hypertrophic obstructive cardiomyopathy. Source, file, HCM__he.jpg by number 275, Wikimedia Commons, licensed under CC by SA 3.0. Equals hypertrophic cardiomyopathy, 2/3. Copyright overlay. Concentric hypertrophic cardiomyopathy. For transverse slices of the heart there is concentric hypertrophy, indicated by arrows, of the left ventricular myocardium, green overlay, which has narrowed the lumen, red overlay, and caused a reduction in the intraventricular volume. Source: Hypertrophic cardiomyopathy, concentric by Zorkin, Wikidoc, licensed under CC by 3.0. Hypertrophic cardiomyopathy, 3/3. Hypertrophic cardiomyopathy. Heart, transverse section, the myocardium of the left ventricle appears hypertrophic with no chamber dilation visible. Source: Figure 5. Cross-section of the heart at the ventricular level, in, case February 2016, 76-year-old male with hypertensive heart disease, renal tumor, and shock by Marcella and Hezini Benetti, Rafael Emerim Belo Nunes, and Luis Alberto Benvenuti, Arquivos Brasileiros de Cardiologia, licensed under CC by 4.0. Hypertrophic cardiomyopathy, 1/2. Eccentric concentric. Left decreased increased ventricle wall thickness right ventricle. Ventricular enlargement diminution. Sarcomere duplication of sarcomeres in series duplication of sarcomeres in parallel width SS a length. Eccentric versus concentric ventricular hypertrophy VV. Copyright Embark. Hypertrophic cardiomyopathy, 2/2. Normal hypertrophic cardiomyopathy. Left ventricular outflow tract, LVOT, obstruction due to interventricular systolic anterior septum motion, SAM, hypertrophy of the mitral valve. Hypertrophic cardiomyopathy. Hypertrophy of the myocardium results in reduced diastolic compliance and filling of the left ventricle, sometimes also of the right ventricle. Hypertrophic cardiomyopathy can occur with or without left ventricular outflow tract obstruction. Hypertrophic obstructive cardiomyopathy, HOCM, occurs when hypertrophy of the interventricular septum and systolic anterior movement, SAM, of the mitral valve leaflet results in the left ventricular outflow tract, LVOT, obstruction. Copyright Embark. Hypertrophic cardiomyopathy, 1/1. EASSXA electrocardiogram, ECG. OLSCSLY no. Heart murmur in hypertrophic obstructive cardiomyopathy, aortic stenosis, and pulmonary stenosis. A crescendo-decrescendo late systolic murmur is depicted. In the case of aortic stenosis, the murmur may radiate to the carotid arteries. Copyright Embark. Hypertrophic cardiomyopathy, 1/5. Overlay. Hypertrophic cardiomyopathy V. Transthoracic echocardiogram, apical 3-chamber view, the walls of the left ventricle are asymmetrically hypertrophied. Compared to normal findings, green dashed outline, the interventricular septum, red overlay, is markedly thickened, green arrows. The lateral wall is also thickened, but not to the same extent as the interventricular septum. These findings are suggestive of hypertrophic cardiomyopathy. To assess for left ventricular outflow tract, LVOT, obstruction, the LVOT pressure gradient during systole should be measured. LW, lateral wall, LV, left ventricle, IVs, interventricular septum, MV, mitral valve, AV, aortic valve, LA, left atrium source, Fig 1, in. The role of echocardiography for diagnosis and prognostic stratification in hypertrophic cardiomyopathy by Mondes L., Rosca M., Psy D., Popescu B.A., Journal of Echocardiography, licensed under CC by 4.0. Modifications, cropped image, removed letter, added illustration. Hypertrophic cardiomyopathy, 2/5. AE on A. Co 700ALALI do AEUEGAE po titenis RAA. VEAEAESEETASGDAEA. OETT1 EP Cande UTNNSSSEFERS ABE PECEEIL POPE NNEA HASEEKD Dine A. Overlay. ECG in left ventricular hypertrophy VV. 12 lead ECG, paper speed, 25 mm/s, heart rate, 55/min regular sinus rhythm normal cardiac axis, positive, plus, QRS complex polarity in leads, IL, and IL broad and bifid P waves, P referred to as P mitral and suggestive of left atrial enlargement SY2, S, plus RIS, R, greater than 3.5 mV, meets Sokolow-Lyon criteria for left ventricular hypertrophy left ventricular strain pattern, ST depression, ST, with T wave inversion, T, in left-sided leads and V4-V6 positive Sokolow-Lyon. Criteria and left ventricular strain pattern are characteristic of left ventricular hypertrophy. Source, copyright IMPP. Hypertrophic cardiomyopathy, 3/5. Overlay. Left ventricular hypertrophy and left bundle branch block VV. 12 lead ECG, paper speed, 25 mm/s. Sinus rhythm, heart rate, 70/min, right axis deviation, RS in AVF, premature ventricular complexes, circled in red, broad QRS complexes, 180 milliseconds, with left bundle branch block morphology, left ventricular strain pattern, ST depression with T wave inversion in the left precordial leads V5 and V cent, also present in IL, IL, and AVF, positive Sokolow-Lyon criteria, SY, or 2 plus RIS or 6 equals 3.5 mV, red arrows. Positive Sokolow-Lyon criteria and the left ventricular strain pattern are characteristic of left ventricular hypertrophy. Eurohypertrophic cardiomyopathy, 4/5. Copyright overlay. Symmetric hypertrophic cardiomyopathy VVMR cardiac, Cine sequence, 2-chamber view, A, diastole, B, systole, there is symmetric hypertrophy of the left ventricular wall, green overlay. Reduction in size of the left ventricular cavity is accentuated in systole. Source, Figure 3, in Cardiac Magnetic Resonance and Computed Tomography in Hypertrophic Cardiomyopathy, an update by Oliveira DC, Asungeo FP, Santos A, Nasif MS, Silo, licensed under CC by 4.0. Eurohypertrophic cardiomyopathy, 5/5. Hypertrophic cardiomyopathy VV. MRI cardiac, left, T1 weighted black blood turbo spin echo sequence, right, T1 weighted inversion recovery 3D fast gradient echo sequence, short axis, there is hypertrophy of the left ventricle, especially the septum, left, which shows a maximum thickness of 17.3 mm, normal. X infective endocarditis. Infective endocarditis, i.e., is an infection of the endocardium that typically affects one or more heart valves. The condition is usually a result of bacteremia, which is most commonly caused by dental procedures, surgery, distant primary infections, and non-sterile injections. IE may be acute, developing over hours or days, or subacute, progressive over weeks to months. Acute bacterial endocarditis is usually caused by Staphylococcus aureus and leads to rapid destruction of endocardial tissue, while subacute bacterial endocarditis is most commonly caused by viridans streptococci and generally affects individuals with pre-existing damage to the heart valves, structural heart defects, or prosthetic valves. Clinical features include constitutional symptoms, fatigue, fever/chills, malaise, signs of pathological cardiac changes. Example: new or changed heart murmur, heart failure signs, and, in some cases, manifestations of subsequent damage to other organs, example glomerulonephritis, septic. Embolic stroke. Management is complex and infectious disease specialists should be involved early. Diagnosis is made based on the Duke criteria, the main features of which are positive blood cultures and evidence of endocardial involvement on echocardiography. Initial treatment of IE consists of empiric 4 antibiotics, which are then adapted according to blood culture results and continued for several weeks. Categorization into native valve endocarditis or prosthetic valve endocarditis helps to further tailor regimens. Surgery may be necessary in complex cases, example valve perforation. IE prophylaxis is administered in specific circumstances, example in patients with congenital heart disease having certain dental procedures. IE is typically fatal if left untreated. OOE. Etiology. Pathogens. Pathogen infecti diseases, i.e., main pathogens characteristics. Approximately 35 to 40% of native valve IE cases NL most common cause of acute IE, including persons who inject drugs and patients with prosthetic valves or pacemakers/ICDs. 2I3 typically affects healthy valves. Usually fatal within 6 weeks if left untreated. Staphylococcus aureus. Approximately 20% of native valve IE cases IU most common cause of subacute IE, especially in predomagate native valves, mainly the mitral valve, common cause of IE following dental procedures, respiratory tract incision and biopsy produce DEX strands that facilitate binding of fibrin platelet aggregates on heart valves. Viridans streptococci. Less than 15% of native valve IE cases Staphylococcus epidermidis bacteremia from infected peripheral venous catheters, common cause of subacute IE in patients with prosthetic heart valves, pacemakers, or ICDs. 4. Approximately 10% of native valve IE cases FL multiple drug resistance. 5. ELEI pound, lick, common cause of IE following nosocomial UTIs. 1 causes native and prosthetic valve IE following gastrointestinal or genitourinary procedures. Less than 15% of native valve IE cases, 1 Galloli subsp Gallolyticus, SGG, 1 I associated with colorectal cancer. 6 If SGG is detected, colonoscopy is indicated. Less than 5% of native valve IE cases L physiological oral pharyngeal flora in patients with poor dental hygiene gram-negative HASIC group, and/or peri. Less than 5% of native valve IE cases at risk groups degree, example patients with HIV or organ transplantation, copyright persons who inject drugs patients who have received cardiosurgical interventions. Fungal endocarditis, Candida, Aspergillus fumigatus, ILS. Copyright patients with long-term indwelling 4 catheters. 9. Coxella burnetii I. Less than 5% of native valve IE cases I. Bartonella species gram-negative pathogens responsible for culture-negative endocarditis. Risk factors for infective endocarditis. 4 I1 I101. Scent demographics. O male sex. O age 60 years. Scent cardiac conditions. O acquired valvular disease, example rheumatic heart disease, aortic stenosis, degenerative valvular disease. O prosthetic heart valves. Copyright congenital heart defects, example VSD, bicuspid aortic valve. O previous IE. Copyright cardiac implantable electronic device, CIED. 4. A. Back collapse. Fine text outline. Scent non-cardiac risk factors. Poor dental status. Dental procedures. Non-sterile venous injections, example in 4 drug use, intravascular devices. Surgery. Chronic hemodialysis. Immunocompromise, example HIV infection, diabetes, other bacterial infections, example UTIs, spondylotischitis, periodontal infection. Copyright 0. Copyright 0. Copyright 0. Degree. S. Ronfo. Pathophysiology. Asterisk pathogenesis. 1. Damaged valvular endothelium. Exposure of the subendothelial layer. Adherence of platelets and fibrin. Sterile vegetation, microthrombus. 1. 2. Localized infection or contamination, bacteremia, bacterial colonization of vegetation, formation of fibrin clots encasing the vegetation, valve destruction with loss of function, valve regurgitation. 2, 11. Asterisk valve involvement, 0 frequency of valve involvement, mitral valve, aortic valve, tricuspid valve, pulmonary valve. Copyright. The tricuspid valve is the most commonly affected valve in persons who inject drugs, associated with Pseudomonas, S. aureus, and Candida. Asterisk clinical consequences, 1 ll1. O. Bacterial vegetation, bacterial thromboembolus, vessel occlusion, infarctions. O. emboli can lead to metastatic infections of other organs. Copyright. Formation of immune complexes and antibodies against tissue antigens, glomerulonephritis, oscillar nodes. And don't try drugs for the sake of your tricuspid valves. Constitutional symptoms, 12-1. Scent fever and chills, scent tachycardia, scent general malaise, weakness, weight loss, night sweats, scent dyspnea, cough, pleuritic chest pain, arthralgias, myalgias. Cardiac manifestations, 12-1. Scent development of a new heart murmur or change in a pre-existing murmur. Copyright. Tricuspid valve regurgitation, hollow systolic murmur that is loudest at the left sternal border, seen in persons who inject drugs, immunocompromised individuals, patients with congenital heart disease, and patients with instrumentation in the right heart, example central venous catheters. 2. Copyright. Aortic valve regurgitation, early diastolic murmur that is loudest at the left 3 feet 4 inches and 4 intercostal spaces and along the left sternal border. 4. Copyright. Mitral valve regurgitation, hollow systolic murmur that is loudest at the heart's apex and radiates to the left axilla. Scent heart failure, example dyspnea, lower limb edema, due to valve insufficiency plus arrhythmias. Suspect a paravalvular abscess in patients with IE who develop a new conduction abnormality, example heart block. J4 equals A. Tiv endocarditis. Extracardiac manifestations of IE, 2I1. Extracardiac manifestations are typically caused by septic microembolus and or immune complex precipitation and are more commonly seen in left-sided IE, with the exception of pulmonary embolic manifestations, which are more common in right-sided IE. ST1 plus peripheral embolic and immunologic phenomena, seen in only 5 to 10% of patients. 5 IL1. Opatechiae, especially splinter hemorrhages, hemorrhages underneath fingernails, LO Janeway lesions equals small, non-tender, erythematous macules on palms and soles equals microabscesses with neutrophilic capillary infiltration and areas of hemorrhage caused by septic microembolus from valve vegetations. O. Oscillar nodes, painful nodules on pads of the fingers and toes caused by immune complex deposition. S. Copyright. Roth spots, round retinal hemorrhages with pale centers, sent emboli to intra-abdominal organs. O. Acute renal injury equals including hematuria and anuria equals due to renal artery occlusion or glomerulonephritis. O. Splenomegaly and possible LUQ pain equals due to splenic artery occlusion or splenic abscess. Asterisk may lead to splenic rupture. 61. Scent neurological manifestations, example seizures, paresis due to septic embolic stroke, hemorrhage, meningitis, encephalitis, and or abscess. Scent pulmonary manifestations, caused by septic emboli resulting from tricuspid valve involvement. Copyright. Signs of pulmonary embolism, example dyspnea. Copyright. Signs of pulmonary infection, example multifocal pneumonia, lung abscess, and or empyema. 19. Scent others, arthritis. J. Ad. IE should always be considered as a cause of fever of unknown origin, FUO, especially in the presence of a new heart murmur. And from Jane. Features of IE include fever, Roth spots, oscillar nodes, murmur, Janeway lesions, anemia, nail bed hemorrhage, and emboli. Classification. EIE can be classified by copyright type of affected valve, native versus prosthetic, copyright acuity of the infection, copyright location of the infection, left versus right-sided. Although this is not a definitive classification system, it can help in the approach to management and selection of empiric antibiotic regimens. Classification by valve type and duration of infection. Classified by type of valve involved and clinical course. 15 Native valve endocarditis VIC valve acute bacterial endocarditis subacute bacterial endocarditis insidious onset sent acute onset clinical S equals asterisk slow progression weeks to months asterisk early onset 1 year after surgery sent severe constitutional symptoms example high fever X 3 fever malaise chills dyspnea back pain, weight loss. Asterisk most common, S. aureus, associated with large asterisk viridans streptococci plus early onset, coagulase negative staphylococci, S. main vegetations that can destroy the valves, 1 asterisk S. aureus aureus, or gram-negative bacilli, most common, 5 pathogens equals. Others, group A hemolytic streptococci, enterococci late onset, coagulase negative staphylococci, S. aureus, S. pneumoniae, and gonorrhoeae Hasek viridans group streptococci, most common, 5. Mechanical valves bioprosthetic valves affected valves sent healthy native valves with prior injury or congenital defects. Classification by location. Classified by ion of valves IA right-sided endocarditis 20 left-sided endocarditis, 15 equals A. OE classification by location. Classified by location of valves involved. Right-sided endocarditis 291 left-sided endocarditis, 15. Bacterial thromboembolus to pulmonary vasculature, example due to lung abscess, pulmonary embolism, 1 distinguishing clinical features of right heart failure, example peripheral pitting edema, abdominal pain features from hepatic congestion. Emboli to systemic vasculature, see extracardiac manifestations in clinical features. Clinical features of left heart failure, example dyspnea, pulmonary edema, often associated with venous instrumentation, example LV drug use, indwelling venous catheters. S. aureus, MSSA more often than MRSA, streptococci coagulase negative staphylococci. S. aureus viridans group streptococci community acquired enterococci main pathogens. Asterisk tricuspid sent mitral protected valves asterisk pulmonic sent aortic. OEA. CE. Diagnostics. Approach, 151-21. Sent suspect i.e. based on clinical findings, example fever without focus combined with a new murmur, and predisposing conditions. Sent the modified Duke criteria help categorize the diagnostic likelihood of i.e. definite versus possible. 6. Asterisk all patients should receive multiple blood cultures and echocardiography. 1. At draw 3 sets of blood cultures, each from a different venipuncture site, as soon as IE is suspected, preferably before antibiotic treatment is initiated. Modified Duke criteria 221I15 2 cent L criteria findings. Positive blood cultures, any of the following copyright